Okay, good morning. It's great to see everyone here. This has been a long time coming, and we're really excited about the turnout we've had this morning. So I'm Sandesh Dave. I'm the Director of Cardiovascular Projects at the Institute for Future Health. And I want to thank our co-chairs, Janice Guzman and Chris Vijay. And this, this idea started this summer, and the idea was for a local event to really start talking about cardiac amyloidosis. And it really has blossomed into, I would say, a regional and perhaps even national event. We have really a full audience here today, and we also have around 100 people or more on Livestream. And we have a great representation from all the Valley institutions, which I think is really encouraging. And hopefully it'll be the first of many events where we can engage our community here in Arizona on this important topic. I wanted to thank our sponsors. This was supported by an independent education grant from Pfizer. We also have support from Alnylam, the American College of Cardiology, Arizona, and the Institute for Future Health, a joint venture of ASU and University of Arizona. I also want to thank some of our out-of-town attendees. Raise your hand if you're from out of town. Okay. We have a pretty packed agenda this morning, and so we're going to take questions during the panel discussion, but feel free to put your questions into the YouTube chat, whether you're in the room or you're on live stream. And if you do have a question on live stream, please write question, and if you have a particular person you're addressing it to, go ahead and put their name. We'll have a coffee break at 9:50 and lunch at 12:15. If you'd like CME credit for in-person attendees, we'll send a survey at the end of the meeting. And now I'd like to introduce my co-chair, Dr. Chris Vijay. Dr. Vijay has been really instrumental in helping organize this event, and he's multi-talented physician. He's qualified in endocrinology, nephrology, lipidology, and heart failure. And he runs a nonprofit for the Tibetan community in India. And without further ado, Chris, I'd like you to introduce our moderators for this morning.
Thank you, Sandesh. Can you all hear me? Loud and clear? Okay, good morning. Thanks, Sandesh. Sandesh has done a fantastic job in putting it together along with the team. Janice, April, where are you? Without you, this wouldn't be possible at all. And thank you for really doing a phenomenal job. And we're excited about the program. Clearly, I think this is a very unique opportunity for us to come together for the greater good of the community, of our patients, right? That's what we strive to do every day, to make sure that if I was a patient today or tomorrow, yes, I would like to know, earlier to detect the disease and then hopefully make an impact with therapeutic strategies and then really have a good outcome. So we're all in the same boat. And to that end, I believe that today is a very important day. And I'm really honored and excited to have great speakers, great agenda, great moderators. So then let's start off with the moderator introduction. Let's go with Dr. Michael Castro. Please, when I call you, please call upon you, come to the stage. Michael Castro is a great friend of mine. I've known him for 25 years. I've been in the Valley here for almost 33 years. I've known him as long as he's been here, and he's one of the finest internal medicine practicing doctor, both clinical as well as research and in teaching. He's also a gerontologist. He's done multiple research projects, and more recently he's done some research with me utilizing technology to actually make a better patient outcome utilizing virtual reality and immersive technology, and he was the principal investigator. We just presented at the Cardiometabolic Health Congress in Boston that Michael presented recently. So he's done some great work, and so honored to have him here. He's also the Associate Program Director for Internal Medicine Program at Abrazo, and such an honor to have you here, Michael. Welcome. And let's, Janice, where are you? Janice Guzman, I'd like to welcome another co-moderator. Janice is again, a gerontological nurse practitioner based in Tucson. She told me that she's based in Tucson, and I heard she's baked in Tucson. I said, okay, we're all baked somewhere or the other, but truly, she's an amazing nurse practitioner who's doing some good work, both in clinical setting, as well as doing some very fascinating research. She's actually doing something interesting. She's doing research in remote patient monitoring in veteran population in Tucson at the VA in heart failure. So it's going to be something very different and unique, and see whether we can actually make a better impact on patient outcomes. So again, welcome, Janice, and again, thank you all for coming. I'm going to now hand over to Sandesh to introduce George, and then we'll kick off the meeting. Thank you all for coming.
Okay, I hope you have a large glass of tea. I have 32 pages of Dr. Post's resume to cover. But some of the brief highlights are Dr. George Post is a Regents Professor and Dell Webb Chair in Health Innovations, Chief Scientist of the Complex Adaptive Systems Initiative. From 2003 to 2009, he built the Biodesign Institute at ASU. And since January 21, he assumed leadership of the Institute for Future Health, a joint venture of ASU and U of A. And he's my boss. From 1992 to 1999, he was the Chief Science and Technology Officer at SmithKline Beecham, now GlaxoSmithKline. And he was also awarded the rank of Commander of the British Empire by Queen Elizabeth II for contributions to research and international security. I think the thing I most admire about George actually is his ability to tell great stories and to integrate knowledge from so many disciplines. So without further ado, I'd like to welcome you, George, Commander.
Well, good morning, everyone. Thank you for taking time from your busy schedules to come on a Saturday. And I hope what we will see emerge throughout this meeting is not only the conceptual framework for the evolving framework for treating this disease, but a greater recognition of this disease and the impact for patients, but a full recognition, very much consistent with my role as director of the Institute for Future Health, was building very large-scale programs and collaboration between institutions. And I say that as the only non-cardiologist in the session, and since the clicker doesn't work, I'm going to have to ad-lib here for some reason, but it's completely dead. Where's the sensor? Okay, great, thank you. Still not working. Anyway, let me, the easiest thing is to get notes and do an ad-lib. So clearly there are going to be a number of consistent themes throughout this meeting, but we obviously start with the fact that this is a disease which is under-recognized and therefore under-treated. Prevalence is clearly higher than has been recognized hitherto. As a consequence of that, there's often an unacceptably long interval between the time a patient first presents and a definitive diagnosis occurs, and in that interval, a substantial utilization of essentially futile cost before that diagnosis occurs. The prognosis is unfortunately a dire one, as this audience certainly knows. More recently, we've of course seen the option for new therapies, new therapeutics, whether it be for cardiomyopathy or polyneuropathy. But by definition, as in most disease states, earlier detection actually facilitates effective outcomes. We're having some problems here. And I think just one of the sort of simple vignette to show the interest in this subject is simply just the rapid growth in both publications and the references specifically in the last few years to therapeutic intervention. Data is, however, still fragmented. That's not unique in medicine, but certainly the data from Arizona against those particular parameters is still a limited data set. And to the third bullet there, we have very limited data on our Hispanic population and certainly virtually no information on our Native American populations. And still most of the data is coming from highly specialized centers such as the ones that you all work in. The clear issue has been, most importantly, a transition from invasive endomyocardial biopsy to scintigraphic imaging. But at the same time, with the increased prevalence of this disease, who do you actually then refer to a scintigraphic workup? And we've seen the evolution of a series of risk scores evolving any one of a number of the parameters which are listed there put together. And with the reach of machine learning and artificial intelligence into many domains of medicine now, applying those types of deep learning tools to these multi-parameters does actually help in a much more important selection, but at the same time there's a need to still validate these evolving test scores, risk scores across the spectrum of the disease. Obviously, one goal certainly shared by this audience is to increase the recognition and awareness beyond the specialized amyloid centers. There is a paucity of biomarkers, which is probably the biggest single area of research opportunity, particularly if you could migrate biomarker discovery into easily sampled biospecimens such as blood and urine, because that would then clearly expand the opportunity to do cost-effective screening for earlier detection. At the same time, rigorous diagnostic biomarker capabilities would, if you had those that could also prognose and predict any progression from polyneuropathy to cardiomyopathy, biomarkers as in other areas of medicine to monitor therapeutic efficacy, disease progression monitoring, and the low-cost issue permitting you to screen asymptomatic hereditary variant ATTR cohorts for late onset disease due to the incomplete penetrance of variants in different cohorts. We're still having problems here, April. Could someone else advance the slides for me? Won't do it off the keyboard either. Then, of course, in the treatment domain, there is still the unresolved issue is efficacy greater for the thyretin stabilizers versus the silencers, proposals with regard to the use of combination therapeutics, and this, of course, applies in so many areas now. One in which I spend a great deal of time is immunotherapy in cancer, where combination therapies are increasingly the norm, but at the same time, what sequence do you give those agents? What is the unit dose titration? And then the point which is going to come up in a moment, well known to this audience, is the fact that the extravagantly high cost of the agents in this arena is certainly problematic. Another issue which we will eventually wrestle with is, are there thresholds for irreversible progression which would predict lack of RX efficacy? And that leads, of course, to the grand challenge question of is this cardiomyopathy reversible? Will that actually then require a new category of myofibril clearance agents? Next slide, please. So, of course, this is the issue I touched on a moment ago. The high annual cost of approved therapeutics ranges from essentially $250,000 to $500,000. And if you look at the studies by ISA and others in the cost effectiveness domain, this would require an extravagant reduction in extravagant cost, probably of the order of 85 to 90%. To actually bring you into the quality adjusted segment of 50 to 150,000 per cost effective quality threshold. Next slide, please. And then, of course, if you go and look at the pipeline that is evolving in this arena, whether it be for neuropathy, cardiomyopathy, or directly attaching the aberrant TTR. This is a burgeoning pipeline, and one has to then begin to ask the question of what will be the cost effectiveness of these new therapeutic regimens. Next slide. And of course, will we in what time frame see a shift in the therapeutic paradigm in this disease that move him from lifelong therapy, which is the dilemma today? And is this a bright star on the horizon, which is using gene editing technology, the work that Intellia and Regeneron are doing with the drug that's listed there? They've demonstrated initial efficacy in the hereditary polyneuropathy situation and now expanding into cardiomyopathy. Certainly extrapolating from the studies in polymyopathy and neuropathy, there is indeed a sustained knockdown of TTR expression for 6 to 12 months, but the question of how that translates to clinical benefit remains to be seen. And of course, in any gene therapy framework, it is the threshold of transduction efficiency into your target cell population, in this case, the hepatocyte, that will determine all. And the dilemma which the FDA is always struggling with is in this emergent arena, not just for amyloidosis, but all gene therapy, is what are the off-target effects, because they, in many instances, may be often delayed. So there's likely to be the cost of post-approval studies. Next slide, please. But this is just a summary of themes which are well known to this audience. What I want to do is put it in the context of trying to create this framework for a pan-Arizona network, because I think there are many elements of what you are facing in this that reflect the same elements that are shaping biomedical R&D and healthcare delivery at large. Next slide. And that is the fact that we have reflected in my own gray hair, an increasingly aged population, chronic comorbidities in that population, economically unsustainable treatment regimens, and major unmet clinical and social needs as a consequence of that. That has to be balanced against what the general public and the politicians think will be an inexorable tsunami of new innovations coming forward at ever lower cost, with better clinical outcomes and quality of life. But the collision course between those two parameters is going to be with us for some time. And then, of course, in the era of precision medicine, we now have multi-omic stratification of diseases into increasingly small cohorts of patients with different underlying molecular teleologies. And of course, that has been the price driver, that if you've only got a small patient cohort, the recovery of your R&D costs, which can be anywhere between 500 million and $1 billion plus, that drives this distortive element of market failure. And the drugs of this category march under the orphan drug status, as you know, but the threshold for that is 200,000 patients. So if indeed the prevalence of ATTR neuropathies and cardiomyopathy is in fact going to quickly move beyond 200,000 patients, then that will have to be re-examined. And what will that mean then for the price structure and people's willingness to come in? And in this, of course, if you are subsetting patients on the basis of molecular stratification, you also need a companion diagnostic. So that adds further to the equation. Next slide. And so this, of course, then leads to something, again, which this audience lives with the entire time. We're living in an environment of escalating scientific and clinical complexity. And in short, how do each of us stay current with our responsibilities? It's the pace and diversity of innovation, new concepts, new technologies, and an overwhelming burgeoning of large-scale data. And the world in which I live is basically a fusion of three previously separate domains, namely medicine with engineering and computing. And then we're seeing new combination products, diagnostics, therapeutics, devices, and data algorithms coming together. And at the same time, with the pervasive and rapid acceleration of machine learning and AI technologies in all areas of medicine, regulatory validation through the FDA, so-called software as medical device, will become an increasingly challenging issue. And then back again to price, increasingly, and if you look at the Inflation Reduction Act, it's very clear that the FDA's mandate, which is currently limited to safety and efficacy, is going to extend to value. And so with or without ICE's insertion into the equation, CMS will become an equally potent blunt weapon in this debate. Next slide. And so it's what I colloquially refer to as the S4 to M4 paradigm shift, particularly if you're in academia. For the most part, academia is still trapped in single scientific disciplines or single clinical specialities, but increasingly the problems we wrestle with are multidisciplinary and multi-speciality, often conducted in single institutions, whereas the scale and sophistication of what's required requires multi-institutional collaborations. Often, if one is dependent upon the federal purse, the resources are subcritical, and at the same time, you've then got to manage the scale of these much larger enterprises, and it is still frustratingly slow to translate innovation into patient benefit, and we have to do better. Next slide. And so another way of putting that is, in fact, silos subvert solutions. And so the whole métier for the institute, which I run and many others around the country, is actually making this transition from the S4 to the M4. Next slide. And so a quick vignette about Arizona for those of you who don't live here. We're the third fastest growing state in the nation. Metro Phoenix is now overtaken Philadelphia and Houston as the fifth largest urban complex in the country. We have unique demographics. Almost a quarter of our population is Hispanic. We have the largest population of Native American tribes in the country, constitute 5.6% of our population. An intriguing feature is that in this 5.5 million metroplex, healthcare is largely provided by only 7 major healthcare providers, whereas if you compare that with Philadelphia or Houston, you're talking about 35 to 40 major healthcare providers. So the question of herding cats in those situations is a lot more complex than trying to get 7 major provider organizations to work together in Arizona. And there has been very rapid growth in both universities, ASU, U of A, and NAU, with now 1.5 billion in annual grant revenues. Next slide. And as a consequence of that, we've had a momentum in the last few years to do exactly what we're trying to do here. These are consortia which have been established in the last 2 to 3 years by bringing everyone together across Arizona. They're listed there. The topics are self-explanatory, but it's a momentum. And so it is the question of what we've done here in these other consortia which have been built over the last 2 to 3 years. The penultimate one, of course, there was catalyzed by COVID, but nonetheless, it is this S4 to M4 transition. Next slide. And so if one were to define theoretically what one would like to see in this network is the capability to build a substantial biobank, a longitudinal registry of patients, ethnic diversity in that patient group, different stages, multi-organ amyloidosis for sampling, both cardiac and non-cardiac, and as mentioned earlier, the ability to migrate to much more minimally invasive, low-cost biospecimens. At the same time, in the ever-increasing world of omics, the last time I checked, there were 400 omics suffixes attached, but certainly whole exome, whole transcriptome sequencing is now quite routine. There are people in this audience who have published on proteomics. Circulating microvesicles or exosomes are becoming an intriguing analyte class and have been shown to be altered in ATTR. And then, of course, what is the nature of the structural biology that gives rise to the altered protein folding, then a whole series of analytical platforms which are needed to support that. And in the end, you get to data, high performance data computing. ASU is now in the top 100 fastest computers, supercomputers in the country. We're one of only 6 worldwide Dell high performance computing capabilities that puts us in the top 10 of any university high-performance computing capability. And as we said when we talked about multi-parameter risk scores, bringing together all this complex phenotypic data, yet alone the multi-omic data, is going to require that type of analytical framework. And last but not least is this, again, back to this issue of pharmacoeconomic analysis. Next slide. And so the idea would be that the people in this audience could in fact be the catalyst to begin to build this statewide network of capabilities in the detection and treatment of ATTR amyloidosis. We need to generate much more sophisticated epidemiological data in the state of Arizona, analyze what are the barriers and the promoters to implement evidence-based care. Apologies for the type evidence-based practice. And at the same time, clearly we're not an island. We would like to see Arizona migrate into a national framework as a leading enterprise within this important area of biomedicine. Next slide. And so just my disclosures, and the most important thing is if any of you want access to the slides, it's also a prompt to remind you that the slides from everyone's presentations are available, but I hope at least with this superficial surf across a large landscape, you've at least got a sense of what we hope will be an aspirational framework for Sandesh and his colleagues in helping us build this. So again, thank you so much for taking time from your schedules on a Saturday, and I'm looking forward to a stimulating and productive symposium. Thank you. Sandesh, do I hand over Chris? Okay, great.
Good morning, everybody. I'm Michael Castro. I'm an internist in Phoenix, Arizona. Been here for about 25 years, originally from Puerto Rico. I lead, as program director, I lead a Brasa Health Network internal medicine residency program, which I think it helps me, recognizing cardiac amyloidosis and other amyloidosis and teach my residents about it. And so we're all aware of this disease. I'm really, really excited to be here. I've seen the faculty and what Dr. Dev have put together. I'm really, really happy about it. It is my pleasure to introduce Dr. Chris Vijay. He's a man of many talents. He's my mentor. He has challenged me intellectually through the years, and I'm really, really happy to see him here because I know he's passionate about disease process and identifying, ways to help people in whatever ways are possible. He's a heart failure specialist, clinical professor of medicine at University of Arizona. And without further ado, Dr. Chris Vijay. He does have 200 clinical trials and more than 100 publications as well. And I know he's humble about it, but I wanted to brag about him.
Thank you, thank you. Is this working now? Yes, no? Yes? Oh, he's moving. Okay. Okay, thank you. Thank you for that introduction. Thank you, everyone, for attending this meeting. So my charge today is to really articulate with compelling clarity those red flags, those things, signs and symptoms that we can detect earlier, perhaps, and then maybe make an impact on the therapeutic strategies. And why are we here? We are here because amyloidosis is making an impact, right? So we know that we had some kind of an erroneous belief in the past that, hey, we can't do anything about amyloid because once you diagnose it, we're just giving them the death sentence and there isn't anything we can do. But that has changed because of newer mechanisms out there and newer therapeutic strategies is available and so many in the pipeline. And secondly, we always believed that we need to send these patients out for a biopsy, an endomyocardial biopsy, to a specialty center. And that is changing because of newer modalities in imaging, and we can detect non-invasively with higher sensitivity and specificity. And then thirdly, we have heart failure patients who now are being detected, primarily those who have HFpEF, or heart failure with preserved ejection fraction. We're now realizing that many of these patients may well have amyloidosis, and maybe we ought to be thinking about it. And that's my talk again, and talking about all of this amyloidosis and the subtypes, and what is the patient journey like, and then what is the role of the subspecialty, and then we'll summarize with the case study. So as you see, amyloidosis is this aggregate of proteins getting folded into shapes, and then they get multiplicated into copies, and then they stick, and then they form fibrils and get deposited in multiple organs. And we thought that this was like starch. So they called it amylin, initially. And then they said, oh, maybe it's more like fat. And then now we know that it's more like albumin or more like prealbumin. And there are so many different proteins that are featured in different disease states that may well be amyloid. As you see over here in this slide, from Alzheimer's to Parkinson's to encephalopathy to, the even prolactinomas and some of the cancers like the thyroid cancer, even atherosclerotic disease, and patients with ApoA1 may well have diffuse atherosclerotic disease, serum amyloid A in rheumatoid arthritis. The finished amyloidosis is called the lattice corneal dystrophy, or gelselin is the amyloid protein that is upregulated. And then there's so many, and all of them essentially constitute just about 5% or so. And then the other 95% are the two big ones that we're going to talk about, the AL, which is the light chain amyloidosis, and then the ATTR. So in the US, as you see in this slide, the amyloidosis is not uncommon. About 4,500 new cases are diagnosed every year, and about 50 to 80 years of age is where their presentation occurs, and it is caused by this bone marrow disorder. The plasma cells, as you see in this slide, actually form the immunoglobulins, and then the immunoglobulins consist of 4 proteins. They're light chains, 2 of them, and then they're kappa and lambda, which is very important, and then the 2 heavy chains, and there's so many other heavy chain diseases. And we know that even some patients with multiple myeloma, about 15 to 20% of them become amyloidosis. They may be the AL one, and then the Waldenstrom's macroglobulinemia. And the treatment strategy is totally different for AL. That's why we need to be quickly figuring out if they suspect amyloidosis, is it AL first, and then eliminate it completely, so that now we go this direction, completely dichotomized, and because their treatment strategies are totally different, because for AL, there is stem cell transplantation, bone marrow transplant, chemotherapy with the Zomibs and beyond. So ATTR is really a protein, again, that's mutated from chromosome 18q12.1. It's been called what is called the Corino de Andrade's disease. Endemic in northern Portugal, in a town called the Via di Candy. It's along the way of the Santiago, the pilgrimage, the Camino de Santiago, if many of you who are Catholics will know about it. And there is a Skellefteå town called Gold Town in North Sweden, where 1.5% of the population already have amyloidosis, and present in supercentennials over 110 years of age. Again, it's a tetramer that dissociates to monomer and then misfolds and aggregates and gets deposited, right? So as you see in this slide, there are so many different ways of mutation. Some of them are pure neuropathy, some of them are mixed, and then some of them are pure cardiomyopathy. The talk that we're going to talk about mainly is the ATTR amyloidosis. As you see, we said it's about AL and ATTR constitute almost 95% of the population. So ATTR is the, again, deposition, as we talked about, it's the liver produces transthyretin, and it's a transport protein that actually carries thyroxine. Also, the retinine is the retinol protein, which is the vitamin A. And so the transthyretin exists in the serum in a soluble tetramer form. And this, in amyloidosis, becomes unstable, becomes dissociated, becomes multiple monomers, and then they now aggregate, and then they form amyloid fibrils, and they get deposited. If it comes into the heart, it is now cardiac amyloidosis. And as you see in this picture, this is how it looks in the autopsy. Amyloid heart, very thickened muscle, and once it's diagnosed, in untreated patients have a median survival of somewhere around 2 to 3.5 years. But again, it varies based on, is it AL or ATTR, and is it mutant or is it wild type? So what are the different types? The wild type and the mutant or the hereditary. So as you see over here in this slide, the wild type is, again, idiopathic, occurs in white men mostly, 60 years of age. The cardiac arrhythmias are very common, like atrial fibrillation. They can present with carpal tunnel, lumbar spinal stenosis, neurological. Whereas the hereditary one, there are multiple, more than 120 known mutations. Both men and women can get it. And as you see, the Afro-American population has a very unique mutation called the V122I, which stands for the valine in position 122 is replaced by isoleucine, so the V122I. In Ireland, in a town called Donegal in Northern Ireland, there is a very high genetic mutation called the T60A. And so we need to be thinking about when you see Afro-American population and they have heart failure, HFpEF, and you ask the question, could this be amyloid? Could this be cardiac amyloid? So again, we'll go through that in a little bit more detail. So the genetic mutation, as you mentioned, 3 to 4% of African-American population is thought to have the V121I mutation. And again, in one retrospective study, the African-American with ATTR had high rates of heart failure, 93%, and 47% had carpal tunnel syndrome. And when you look at the patient's journey, by the time they actually get detected to have amyloidosis, is about 1.3 to 7.2 years. And if you look at it, they start off with symptoms, they're non-cardiac, and then they go to the primary care, and then the cardiology, and then they see another cardiologist. It's almost 30 to 40% of the time they got to see somebody else for a second opinion, and then they've seen multiple specialty. They even come to the pharmacy with different kinds of medications. So the pharmacist has an opportunity to ask, oh my God, could this be amyloid? They're carpal tunnel, they're on narcotics, they're also having heart failure, they got discharged, they're on Lasix. And, the pharmacist could actually say, oh, my God, ask your doctor, your cardiologist, whether you could have amyloid. So testing, diagnosis, by the time they get there, it's a trap. So hidden in plain sight. So this is a very powerful slide. So think about hidden in plain sight. The H stands for the HFpEF. 16% of have ATTR, of heart failure with preserved ejection fraction. I is intolerance to many of the standard medication we use, ACE, ARB, beta blocker, they can't take it, blood pressure is low, a side effect profile. D is for discordant on the EKG. Many of them have low voltage EKG, and yet they have a thickened ventricle in the echocardiogram. And that's the D stands for dysrhythmia, the E stands for the echo abnormalities with LVH, aortic stenosis, think amyloidosis in a younger person, and RV thickness, biatrial enlargement, pulmonary hypertension, some pericardial effusion that you cannot really figure out why they're having pericardial effusion. They're negative for ANA, and suddenly they have pericardial effusion for no obvious reason. And then the N stands for all the non-cardiac, which is on the other side of the slide. They can present with carpal tunnel, spontaneous biceps tendon rupture. Even statins can cause that. Bempedoic acid can cause that. But then when they come with spontaneously, without really getting any weightlifting done, and they get spontaneous biceps tendon ruptures, think ATTR. There are multiple arthroplasties, the lumbar spinal stenosis, GI, peripheral, autonomic nervous system. They have all kinds of orthostatic blood pressure drops, and they're not able to tolerate many of the medications as well, and some neuropathy. So if you have many of this confluence of symptoms, start thinking, oh my God, suddenly you might have an epiphany. Oh, this could be amyloid. Let me go and dig a little bit deeper. And they have persistent elevation in NT-proBNP or troponin or both. It's a prognostic marker. The Mayo has a criteria, and UK has a criteria based on these biomarkers that they can actually have a prognosis which can be worse if both of them are significantly elevated to maybe just 1.5 to 2 years in their longevity. The lifespan is decreased significantly because persistent elevation in the biomarkers. Again, functional class, EKG, and even cardiac magnetic resonance imaging. We can dig a little bit deeper, as with both Bob and Vital will talk about that too. This is the EKG where there is a significant drop in the QRS voltage, but then again, the QRS voltage can vary, and only about 20% of ATTR cardiomyopathy have a low voltage QRS. So don't keep looking only for the low voltage QRS. If it's not there, don't assume that, oh, this cannot be amyloid. It could still be, because even in AL amyloidosis, only about 60% have a low voltage QRS in the anterior lead. They can have pseudo-infarct pattern, they can have AFib, they can have AV block at an earlier age, requiring a pacemaker for no obvious reason. Start thinking about it. And Bob will go through the echo findings, as you see over here, the cherry on top with the global longitudinal imaging with apical sparing. He'll go deeply into the and cardiac MRI, as well as the accumulation of delayed washout of the exogenous late gadolinium enhancement can occur. Increased extracellular volume can be seen in the second row there, and then increased native T1 signal for both AL and ATTR, which can be detected before the presence of the late gadolinium enhancement, which is a marker of increased fibrosis. And so, screening. So if one finds symptoms and signs as above that are suspicious for ATTR, then yes, in heart failure, please do the screening for amyloidosis. Consider screening, even if they're not in heart failure, but they have all of these little things, little signs and symptoms, and you start thinking, maybe I should detect earlier. Why? Because earlier you detect, put them on therapy earlier, perhaps you can change the trajectory of their prognosis and their disease state and their quality of life and cardiovascular mortality, which will be discussed in detail again. So how do you rule out AL? Again, starts doing serum-free light chain assay, the kappa lambda ratio, do the serum protein electrophoresis, but with immunofixation, because immunofixation is a lot more sensitive and specific, or more than 95%. Same thing with urine immunofixation. And then once you know that it is not AL amyloidosis, then we go beyond and ask the question, oh, could this be ATTR amyloidosis? So what is the algorithm? Well, does the patient have a history? Does the EKG look like it could be low voltage? Have you ruled out hypertrophic cardiomyopathy, constrictive pericarditis? They all can mimic amyloidosis. Sarcoidosis, cardiac MRI, consider that. Is suspicious, again, do the blood testing, urine testing. If positive, then go ahead and send them to hematologist. If negative, then start thinking, should I do a PYP scan? If PYP positive, then ask the question, or is it ATTR CM? Do we need genetic testing? And then there's the treatment strategy. And that's defined over here in this algorithm. As you see from the top to the bottom, it may be a little bit tiny, but you'll have the slide kit with you. So essentially talks about the same thing. I just put it in words, but this is in a flowchart format, exactly talking about the same thing that we just mentioned. And in terms of the multiple subspecialties are actually involved and should be involved in detecting and managing ATTR, from beyond cardiologists, again, orthopedics should be thinking about it, nuclear cardiologists, genetic counselors involved, neurologists ought to be thinking if they are autonomic dysfunction, no obvious reason they can find that is very obvious. GI, again, hematology, pathology, multiple different subspecialties, and each of them have a role to play, as you see, from recognition to early clues to knowledge about the ATTR itself, and that's why we are here. Hey, let's talk about amyloidosis again and again to increase the awareness, understand many of the symptomatology, and recognize and provide consultation and support and work together. So let's summarize it with a case study. So a 66-year-old African-American male recently discharged from the hospital with HFpEF, sees PCP as follow-up 5 days, has had the angiogram, cardiologist say it's all good, you don't have any coronary disease, so they don't want to follow up many times because they don't have any more procedures to do. And then now the patient has had third-degree AV block a few years ago, has a dual-chamber pacemaker, carpal tunnel syndrome surgery, underwent TAVR for aortic stenosis, no bicuspid aortic valve, on multiple medications, not tolerating blood pressure, dizziness, blood pressure is low, the BNP is a little high, creatinine is borderline high, LVH is present, and you can actually put each of them in a separate silo and essentially take care of those individual signs and symptoms and disease states and not put them all together in one box and look at what comes out from a confluence of this disease state process. And could this be ATTR is the question that you need to be asking. So what do you call an 8-foot creature weighing 5 tons with a large proboscis used as a vestigial appendage with 2 large tusks, 2 large ears, and gray in color, irregular in shape, rough, and if it is the opposite, small, white, soft, smooth, regular, and round, then I would have to call it aspirin, right? So the elephant in the room. That's what we are talking about today. You have these confluence of symptoms. Can you quickly ask the question, am I seeing this elephant in the room? And clearly, early detection, prevention. We do too much at the secondary and tertiary care level. We ought to be doing primary and primordial. What is primordial? Not even allowing them to have these risk factors such as blood pressure, diabetes, obesity, dyslipidemia, and All of that we are talking about primordial, because too much has been done in late stage disease with treatment strategies, as you see the bottom heavy model of cardiovascular care. And truly we got to be addressing it here in this action framework for a comprehensive public health strategy to do it earlier in the prevention and make this a social environmental condition, make that favorable, make the behavioral patterns and promote health at the population. George Post did a beautiful job in discussing all of this strategy that we're talking about, and through this Department of Future Health, perhaps we can address all of these and then do it at an earlier. And I believe that we certainly can, with knowledge gain, we can provide inspirational, transformational message filled with credibility, humility, and a foundation based on empathy. So yes, Aldous Huxley said, the rung of a ladder was never meant to rest upon, but only to hold a man's foot long enough to enable him to put the others somewhat higher. Again, epitomizing that sense of hope. Thank you for your attention. As they say in the Tibetan Buddhism, Jalay.
Thank you. Again, my name is Janice Guzman-Clark. I'm a nurse scientist at the VA, trained as a gerontological nurse practitioner. I'll be presenting our next speaker, who you're familiar with already. Santosh Dev is a cardiologist at the Southern Arizona VA healthcare system. He's also the director of cardiovascular disease at the Institute of Future Health. And I actually met him, I think, a year and a half ago when we started doing a project that's now a VA-funded project using implementation science to improve treatment or optimal treatment of patients with heart failure in the VA. So welcome, Santosh.
All right, thank you, Janice. All right, so I'm tasked with getting us back on track. So I'm going to sort of give you the high-level items from my talk. And just to remind the speakers, we have a timer here for 15 minutes. So you can watch that. When you see the red light, you can wrap up. So I'm excited today to talk to you about epidemiology and population health. This is an area that I'm very interested in as far as implementing strategies to screen patients and really bring the research into practice. So if you have any interest in that, please let me know. And in fact, we are looking for a couple participants for a focus group research study. If you have a background in primary care or general cardiology, talk to me at the break. So I'm going to sort of go rapidly and skip some of my slides. So these are some of the abbreviations I'm going to be using. It'll be on your CME quiz at the end. So I'm really going to focus on what are the high-risk groups for this disease. And I think these are sort of the current state of where people are really looking right now. I'm also going to talk about a screening tool to help identify high-risk patients. So really we want to move the needle from looking at patients who are already symptomatic to patients with early symptoms or even pre-symptomatic. So, some of the cost data suggests that 4% of patients with heart failure preserved ejection fraction have amyloid. And this paper, I think, is probably where that data came from. It was a relatively small retrospective series of autopsies at the Mayo Clinic, comparing patients with HFpEF to those that were controlled without any heart failure. And overall, 4 patients had significant or severe interstitial wild-type ATTR deposition. So to my knowledge, this is probably where that data comes from. So, what's the overall rate of amyloidosis in the general population? And I don't think we have a perfect answer to that, but in this series from Italy, about 12,000 patients had already received scintigraphy for a non-cardiovascular indication, so oncology or rheumatology. And so they went back and looked at what was the uptake in the heart, and about 1 in 277 patients had incidental DPD positive scintigraphy. So that's less than 0.5%. But you can see that there's a high association with increasing age and gender. So it was about 1.2% in men over 80. And then what's the current trends in cardiac amyloidosis? So this was probably the most contemporary series, and this is from Germany, looking at a large health insurance population, inpatient and outpatient. And they looked at any sort of code for amyloidosis accompanied by heart failure. So these are presumed cases of cardiac amyloidosis with age greater than 60. And they saw a 3-fold increase in prevalence and 2.5-fold increase in incidence over a roughly 10-year period. And the greatest increases were in men 80 years of age and older. So this suggests that ATTR is increasingly being diagnosed. And also was very interesting, they looked at the outcomes, and the median survival was only 2.5 years. Now, they did not distinguish between ATTR and AL amyloid. However, the population characteristics suggest that it was mostly ATTR patients. So this survival is lower than typical smaller studies of ATTR patients. So this is somewhat eye-opening. And the 1-year survival overall was 70%. And even in 2018, the most recent year of the study, 1 in 4 were dead after 1 year. And there's a high burden of disease. In the year after diagnosis, the median number of outpatient doctor contacts was 40. So that's almost once a week. There's also some evidence of geographic variation. So this study from 2000 to 2012 looked at cardiac amyloid heart failure hospitalization. And you can see in the panel A that there was a high hospitalization rate in red around Rochester, Minnesota, as well as the Northeast from Boston to roughly Washington. And these are most likely areas that are associated with amyloid centers. But it also suggests a disparity where you have very low rates of prevalence cases, for example, southeastern Arizona and New Mexico. And if you look at the incidence, panel B, there's a similar trend, although it's not quite as striking, where newer cases are still being diagnosed in those large centers. And the increase in incidence was also seen similar to Germany, where you had a multiple increase in prevalence rate and incidence rate, predominantly in men aged greater than 75 and in the Black population. Again, suggesting that ATTR is what is responsible for these trends. Similar findings were associated when they looked at death rates from cardiac amyloidosis. And the panel A, the red and orange are the total percent Black population. And so you would expect to see a very high rate of cardiac amyloid diagnosis in those states. And despite that, they had the lowest death rate in panel B. So suggesting that there's a huge discrepancy in underdiagnosis of cardiac amyloidosis in those states. So the question is, well, what is the population prevalence of ATTR in sort of the most common patient population, which is heart failure? And so this study looked at 1,200 consecutive heart failure patients in several counties in Minnesota, age greater than 60 with left ventricular hypertrophy, with preserved or mildly decreased ejection fraction. And so all patients were offered systematic screening, starting off with a PYP scan. And 1/3 of the patients agreed to screening. The median age was 78. Only a quarter had been hospitalized, so this was largely an ambulatory population. And impressively, you can see in panel A, systematic screening was associated with a 5-fold increase in detection of ATTR. And when you break it down by gender, there was a 10% prevalence in men compared to a much lower prevalence of about 2% in women. But interestingly, none of the women were detected unless there was a systematic screening approach. So the sort of usual care or clinical diagnosis did not lead to any cases diagnosed in women. And again, there was a striking prevalence with age. And you really start to see things take off in 70 to 79 and going up to 80 to 89. And in greater than age 90, 20% of subjects had ATTR diagnosed, which is really amazing. So overall, 1 in 20 patients that was screened had ATTR, and the highest yield was in men older than age 80. So patients who are undergoing evaluation for transcatheter aortic valve replacement, this is another high-risk population. And this study looked at 3 different centers, approximately 400 patients who were evaluated for TAVR. And they wanted to see what was the outcome in patients with cardiac amyloidosis. And they found that, first of all, many of the patients with amyloidosis were denied surgery. There was a 2-to-1 higher likelihood of receiving surgery if you had lone aortic stenosis. But that being said, 1 out of 8 patients who was referred for TAVR had a diagnosis of cardiac amyloidosis. So that's written as ASCA. So 12%. Most of those were high grade. And if the patient had been selected for TAVR, then the outcomes were technically not different between the lone AS versus the ASCA patients. So if they were healthy enough to undergo surgery, they had a reasonable survival, suggesting that these patients should not be denied surgery. And the authors developed a risk score, and if you had a score of 2 points, there was a very high sensitivity of 94% with a specificity of 52%. So you can detect most cases of cardiac amyloidosis in using this score, and I think this is a great model for centers and clinicians who are evaluating these patients. So a couple other populations are carpal tunnel and spinal stenosis. And there's a really intriguing article showing that 10% of patients undergoing carpal tunnel release surgery had amyloid deposits. But interestingly, not that many of them actually had active cardiac amyloidosis at the time. And so the Cleveland Clinic is using this protocol. So if a patient is a male greater than age 50 or a female greater than age 60, and they have bilateral carpal tunnel, they are getting a biopsy at the time of carpal tunnel release. And if they have just one of those tier 1 factors, or if they have any of the tier 2 factors, that combination also leads to a tissue biopsy. And if the patient is Congo red positive, then they undergo further screening for cardiac amyloidosis. And this was a nice case example in which they showed that a patient that had Congo red positive at the time of carpal tunnel release had normal scintigraphy and was essentially asymptomatic. However, 4 years later, they had a positive PYP scan, although they didn't have any evidence of LVH, suggesting that these patients, may be have a early detection of future cardiac amyloidosis. And this was a nice study that retrospectively looked at patients who had already undergone bilateral carpal tunnel surgery, looking back 5 to 15 years. And 5% of the entire sample had evidence of cardiomyopathy. This was nearly 10% of men. And if you're a man greater than age 70 with a normal BMI, it was a 21% rate of amyloidosis. So that was really a good example of how to find these patients. And Dr. Maurer is probably going to speak on this, but as far as spinal stenosis, similar findings where there's a fairly high uptake of Congo red at the time of spinal stenosis surgery. However, very few of the patients in this series, for example, actually were PYP positive and received treatment. So Black patients, because of the high rate of the V142I mutation, are at roughly twice the risk of heart failure. And so this is another high-risk population. So I'll leave you with this risk score. The Mayo Clinic looked at a population of patients who had been referred for cardiac amyloidosis referral into cardiology clinic, and they developed this risk score using available variables. So they excluded some variables that were not available, such as biomarkers, ECG, or there was some missing data. So they settled on this score, which combines age, gender, presence of hypertension, ejection fraction, posterior wall thickness, and relative wall thickness, which is the sum of septum, posterior wall divided by the dimension, LV dimensions. And if you have a score of 6 or greater, there's a 93% sensitivity and a specificity of 62%. And interestingly, addition of biomarkers did not help the model. So one of the nice things about this is that it has a good performance at different prevalence of the disease. So even in low prevalence states, it has a good performance. It is specific for ATTR. And it uses widely available data that is available to any clinician doing an H&P and an echocardiogram. So I hope you can see that there's some really, I'd say, prime time populations that are ready for screening. And I think the question is, are we doing enough with what we already know?
Next in the agenda is Dr. Robert Burke. Dr. Burke is a practicing cardiologist in Scottsdale, Arizona. He's with the Honor Health System. He had gone to medical school in RWJ, completed his residence in internal medicine at Mayo Clinic, Rochester, came back to Arizona, was chief resident down here, and did his cardiology and echo imaging fellowship down here. His interests include cardiac imaging, especially with structural heart disease. And without further ado, he will be talking to us about echocardiography and strain imaging in cardiac amyloidosis. Thank you, Dr. Burke.
Well, good morning, everybody, and thank you for having me here, Dr. Dev, Dr. BJ, thank you again. So cardiac amyloidosis and echo, I think that we've all heard about this before and we're relatively familiar with the concept. I think that echo has been viewed as generally the introduction and primary screening tool for amyloidosis going back for pretty much as long as we've been doing echo. We do have guidelines that actually reflect this, and we'll go through this very briefly. I think this is probably the most important paper that we have to look at what we're supposed to be doing in clinical practice. So again, the algorithm here, you've actually seen this before. We're not going to go through this again. Clearly, we all understand that this is incredibly important and that we need to have echo as a primary tool to determine whether or not somebody should even be evaluated for possible amyloidosis. So recommendations, again, I'm not going to read through this. You all seen this a couple of times before. So consensus recommendations for multimodality imaging in amyloidosis. And realistically, there's going to be a lot more than just echo. But given the fact that echo is relatively inexpensive, it's very readily available, it will still remain the primary tool from an imaging standpoint to say, is there a problem or is there not a problem? Again, I'm incredibly biased because I'm an echo guy, and I anticipate that everybody's going to love the echo and start to use that as the way to really help to differentiate what's going on. So, basic assessment. Is the LV thick? Okay, do you have an increased LV mass and low voltage EKG? We've already heard that that's not 100%, and it's not going to be something to exclude us. Atrial enlargement, incredibly important. For those times when somebody does have a transesophageal echocardiogram, looking for evidence of left atrial stasis or smoke, particularly within the left atrium, that should definitely elevate your pretest probability or suspicion for possible amyloidosis, particularly in the absence of mitral stenosis. Somebody has mitral stenosis, that's a different creature altogether, and they shouldn't be overlapped, and it's pretty easy to take a look at. Valvular thickening, we can comment on that somewhat, but again, valvular thickening in the absence of a reason for it is incredibly important, and that's actually been hit on already. Atrial septal thickening and pericardial effusion, as was noted again by Dr. Vijay. A pericardial effusion with no reason, well, you might need to start thinking about amyloid as the etiology. So again, standardized acquisition, interpretation, reporting for echo with amyloid. These are the things that we're expected to talk about. Now, for those of you who are practicing cardiologists, now you have to realize, at least in part, why I'm such a pain in the butt when it comes to structured reporting. All of this is supposed to be on an echo report per IAC. None of this is unusual. This is all inherently there. One comment that I'll have here is myocardial echogenicity, and saying that sparkling or starry night appearance to the myocardium. There's a caveat to that one. And unfortunately, a lot of what we have historically relates to fundamental imaging. So now that we use harmonics in the vast majority of our studies, we get more of that sparkly or hyperrefractile texturing to the myocardium, and it doesn't always relate to amyloidosis. So we need to just sort of take a little step back there. I know that I've got a colleague of mine who likes to sing Starry Night every time that he thinks that something's going on with amyloid, but that's not always the case, particularly with types of imaging that we use from a technology standpoint. Atrial size, septum, effusion, we talked about that stuff. Again, anytime that you're starting to see diastolic dysfunction in the absence of a reason, this is not a hypertensive heart, they don't have a history of terrible hypertension, you really should perk up your ears a little bit more to say that there might be a problem there. Again, a couple of just things just from a very basic standpoint. In this panel A, you can see that there's thickened myocardium. It does have a little bit of that hyper-refractile or starry night type appearance. You can see that there's a little pericardial effusion. You can see that there's overall thickening. So this all fits. Now, do we see this commonly? Yes, we do. Do we often blame it on things like, well, there's renal insufficiency, it's a kidney problem, they're going to have hypertensive heart disease. Don't worry about it too much. The overlap there is still significant, and we need to be mindful that just because somebody has hypertension and kidney problems doesn't necessarily get them off the hook, and the underlying etiology could still be amyloid. So again, thickening here, as you can see with the white arrow, thickening of that anterior mitral leaflet, we see that, and we see it quite a bit. Again, there's a caveat with this one that I would say the more we're going with harmonic imaging, the more we're going with lower dynamic range or compression, the more likely you are to end up with thickening of structures that's somewhat spurious. So just be mindful of that as an etiology. The yellow cursor here, what that's looking at is thickening of the interatrial septum, and that's what we had spoken about before. So, echo assessment, functional assessment, elevated filling pressures, restrictive physiology, and decreased strain. So tissue Doppler, the 555 sign, I don't know if you guys are familiar with that or if it's just an echo geek thing, but all the tissue Doppler velocities being less than 5 centimeters per second, that's very abnormal, and that tends to correlate very well with restrictive type inflow patterns because your ratio tends to be with your EE prime in that 20 plus range, and you start getting at 25 or more, that really pushes toward this is restrictive physiology. Dr. Steadley knows this better than I do, and it's just one of those things that as soon as you see those numbers, something's wrong. And you really want to have a reason for that. And it's just, well, they got high blood pressure and they've got a bad valve. There's probably something else happening. Strain. Now, the interesting thing here is that when we talk about GLS or global longitudinal strain, we talk about values less than -15. That's a little bit dependent upon the vendor. You don't have to worry about that too much. If it's low, and oftentimes these are in the 10 to 12 range, you've got a real problem. That deserves an evaluation. The cherry on top sign is not always perfect, but if it's there, it's a wonderful thing. So again, this is our 555 sign. I'm not going to go into all the echo intervals. And when we talk about looking at the cherry on top sign and strain, here you can see that really the apex is spared. It has normal strain parameters, and then that falls off as you get through the mid to the base. That is entirely a non-coronary distribution for a problem. Okay, so that's incredibly important. Just keep that in mind. It's not always this pretty. We saw another example of strain where there's going to be some more heterogeneity and there may be a little bit of basal normal strain. That's not uncommon. Strain imaging is still somewhat technically challenging, and it does depend upon whether or not you've got good imaging up front. So there are times when strain, I really can't give you a good strain number, and I can't give you a great pattern because you've got intercostal spaces that are incredibly small, we lose segments, that kind of stuff. So you don't have to go and say, well, we couldn't tell it on the strain, or the strain looked okay. You still have to keep an open mind. Again, same stuff through here. This is actually looking at the left atrium and looking at left atrial strain. And again, if you have infiltration of the left atrium, that's going to set you up for atrial fibrillation. Those values will be lower. Your mechanical function of the left atrium actually drops off. So reporting all this stuff as far as whether or not we should say, is there any question of amyloidosis, things that are going to be very suggestive. Increased LV wall thickness, we talked about that with the relative wall thickness already. Increased LV mass and mass index. Typical strain patterns, the 555 thing on tissue Doppler, atrial enlargement, particularly biatrial enlargement, and loss of A waves. So the atrial contraction, the left atrium is not contributing much to filling. That's incredibly important because that is infiltration of the left atrium, goes along with potential for atrial fibrillation as well. That's small to trivial pericardial effusion and pleural effusions that we can't explain. So I hope I caught up a little bit on time, and we'll have a moment for some questions later. But thank you all for your attention.
Thank you. So our next presenter is Dr. Bital Savir from the University of Arizona based in Tucson. She's an associate professor of medicine of radiology and is the section chief of nuclear medicine. Thank you.
Still with my mint in my mouth. Thank you very much. I will try to get the time back. Sorry, I just took a mint, so. Okay, there you go. So I will not, first of all, I have a lot of disclosures in oncology. I don't have a disclosure on amyloidosis, so I don't have that slide. This kind of introduction already been told, so I'm not going to cover that, but we all know that it is not coming from sugar like the name. It is actually precursor proteins that's going to create a very stable structure. And depends on when it will be deposited, it will create a variety of diseases. So we're here to really speak about the way to delineate light chain amyloidosis that will come from the bone marrow, from TTR amyloidosis that will come from the liver predominantly. So this is an example of a normal staining and then a Congo red staining. And we all know that back in the days that what we do, if there would be already a suspicion, like was told before, the elephant in the room, people will go through biopsy. And the goal today is to see how can we minimize that biopsy. So we all are well aware about the bone scan, and this is the bottom line. This is sort of the last chapter of that, the last page on that chapter, that in order to delineate LA from TTR amyloidosis, we would basically exclude the monoclonal protein in the body. We will use PYP. If the uptake in the heart is either equal or above that of the bone, it will consider to be grade 2 or grade 3, highly sensitive, highly specific, and also we can quantify it by putting a region of interest above the heart and compare it to the contralateral area. If the ratio is above 1.5, this is actually ATTR amyloidosis. So that being said, we have multiple tracers. As you can see, PYP, DPD, EDGE-M, DP, and MDP. For those that not doing oncology, in the United States, MDP is actually the one that we do. So compared to the study was shown here before about the prevalence of incidental finding of ATTR, it will be really hard to do because we're not actually using routinely any of the other tracers. We're using MDP. And PYP is the only tracer here that is FDA approved. That being said, let's start looking at why the guidelines are the way they are. So this is a small study that looked at, in 2005 already, looked at ATTR patient 15, AL patient 10, and then a control group. They did 5 minutes images, they did delay images at 3 hours, and then they said any cardiac uptake, even if you see the heart a little bit, that would be considered to be positive. And you can definitely see that group A with ATTR was actually significantly higher in uptake than the rest of the groups. And the nice thing about it, that AL was equal to control. And that was the sign that you can actually delineate those two diseases together. Interestingly enough, in this cohort, which is extremely small, there is no grade 1. And we'll talk about the grades in a little bit later. And that's where I'm going into the oncology bone scans in the United States, which is MDP. You can definitely see here that on a patient with ATTR, there is actually positive uptick in the heart. It's so positive that there is almost no uptick in the bones. And that would be considered grade 3 uptick. However, you can see on AL that there is no uptake, and what you see there, it's actually the sternum and the spine. And look at that oncology MDP tracer. It's negative on both ATTR and AL. So we don't have enough data, but the data we have on MDP shows that it is inferior. And I'll speak about it at the end when we have shortage of PYP. So that being said, a very large study, 1,200 patients with positive and negative, and you can see that among them they had 538 ATTR, 181 AL, and obviously other kinds. And this is a very nice study because some of them had endomyocardial biopsy, the rest of them had either other biopsies or clinical determination of amyloidosis and the subtype of it. And they use, again, DPD, PYP, and DP. And you can see that they only did planar, and we'll talk about that as well. That being said, they did multiple region on the curve. So the first one, they took the only patient that they actually did biopsy. And they said, we're going to call any little uptake in the heart, grade 1, 2, 3, we're going to call it positive. We want to call negative for the one that are absolutely negative on bone scan. Planar only, again. That being said, now you have sensitivity of 99%, but specificity of 68%. To make it very clear, now we have patients that we think they have amyloidosis or not, and we're going to call all of these patients ATTR, whether it's true positive or false positive, and that's a problem. So they said, okay, let's see what's going on. Among the false positive, they saw that they had tons of patients of light chain amyloidosis and amyloidosis. So that being said, they say, let's take the entire cohort. They included all the 1,200 patients now, and now since specificity in the larger cohort ended up being 86. Higher, not enough. So now they went and say, let's see what makes it, why is it so important to increase the specificity to 100%? Because this is a patient that you may call grade 1 uptake. And now you won't be able to differentiate between AL and ATTR. And now those that need chemotherapy will not receive it. And now it's a problem. So that being said, they said, okay, let's increase the specificity by going into only calling the one that we biopsy. We know for sure with the verification of truth that grade 2 and grade 3 now would be considered ATTR only. And now they had 91% sensitivity, 87% specificity. Again, not enough. So they start looking at the entire cohort, the same concept. Now sensitivity decreased because, again, you do have some overlap when the cohort is high, but specificity, again, 97%. Again, may not be enough. So let's look at the role of the monoclonal study. I'm not going to spend much time. This is on the agenda of today. But what they did, they basically said, let's take all our cohort that we know have AL, and then they saw that 99% of the light chain amyloidosis actually had some kind of monoclonal in their either urine or blood. So when they excluded this population, they actually find that this is where they're going to increase their specificity. The interesting part was they said, you know, out of ATTR amyloidosis in their population, 19% also had detectable monoclonal protein. So you can already understand you're going to compromise your sensitivity. So now when they included all of it with grade 2 and grade 3, specificity became 100%, but look what happened to the sensitivity. But it's okay because before everybody would go to biopsy. Now you can find some subpopulation that you can exclude biopsy, because now you know that if they're going through these parameters, they're going to have 100% specificity with positive predictive value of 100% to have ATTR amyloidosis, and the best way to delineate the two. So they concluded that the only people that would actually benefit from PYP bone scan would be patients with negative monoclonal, need to have, again, you need to think about, like it was said, I use that term, the elephant in the room, and then have positive echo, cardiac MR, and grade 2 and grade 3 aptic scintigraphy. Pay attention that the semi-quantitation is only included here, which is essentially visualization and not the quantitation. So let me show you the quantitation. Extremely small study, but very robust, because they had 12 patients of AL, and then out of the TTR amyloidosis, they divided them almost equally to the wild type and the mutate. They used PYP, and basically they did images at 1 hour, followed by SPECT if needed, compared to the protocol today that when you have a SPECT CT, you do it anyway. And they looked at cardiac retention. They looked to see how it's washing out from the system. And then they actually saw that on the semi-quantitation, they had 2 patients, again, with false positive that they called ATTR, whether they had actually light chain amyloidosis. But they went into the quantitation, they only had 1 ATTR false negative. So this is where they increase the sensitivity in that cohort to 97%, and specificities remain 100%. And you can see the delineation that when you have region of interest on the counts, and you have X counts on the heart, and you compare that to the contralateral lung on basically away from the sternum, you can actually see that everything that is 1.5 and above in ratio would be very, very specific for the delineation of TTR from light chain amyloidosis. So a multi-central trial looked at multiple, and again, you can still see the tracers. We don't have MDP, the oncology tracer that we use here in the United States. So you can see that the variety of studies, and again, specificity and sensitivities are very high. Again, they didn't certify those studies, whether they use monoclonal search or not, but they did mention that in that paper. So going back into the guidelines that was done by ASNAC, and also I took some from Up to Date, but you guys saw that guidelines on all of the presentation. So first of all, do you have any clinical features of amyloidosis? If the answer is yes, you have to exclude monoclonal antibody by blood and urine. And if it's yes, you have to understand that you cannot go through the ATTR pathway, the traditional images now. You have to go by hematology referral biopsy, because you can actually have either ATTR and light chain, as you saw in the study, and you have to go into a different path. If the answer is no, now you can actually perform PYP bone scan. Why PYP? FDA approval here. We cannot bill for the rest of them. And if there is basically grade 2 or grade 3, now you know it's highly specific for TTR amyloidosis. If it's 0, you're basically going into different approach. Maybe it's early, maybe it's not amyloidosis. But then if it's grade 1, it's equivocal, and biopsy would be needed anyway. So going into the, I won't go into all the protocols, but this is for you to see. If you have an institution that has SPECT-CT, this is what we recommend, and I'll explain why. So the finding would be either by semi-quantitation, as you can see here. Negative will have absolutely no uptake. Grade 1 will be uptake that is slightly there, less than the ribs. 2 equal to the ribs, 3 above the ribs, and actually decrease in the bone itself. So the uptake is predominantly in the heart. And then you have the quantitation, which you do the circle. There is no really mentioning of the size that you want, but you want to get a good size around the heart. Copy paste it to the other side. The technologists are doing that for us. And then you want to make sure it doesn't sit on the sternum, obviously, because you're going to have false positive areas. So 3 options. 1, not suggestive when the score is 0 or less than 1.5. And then you have strongly suggesting when it's 2, 3, and above 1.5. Anything in between that is equivocal. As an imager, I don't like to give you equivocal data. I will try to do everything I can to say yes, no, and if I say I don't know, I'll tell you why. So let's go over some cases. This is a no-brainer. Across the street, you see grade 3. You don't even need a quantitation. So this is another case, and you can actually see the uptake. You can see where is the most deposit of essentially the calcium. That's what we see here. And there, you know, there is probably a TTR. This is an interesting case because this is a grade 0, maybe grade 1, and you know, there is a little bit of uptake there that someone can come and say, you know, I don't know actually to exclude or not, but then when you look at a region of how you have 1.1. Said, sorry, that's sort of fluctuating. That being said, now it goes into the equivocal, right? If you look at ASNAC, it's like, what do you do with that? Are you guys gonna take him for a biopsy according to the recommendations? So here you go. There is a spec. There is still some uptake there, right? But there is another problem. How do you exclude? So this is where the spec CT is extremely important, because when you fuse them together, you just see that this is in fact blood pool uptake. Those people may have more stasis in their blood. It's going to take a long time to completely excrete the tracer. The uptake is in the blood pool. It's not along the myocardium, and therefore this should not be called equivocal. It should come and say in the report, not suggestive of cardiac amyloidosis, ATTR amyloidosis. Another grade 1, and another example of 1.1, and another, essentially you can see SPECT only, that there is uptake predominantly in the blood pool, but obviously your confidence is increasing when you fuse it to a CT image. And for those that understand, you can see that I really blacked out that image to be able to show the blood pool, because look at the ribs, look at the spine, how intense it is. So I just try to show it. But that in a non-expert eyes may go into the equivocal, and that may actually send you to a different workup protocol. So another thing, this is actually minimally positive. So this is an interesting case that I just came across not too long ago. If you look at that, you can definitely say grade 2. It's there. There is uptake. You can't argue with that. But then when you look at the uptake and the ratio, it's 1.4. It doesn't reach the threshold. Is that one of the false negative that study showed? Maybe. But the problem is that if you look at the uptake on the upper picture you have there, you see that it's predominantly in the blood pool. But then when you look at other cross-section, you see that there is some uptake in the lateral wall in the basal aspect. And then you don't really know what to do with that, because according to the recommendation, this is highly suggestive. According to quantitation, it's a so-so. And also the SPECT CT doesn't show much of uptake where it's supposed to be, and therefore this would have to go into the other way of workup, because this is not as specific, and that will be on the discrete of the referring physician. So the challenges, we know that we have again and again shortage of PYP. It's hard to get it. We don't have enough kits, and we need to sort of fight for it. And then I always get the question, can I use the other bone scan? And the answer for that question is probably not, because data is not supporting it. Now, if it would be positive, it's probably very positive. But if it's negative, it's probably not sensitive enough for. Another thing, as mentioned again and again, there is lack of knowledge among physicians. We don't get enough of these compared to what we see. So, and if we get them, I have no clinical history to know what I'm looking at, because nobody told me what happened so far. So I'll know if I'm looking at the correct workflow of what I see, because positive bone scan can also be shown sometimes on light chain amyloidosis. As you could see, great overlapping. And then, as I said, outreach is extremely important. So I don't have time to speak, and I'm really going to give the tip of the iceberg, but we do have amyloidosis beta sheet proteins that are specific for those proteins on the PET-CT side, compared to the bone scan, that it's mainly for TTR, because we are tracing the calcium, extracellular calcium deposit. Here we have a specific tracer that goes into this beta amyloid. So those are the three approved tracers that you can see. And when you look at the data, this is an example of a non-FDA approved, but this is the C11 Pittsburgh B compound that you can actually see that there is correlation between mortality, prognosis, and the increased uptake, the quantitation, the SUV max of the PET. So that being said, this is very promising, and that's probably holds true for other tracers. This is the tracer that you're all familiar with, and you can see that light chain, it will show uptake, and ATTR and non-cardiac negative group will show washout. And it seems to be that the future goes into combination of both to predict some AL and delineate it from ATTR. Not very cheap method though, not cheap at all. With that, I will say thank you very much, and I would be happy to join the panel later. Thank you.
So next, I welcome back our speakers back to the front so we can do a panel discussion and answer some questions. And so the way we're going to do this is we're going to alternate between questions from the live audience and questions from the chat. Okay, and I have Michael's going around. If you have questions, just raise your hand so he can see you and go to you.
Questions?
Okay. Oh. Thank you. Okay, so far as I can see, we actually just have one question from the live chat, and this is from Sanjay Shankar, and I'm sorry if I hope I'm saying your question correctly. The question is, how can you figure out the vague, not so clear-cut screening test like MGUS when you do the light chain assay?
Sorry.
No worries. So how can you figure out the vague, not so clear-cut screening test? The example they gave is the monoclonal gammopathy of unclear significance when you do the light chain assay.
So we are coming actually on the second phase for that. We only supposed to receive patients where they have negative uptake. We don't even supposed to get to our nuclear medicine practice anyone that has any positive. So this is the first step of the guidelines, and I believe the data shows that because there is overlapping between TTR and AL, predominantly at the AL, but you have some subpopulation that will have the TTR, that will definitely going to decrease the sensitivity. But the PYP goal, and that is something that I don't think is well spoken, the PYP goal is to skip essentially the biopsy. You don't need a biopsy if you are going through the criteria that I mentioned. Everything else that is outside of those three criteria, negative monoclonal, basically positive grade 2, grade 3, and now we're adding to that the quantitation, should go through a different chain of workup. So this is much before us, and that would be probably discussed when Hemong will give the talk, and then we can discuss the monoclonal.
Yeah, I think that as a clinical cardiologist, when you have the suspicion of monoclonal gammopathy, you're leading automatically down the hematology side. And then the question there is really working with hematology where they're comfortable navigating that gammopathy and saying, yes, no, and do we have enough information here that we're going to do anything? Now, by definition, if it's MUGUS, you're generally going to be watching that patient. Now, that does not exclude ATTR. So you still may need to have an evaluation in that regard, because you can have, as we've already seen with our presenters, that you can have coexistent problems and coexistent pathology. So then you really have to go back and say, look, everything fits for amyloid. MUGUS may not explain it, and I'll defer again to hematology for the final word on that one in the afternoon. But you still have to pay attention to that, and this still could be ATTR, and again, approach it as I don't yet have my answer, and we're really not off the hook if you got, an infiltrative cardiomyopathy appearance on echo, you got restricted filling patterns, you got, a pericardial effusion, you got all of those other things. You owe it to your patient to pay more attention and not just say, well, it's Muggus. We're okay. We'll just take care of it from there. I don't know, anything else, Chris?
Yeah, no, I think I totally agree. One does not exclude the other. I think they can be present, concomitantly. So I think we just need to be aware of that. So yeah, good.
Yeah, thank you. Good reminder for the person who asked this question, Sanjay Shankar. We do have a speaker on workup of monoclonal gammopathy later in the next panel, so stay tuned.
I would like to add one more thing to that. And as we saw in one of the cases here, even someone that not related to the MAGAS that comes with a complete negative workup, and then the bone scan was negative, again, it's not off the hook because it may be so early that we just don't know that it's there, or the deposit didn't even start. So again, I love, I used to call it the new zebra because I'm coming from the oncology as well, so the neuroendocrine, I like now the elephant in the room because it doesn't, if there are too many clinical areas, it doesn't mean that at some point that bone scan will become positive. So again, it's all about the amount of damage that was done to the myocardium for the calcium to aggregate enough to attract the PYP. So that's sort of the mechanism of action.
Great.
And next, do we have any questions or comments from the field?
Amyloidosis and carpal tunnel, how is it related to, does the amyloid plague deposits in the carpal tunnel, or?
If the amyloid presents, if I understood correctly, if the amyloid deposit is the cause for the carpal
Tunnel, yes.
Yeah, so the amyloid can be deposited in so many different organs, right? So when somebody has, say, a hypothyroid and then they have carpal tunnel syndrome, you want to attribute that carpal tunnel perhaps is associated with hypothyroidism. And now you have carpal tunnel and you also have somebody who has heart failure with preserved ejection fraction and they are hospitalized, and then you start asking the question, is there something else that I'm missing out here? Is the deposition inside the neurovascular bundle and the nerve trappings around the bones for the carpal tunnel where the median nerve is going through, whether there is deposition of amyloid in those areas and whether that is the cause of the heart failure as well, or they're related. So I think you need to be just open-minded about thinking that this is carpal tunnel can be isolated and may not be related to anything else at all, even the absence of hypothyroid or any other conditions that can cause carpal tunnel syndrome. But when you have confluence of something else, suddenly the light bulb goes on and you ask the question, could this be? Could this be? Is the question that you need to be. So that's why we are here, because early detection, because there is clear-cut evidence that you start them on therapy, where Julie Rosenthal will talk about, that there is opportunity to actually quickly, change the trajectory of the disease, and the prognosis is actually changed. So that's why thinking about it is very important. So.
Thank you. Any other questions? I actually don't have any more questions from the chat.
Thanks to the panel for a good way to start the morning. Eric Stelly from Mayo Clinic. So, Chris, you said in your talk that that epiphany occurs and you make the diagnosis, but as I go on, epiphanies get farther and farther apart, and so perhaps the imaging folks could give us an idea of how do we push the report or the information out from the lab to the clinician, because like I said, we go through our busy days that we pray for an epiphany, but often it's just patient after patient after patient. So tell me a little more about how you guys would institute a mechanism to spark that.
Great, Eric. Great to see you. Thank you for being here. Great question, right? So, the minute you start thinking about it, and then you say, okay, I want to do some more testing, and then you already have the echo, and that's where some of the red flags are coming up in your mind, and then now you do the PYP because in your system, in our system, the radiologists, we actually put the whole protocol together for them. And so we are one-on-one directly, my nurse practitioner directly is constantly asking, when is the PYP scan? When is it done? And right on that day that it is done, can we quickly connect with that radiologist to give me a call back, give her a call back, or whichever it is. And then now you have the results quickly. I totally agree with you that we need to translate that information quickly to, all of the folks that are involved with that patient's care, including PCP, and then the therapeutic strategy needs to be initiated if it is positive, right? So, or even if it's negative, we got to be asking the question, if it's negative, we need to be thinking something else is going on if the patient truly is symptomatic. So you can't just say, oh, it's negative, it's not amyloid, I'm out of the picture, I'm not going to do anything more, because the patient is still having symptoms and struggling. So again, patients first. To your point, yeah, we need to be a little bit more proactive, clearly.
So, Eric, how about this? How about the echo reports have the risk score on them? So we have it calculated, and then the clinician, you say, well, if they have hypertension, please add 1 point to this score, and this is the sensitivity and specificity associated with this score. This was done with the suggesting beta blockers in patients who had a low ejection fraction. That was found to increase beta blocker prescription rate. So I don't know if we could do that as kind of a clinical decision support. What do you think, Dr. Berg?
Well, I think all of this starts actually with our sonographers. So really what it comes down to is that you really do need to have a very solid echo lab. And that begins with your sonographers first and foremost, and maintaining very high quality standards. And without that, we're lost. Because again, garbage in, garbage out. If your baseline data that comes into the care of that patient is not accurate, we go down lots of different pathways. Measurement issues with regard to just simple septal thickness, posterior wall thickness. Do we actually define concentric LVH well? That's critical. And it's a stupid, simple thing that we've been talking about since we started doing M mode, for that matter. Okay? So with that being said, having accuracy and fidelity in that measurement is critically important. Along with that, having the ability to do appropriate diastology and making sure that those measurements that we have are accurate and that we really can define, is this a restrictive pattern in any way, shape, or form? Those things are critical. Now, a trivial or small pericardial effusion, yes, being mindful and not just blowing it off. Those are simple things that we can do that we need to do. Now, as far as the reporting aspect is concerned, we get into trouble. And where we get into trouble is that a lot of our screening tools, and when we talk about the risk scores, if you're 80 years old with any LVH, you're high risk for amyloid, period, by echo criteria. And that's not incredibly specific. It may be sensitive as all get out, but our specificity there really tends to fall off. So we do need to be mindful of that, because I get into my world of, oh, gee whiz, everybody can have amyloid. And you start getting into the structural realm, and you start talking about TAVR patients. Again, we know that they have a high prevalence. Now, the question is, what are we going to do about it? Okay, so you talk about TAVR patients. They have LVH. They have at least some degree of diastolic dysfunction. They've got conduction problems, and conduction problems occur independently of anything else. You talk about a right bundle. We worry about that all the time. What do we do about it? We get EP involved. We want them to put a pacemaker in before we put a TAVR in so that we don't have to keep them any longer. That tends to be the mindset. Now, when we talk about amyloid, let's go back a little bit. When we got into doing structural heart, and I'll talk about my other world just a tiny bit here, we ended up getting into a multidisciplinary, multi-specialty beast. Now, we have to have that same model for amyloid. On the structural side, we have interventionalists, we have cardiac surgeons, we have imagers, we have radiology, and we have anesthesia. So for amyloid, we still have largely the same team, but really we don't have anesthesia in this one, but we have hematology. So we have to build a very similar multi-specialty team. This has to be something that is actually taken into account for all of our systems and not just, well, you're at Mayo Clinic, so you get to do this, and that's great, but it has to be everywhere else because Mayo can't take care of everybody, you know, and our patients are going to multiple areas.
I think Eric would dispute that.
Yeah, that's all.
Oh, his bandwidth, he's got more business than he wants. Trust me. But that being said, we have to have these multidisciplinary, multi-specialty teams as a part of our regular conversation and being able to take care of patients that way. Like I said, structural heart, we've done that and we do a fair job. We're certainly not there, but at least we have models now, which we didn't have a decade ago. So I think this is very hopeful for all of us.
Yeah, I would like to add one thing. So I'll put the hat of the co-chair of the outreach at the outreach committee at the Society of Nuclear Medicine, as is sort of what we do. As the imagers, one of the biggest problems, and it's not, you know, not only for cardiac amyloidosis, it's everything we do. We come up with so many new tracers, and how do we tell you guys how to correctly use it? And I think your question is really looking at sort of the entire picture, because if everyone here has something that is very good at what it does, but how do we collect that? So one of the things at the Society of Nuclear Medicine, you can all just click ATTR amyloidosis, you'll find vignette, that's for patients. So we also got an educational grant from Pfizer to be able to do something like that. Those kind of events are the one that going to bring us into a full practice. Because yes, Mayo, even if they wanted to take care of everybody, they can't because of also region areas, right? Different population, different geographic. So if we take from the cardiology world what we do for cardiac sarcoidosis, there are clinics for that. So maybe lesser prevalence with amyloid, again, because I don't think we really know the extent of that disease at this point, but getting in each hospital, help administrators, and that's how we do it from the society. We help administrator, we teach the physician, and it's not, you know, doesn't need to be only oncology, because only cardiology, I apologize. They go to see their PCP, and that's what you said. They do not make the connection. I always like to tell the story of a girl that had headaches, and then they gave her ibuprofen, and then she didn't see anything, so they gave her glasses, and then she lost her period, but nobody sent her to a neurologist to look at her pituitary gland. So that's exactly the same concept. So we have to educate the primary physician, because those are the one that will see them first. And then in each hospital, even we will see one person a week, we can still call it amyloid clinic. And that's what would attract people, because they go to the place where the coffee machine is pretty. So if they see amyloid clinic, they don't care what's going on inside. And that's the key of outreach, and that's what we do. We're making sure the patient aware. Where is it? Where is searchable? And it's not out there for amyloidosis. So that's sort of my advice from the upper side of it.
Hi, Matt Moore from Columbia. So I wanted to just follow up on Eric's excellent comment, which he always has. And at our center, one of our junior faculty discovered that at the end of an echo report, when individuals who are reading the echo actually write suspect amyloid, the diagnosis is 5 to 7 times more commonly made by providers than when I guess it's not written. So the other thing I just wanted to applaud, you guys have been at hundreds of amyloid programs, but I think this is very forward-looking. The rationale here is very clear. The drugs that we have to treat amyloid prevent new deposits. We're not sure they extract. They're markedly more effective when given earlier, and there's no doubt that what we want to do is try to identify people as early as possible. Just to highlight one other thing with colleagues at the Cleveland Clinic recently is that 83% of patients with wild-type amyloid have an orthopedic manifestation, so it's nearly universal. So everyone in clinic needs to ask when they're seeing anyone who's elderly with the phenotypes we talked about carpal tunnel syndrome, lumbar spinal stenosis, and any joint replacement, hip, knee, or shoulder. Collectively, like I said, 83% of patients are going to have one of those findings, and heightened suspicion is the key. If you don't put amyloid on your differential, you're never going to make the diagnosis.
I think that's an excellent point. And the one thing that I failed to mention in, again, echo reporting is with structured reporting, having the ability to say, you know, features consistent with infiltrative cardiomyopathy / amyloid, and that is a common summary statement that we have and we use. We've not tracked that as far as outcomes, but it is something that we routinely do. The biggest challenge that you get, I think, in community practice is that for the most part, you don't have a dedicated group of echocardiographers that are actually reading. So this is an all-comers event. So whether you're an interventionalist or non-invasive or an echo guy, you're still reading your own echoes. And so it does create a great deal of heterogeneity, particularly in community practices. And I don't know that we're going to get away from that except for ongoing educational events, getting people to at least go to grand rounds, conferences like this, and then hopefully maintaining some degree of heightened awareness. But it's a major challenge because, you know, echoes are still a big part of the general cardiologist's livelihood. So we're not changing that anytime too soon.
Absolutely, great point, Matt. And the other thing that many times happens in the echo is that we diagnose hypertrophic cardiomyopathy and mistakenly. And so when we see, especially for the echo technicians who are all in the audience, when you see something that's suspicious, it looks like LVH, maybe there is asymmetric septal hypertrophy, a little bit more, and you assume, oh, maybe there is hook'em, maybe just LVH. But make sure that you do Valsalva on every one of those patients to make sure that is it truly hypertrophic? Is there a gradient that significantly increases with Valsalva? And if it isn't, then question is, oh, could this be amyloid? So it should be always thinking about that concept. So, thank you.
Yeah, I think because of time, we have one more question and then we'll call it in. Thank you.
I come from the world of geriatrics and cardiology as well as medical education. And I agree that the vast majority of these patients are seen on the primary care level, but you have a captive audience who doesn't have time necessarily to go to grand rounds and that. But in the state of Arizona, to renew your license, you're required to take a quiz every 2 years on basically the opioid crisis in this country. And that's critical that you take that and pass that before you get relicensed. Why don't we have an initiative to have at least some basic training about amyloid? Because I think the problem is huge. And having spent the last 15 years in medical education, getting these people at the fellowship level in geriatrics and being a cardiologist and a geriatrician myself, they don't know jack about amyloid. I mean, it's like, oh, that's really weird. Thank you, Dr. Simo. You know, but I think that that's a golden opportunity. They have to do this to recertify, get their license again. And even if it's only, if you don't make it the relicensure dependent on this, at least have them respond to a CME program and a quiz. And then you'll have an idea of how big the problem of recognition at the level where most patients are.
Thank you for that suggestion. Any comments or responses? Any responses? No, we're good? Okay. I like that system thinking and looking at it from a higher versus just one-on-one, because I agree, thinking of Arizona, there's so many rural areas still, and so we need to reach them somehow. I agree. So thank you so much for our speakers and presenters. We appreciate you. We are now during our coffee break. Please come back at 10:10. Thank you.
Okay, hold on.
I'm sorry, one more thing. I forgot to call into Chris Vijay. He wanted to speak briefly about ACC. Thank you.
Yeah, almost. So just before the break, I just wanted to kind of update you about something very important. This event is actually endorsed by the American College of Cardiology, and we are truly humbled and really honored to have had that opportunity. And April and the team have really worked hard on getting that together in the ACC Arizona chapter, especially with Liana Collins. I want to thank her, who's been there
executive director for a number of years, and she made it happen. And so we have ACC endorsement. So I just want to Dr. Su, Wilbur Su is the current governor. We call them governor of Arizona chapter for ACC. There are 60 governors in the country, and we all are part of the steering committee of the executive board, actually, of ACC at the national level when you become a governor. And I was privileged and humbled to have been the governor for ACC from 2009 through 2013. I can't believe it's almost 10 years ago I finished my tenure. I can't believe that. But it was such an incredible experience. And Wilbur Su, who's an electrophysiologist here at Banner, he's not able to come today, and he was going to say a few words about ACC. And he said, "Oh, can I talk about it, because I was one of the previous governors." And I just want to briefly tell you about their purpose and what they do. So to contribute, the purpose is to contribute to the prevention of cardiovascular disease and to ensure optimal quality of care for individuals with such diseases in carrying out this purpose. So the chapter functions in consultation with the leadership of the college at the national level as a source of advice to local and state government and professional organizations concerning issues related to cardiovascular. The chapter, in the interest of patients, physicians, and the public in general, maintains a high level of social consciousness and involvement with all of the socioeconomic factors. You heard the term DE&I, the diversity, equity, and inclusiveness is a buzzword. It's going all over the place with every society really picking up that tab, and also giving access to the highest possible quality of cardiovascular healthcare. So they have core values of patient-centeredness, teamwork, collaboration. Again, is very, very apropos to our discussion with amyloidosis, the teamwork and collaboration with all of the multi-morbid modalities that we see with multiple specialties here. And of course, the professional excellence. They do it through conferences and publications and newsletters and social media presence in Twitter, Facebook, lots of resources, and the conversations in cardiology, the quality outcomes. They do door-to-balloon, gap, H2H, images in cardiology, and also the large registries, right? So one of the largest registries going on is called the Pinnacle Registry, and I'm part of Pinnacle India on the steering committee, which is also part of the extrapolation of the Pinnacle in the U.S. And they got awarded for the FIT Fellows in Training for the local chapter, and also for the best women in cardiology for a chapter in the country. So kudos to all of them. Thank you to ACC for endorsing, and again, thank you all for coming. And any questions you have about ACC, just reach out to me. And thanks to Leanna Collins, who has also done some phenomenal work. Again, thanks all for coming. Let's have a break, and then we'll meet up and regroup again. Thank you.
This is Sonia Sobrowski.
Yeah, I met
Is she
her.
okay,
Yeah.
she's the next speaker.
Yeah.
Okay, good morning, everyone. We're going to go ahead and get started with our second session. So go ahead and grab your seats. So thank you, everyone, for a great first session. I just wanted to briefly introduce myself and my co-moderator here. I'm Amber Andrade. I'm one of the heart failure specialists at Banner University and University of Arizona.
And Matt Moore from Columbia University. Pleasure to be with you all.
So we have a great second session for you guys. We'd like to bring up our first speaker, Sonia Sobrowski from the Mayo Clinic. Will be talking about the role of genetic testing. I know this can be the bane of our existence in cardiac amyloid diagnosis, let alone just all of cardiomyopathy. So really excited for her great talk. Thank you for your attention.
All right. Hopefully you can all hear me. Okay, thank you for that introduction, Amber. As she mentioned, I'm a genetic counselor. I work at Mayo Clinic, and I actually serve our adult general genetics population. So I see lots of patients with wide varieties of indications, but I'm particularly fond of cardiac genetics. So today I'll be discussing the role of genetic testing in cardiac amyloidosis. So no conflicts of interest to disclose, breeze through that. So given that my focus area is in genetics, it's fitting that the majority of this discussion will focus on identifying hereditary or variant type transthyretin amyloidosis. So thinking about the types of amyloidosis most commonly associated with cardiac manifestations, we've already touched on AL and ATTR. And the ATTR cases, as we've also discussed, can be wild type or hereditary. And genetic testing can help differentiate between the two, which can then help us better understand implications for the patient and their family members. So genetic testing for hereditary TTR amyloidosis involves analysis of the TTR gene. And this gene is located on chromosome 18q12.1 and encodes the transthyretin protein, which again, as discussed previously, is one of the 3 prealbumins. So I won't talk too much about this since we've already gone over most of it, but pathogenic variants, also known as mutations, in this gene are associated with amyloid deposition, predominantly affecting the peripheral nerves or the heart, though there are a small percentage of gene mutations considered to be non-amyloidogenic. So TTR genetic variants are implicated in the etiology of several diseases, including amyloidotic polyneuropathy, erythroid hyperthyroxanemia, amyloidotic vitreous opacities, cardiomyopathy, and carpal tunnel syndrome, as we've discussed previously. And from a molecular standpoint, pathogenic variants in this gene are nearly always sequence variants rather than deletions or duplications. So thinking about the inheritance of hereditary ATTR, these variants are inherited in an autosomal dominant pattern. So that means that each child of an individual with hereditary TTR amyloidosis has a 50% chance to inherit this causative variant. And we expect that the affected individual inherited the variant from a parent. So we would also anticipate that other first-degree relatives, so siblings, parents, also have a 50% chance to share the same amyloidosis-causing variant. Theoretically, there's a chance that somebody's TTR variant could be de novo or new, arising for the first time in themselves, but the rate of de novo TTR mutations is currently unknown. And we'll continue to dive into the concepts of incomplete penetrance and variable expressivity as related to this condition, but just so we have kind of a framework for what those mean over the next couple of slides. Incomplete penetrance really refers to the idea that not all individuals with a specific genotype will manifest a particular clinical symptoms or characteristics of that, while variable expressivity really refers to the variability of signs and symptoms that can occur in different people with the same genetic condition. And these things, incomplete penetrance, variable expressivity, are pretty common in the cardiogenetics world. And for hereditary TTR amyloidosis, there's been quite a bit of investigation done related to genotype-phenotype correlations for specific variants. So for example, the valine 50 methionine variant is considered the most widely studied TTR variant. And just to touch on nomenclature again, really what this means is that at amino acid position 50, there should be a valine, and now there's a methionine there. And autonomic neuropathy and peripheral neuropathy are most commonly associated with this variant, while cardiac involvement is much less common. And penetrance appears to vary by age, region, or ethnic group. So just for example, in Portugal, the cumulative disease risk in individuals with this variant is estimated to be at about 91%, whereas in individuals in France who are heterozygous for this variant, the risk is about 50% by age 70, and in Sweden, the penetrance is much lower, estimated to be at 36% by age 70. And in some cases, heterozygotes do remain completely asymptomatic. And then looking at another example, we've also briefly touched on this one previously as well. Approximately 3 to 4% of African Americans are estimated to carry the valine 142 isoleucine variant, which may be present in more than 5% of the population in some areas of West Africa. And most individuals who are heterozygous for this variant are expected to develop late onset cardiac amyloidosis. So over 140 disease-causing TTR variants have been identified. And this table shows a few additional genetic variants with a breakdown of how these variants have been characterized thus far in terms of prevalence, median age of onset at symptom presentation, primary ethnicity, geographical region, cardiac phenotype, other manifestations. And genotyping doesn't provide us with a crystal ball to perfectly predict disease course or outcome, but it can help us anticipate general clinical presentation, age of onset, organ involvement, and potential prognosis based on what have been generally seen in individuals with these specific variants. And we do know that essentially all TTR variants exhibit age-dependent penetrance, so risk for symptoms increases with age. And research has also been done in individuals who are homozygous for specifically that Val50 MET variant, and people who have 2 of this variant, one in either copy of their TTR gene. And this has suggested that homozygotes present with a slightly more severe clinical course, so higher incidence rate, earlier onset than heterozygotes within the same family, or people with just one TTR mutation. And in these people who are homozygous, amyloid deposition was also found to be more widespread compared to heterozygotes in that study. And so another important piece of information to consider when reading a genetic test report or searching for specific TTR variants in the literature is that the nomenclature of these variants has changed over time. So when we look at that Val50 MET variant, in one paper, it might also show up as the Val30 MET variant in another paper. And really this naming convention differentiation is just because one includes a 20 amino acid signal peptide in the count of residues, whereas the other doesn't. So that accounts for the difference between 30 and 50, but just important to keep in mind as we see these variants pop up in the research. And then as previously mentioned, there are many more known TTR variants than just those 5. So many have been studied to better understand the phenotypes associated with them. And that is available in the research to find. So knowing a patient's genotype and whether their TTR amyloidosis is wild type or hereditary may also have implications in treatment. And I am not an expert on the treatment side of things, but just to briefly review, options may include TTR tetramer stabilizers to address tetramer dissociation and fibril formation, or gene silencing therapies, which use antisense oligonucleotides or small interfering RNAs to reduce amyloid fibril precursor protein. And there are other potential molecular therapies under investigation as well for hereditary TTR amyloidosis that may aim to also either inhibit synthesis or stabilize variant TTR or to disrupt insoluble amyloid fibrils. So gene editing therapies such as CRISPR-Cas9 technology is one of these methods that's currently under investigation. So we're probably all familiar with the clinicaltrials.gov website, so I won't talk about that too much, but some of the eligibility criteria for these research studies or clinical trials may require a known genetic variant to be present. So now that we've kind of touched on why genetic testing can be beneficial, it's important to know when it's indicated. So TTR genetic testing is certainly recommended for all patients with an established diagnosis of TTR cardiac amyloidosis, regardless of age, to differentiate between the wild type and hereditary ATTR, given the discussed management implications. And at this time, genetic testing is not indicated for AL amyloidosis. Another situation that may arise, or maybe you've interacted with patients who have done direct-to-consumer testing that can be purchased at the store. Sometimes patients who do this type of testing and opt in for the medical assessment side of things may be identified to carry a common TTR variant. So for context, these tests are commercially available to purchase. Healthcare provider involvement, insurance provider involvement is not necessary, and they might screen for the presence of really only 3 common TTR variants. So if a patient is found to carry one of these variants, there's a good chance that it's a true positive, but it's still recommended to follow up with confirmatory clinical genetic testing. Now, it's also important to be especially wary of patients who might have done direct-to-consumer testing and they say, I have a rare variant in the TTR gene. These may pop up when patients elect to use their data that they've gotten from direct-to-consumer testing and upload it to a third-party interpretation service. These rare variants that pop up from that type of testing have been known to have a significant false positive rate. So certainly clinical confirmatory testing is really recommended in those cases. And on the flip side of that, it's also, again, important to recognize that this testing only really screens for those 3 common variants. So if somebody has a suspicious clinical or family history for hereditary amyloidosis, but they say, oh, I had negative direct-to-consumer testing, that really doesn't rule out the possibility that this is something hereditary, and clinical TTR sequencing would be indicated in that case for a more comprehensive analysis. And then another indication for genetic testing would be if somebody has a known family history of a known TTR variant and they want to know what their risk is. And in that case, it's really helpful for the patient to obtain records of their affected family members' genetic test results, so we have reference of what variant we should know to be looking for. And it's important to keep in mind that a negative family history doesn't necessarily rule out the possibility of hereditary TTR amyloidosis. There are several reasons why a family history may appear non-contributory, such as the failure to recognize symptoms, early death of a parent or other relatives before onset of symptoms that really never had a chance to present, or given the variable nature of the condition, it's possible that it may not have yet presented itself in a parent or other family members. And then once we have identified, okay, this patient probably needs some genetic testing or is recommended to have genetic testing, how do we coordinate that? The testing itself is typically performed using a blood, buccal, or saliva sample, and there are many labs that offer TTR analysis as a genetic testing service. So some of these commercial labs who specialize in genetic testing may have convenient insurance billing assistance where they might be able to conduct a benefit investigation for the patient to provide them with an estimated cost of the testing before proceeding with testing. Or they might provide them with a self-pay option for testing that's typically around $250. Some of these labs also have policies to not balance bill patients who are insured through Medicare or Medicaid, so oftentimes testing might be covered for them. Additionally, I have on here some sponsored testing programs as well. So these exist to offer no-charge genetic testing to patients who meet certain eligibility criteria, like a suspected diagnosis in themselves or a confirmed family history of hereditary amyloidosis. So there's often different eligibility or clinical features that you can go in and say, yes, this patient meets this criteria, and they might qualify for free testing. So these sponsored programs have the goal of providing increased access to genetic testing and counseling for patients, and they then might receive de-identified patient data for research and commercial purposes. So just a couple of examples of those are the Alnylam Act program through Invitae Laboratory, as well as the HATTR Compass genetic testing program through Ambry Genetics. So if you need assistance coordinating genetic testing, genetic counselors are here to help. In general, we can assist with performing risk assessments, providing genetics educations for patients as well as their family members, facilitating decision-making and coordinating that genetic testing as well, among other things that we can assist with. So if you have genetics questions, ask us. And where do we find genetic counselors? Your hospital or clinic may have genetic counselors on staff who can assist in answering genetics questions or point you in the right direction. But also many of these labs offer genetic counseling services. So you can call the lab and ask questions about variant interpretation or if you need help understanding a result. Or sometimes genetic counseling for positive results is included for patients in the cost of testing. Or they might partner with independent telehealth companies that can provide those genetic counseling services for patients. And a good resource that I always provide too is www.findageneticcounselor.com. That can help you locate local genetic counselors. So looking past the affected patient themselves and into their family and family dynamics, when a genetic variant is identified to be the cause of a patient's amyloidosis, their family members might be interested to know, whether they're also at risk for hereditary amyloidosis as well. So testing of asymptomatic family members requires additional consideration and counseling. It's important that they have the opportunity to meet with a genetics provider to discuss their motivations for genetic testing, as well as the benefits and limitations of doing genetic testing at that time. So they might have certain expectations of what testing can tell them and how it might impact their medical management or their family dynamics. So it's helpful to have a discussion of family history to understand what their experience has been with the condition and that affected family member or multiple family members, and kind of to know what the predicted age at disease onset might be for that family, both in terms of what other family members have shown and what we might know from the research side of things about that particular familial variant. So it's been suggested to begin monitoring for symptoms around 10 years earlier than the predicted age of onset. And it's also important to consider that predictive testing in asymptomatic minors is considered inappropriate. So it's helpful to set expectations with a patient that if they're positive for the variant, we typically will not be testing their children if under 18. Something else to think about is psychosocial implications of testing. Really, not everybody is going to react the same way to a positive or negative genetic test result, finding out about their risk for one of these for this condition. So it can be helpful to prompt the patients to consider, how they would really feel either way. Maybe if a negative result, they might be really glad or relieved that they're not at risk. Or sometimes patients might feel guilty that everybody else in their family is positive or have undergone this medical experience, and now they know that that's not going to be the case for them. Or on the flip side, if a positive test result, maybe they'll be really anxious or stressed about the potential health implications, or they could feel empowered to know their risks and understand their management options. And then from an insurance standpoint, it's important to think about how the implications of learning about a genetic test result might impact different insurance eligibilities. So something I talk about with patients is that there's a federal law called GINA, or the Genetic Information Non-Discrimination Act, that protects most people from their health insurance and employer asking about their genetic test results or using that risk information to discriminate against them. However, other insurance companies like life insurance, long-term care, disability insurance companies are legally allowed to ask about genetic test results and use them in their eligibility determination processes. So for some patients, this is something they really care about. For others, something that's not too much on their mind. And another reason that individuals might want to know their TTR genetic status is for family planning purposes. So when a person is identified to have a TTR pathogenic variant, IVF and pre-implantation genetic testing might be available to select for embryos that don't carry the variant. And there are differences in perspective about prenatal testing for familial TTR variants during pregnancy, given the adult onset and variability of the condition. So really discussion of the considerations may be beneficial for reproductive decision making as well. So with that, I just have some references. And thank you so much for your time.
Thank you, Sonia, for that amazing comprehensive overview. I'm sure we will have many questions for you at the panel discussion. We'd like to bring up our next speaker. Dr. Muhammad Hussain from the University of Arizona, Tucson will be talking about the work of monoclonal gammopathy.
Thank you for the introduction, and happy to be here. So my name is Muhammad Hussain. I'm an assistant professor at the University of Arizona, Tucson, and I'm a hematologist talking to a lot of cardiologists here today. And my discussion is workup for monoclonal gammopathy. This one? Okay. So these are my disclosures. So objective for today's talk is I will be talking how we need to work up for monoclonal gammopathy, and then work up for light chain amyloidosis, and staging and prognosis of light chain amyloidosis. So we'll start with the clinical case. This is the case that I saw a couple of months ago, an 80-year-old man with history of hypertension who was diagnosed with heart failure with preserved ejection fraction, EF was 55 to 60%. Patient had 3 admissions for heart failure exacerbation, and echo showed left ventricular hypertrophy. Then hematology, and that patient was referred to me actually from a community oncologist. They had already started the workup. They had done the SPAP, IFE, and free kappa lambda ratio. So SPAP showed M spike of 0.7 gram per deciliter. Immunofixation serum was positive for IgM lambda monoclonal gammopathy. Free kappa light chain was 20 milligram per liter, and free lambda light chain was 51.4, and kappa lambda ratio was 0.4 for this patient. So we started further workup. 24-hour urine protein electrophoresis was done. We showed 78 milligram per day total protein, and 24-hour urine immunofixation did not show any monoclonal protein. Cardiac MRI was done, which showed that it was consistent with cardiac amyloidosis. So we performed a bone marrow biopsy on this patient, which showed 5% CD138 plasma cells, and Congo red stain was positive for amyloid deposition. So we sent this specimen for mass spectrometry to Mayo Clinic, and this confirmed this to be a light chain lambda amyloidosis. And patient was started on treatment with dara-Cybody-based chemotherapy. He has been on treatment for the last couple of months, tolerating treatment well, and the light chains are improving, and heart failure is kind of stable for him for now. So this has been already discussed, but the AL amyloidosis is around 50% of all the amyloid types. This was a study done by Mayo Clinic, and then the rest are all the different amyloidoses, including the TTR amyloidosis and wild type and hereditary, and also there could be localized amyloid deposition as well. But main focus is light chain amyloidosis and systemic amyloidosis for today's discussion. I don't know if this is not working. Okay. Okay. So light chain amyloidosis is a rare disease. There are around 2,000 cases per year diagnosed in US, so 6 to 10 cases per million diagnosed per year. And the median age of diagnosis is 64. And 10% of these patients could have CRAB criteria and have concurrent multiple myeloma as well. So pathophysiology of light chain amyloidosis is mainly a bone marrow disorder, plasma cell disorder, plasma cells which usually make the normal light chains stimulated by different antigens, but in this case, they start making the monoclonal light chains, and those monoclonal light chains then can form the amyloid fibrils, and those amyloid fibrils can then have the systemic deposition in different organs in the body, heart being the most common organ, then kidneys and liver, on the second and third, and there could be GI involvement and nervous tissue involvement as well. So we only need a small number of plasma cells for this to cause the light chain amyloidosis. So only 5 to 10% of the plasma cells are usually enough to cause light chain amyloidosis. And initially, patients can have monoclonal gammopathy of undetermined significance, and then this can progress to amyloid deposition in these patients. And amyloid, as we said, can cause end organ damage, and then these patients could be diagnosed with amyloid. So I want to spend a minute on differentiating between multiple myeloma and light chain amyloidosis. So patients could have renal involvement from the amyloidosis, and they could have predominant proteinuria. But in patients who have multiple myeloma, the renal damage is different than what we see in patients with light chain amyloidosis. So in patients who have multiple myeloma, usually what we see is the cast nephropathy, or what we call myeloma kidney, while in light chain amyloidosis, most of these patients, if they have the renal involvement, the predominant proteinuria is albuminuria and not the light chain. So that's is one of the differentiating features that we can see. And then those patients, they might not have the myeloma kidney, but they could have the light chain amyloidosis. So it's important to get that differentiation done, and that can help you differentiate whether it's amyloid or myeloma there. So clinical presentation for most of these patients, cardiac involvement is most common. So patients can present with heart failure, renal involvement, so they can present with nephrotic and proteinuria, which is most commonly is albuminuria. In those patients, there could be nervous system involvement and can cause peripheral neuropathy, autonomic dysfunction. Could also be seen, patients could be having hypotension, dizzy spells, syncope. They could have periorbital purpura, skin changes, and then unexplained edema, unexplained soft tissue involvement, elevated liver enzymes, elevated ALK phos, and enlarged liver. And in the GI, they could have diarrhea and GI bleeding as well. So diagnosis requires pattern recognition. So most of these patients, if they have, on the echocardiography, they have hypertrophy, left ventricular septal hypertrophy, and then they, some of those patients who were on antihypertensive and now they're becoming intolerant to their antihypertensive medications and becoming more hypotensive, and then low blood pressures, history of carpal tunnel syndrome, and for the light chain, most of these patients would have heart failure plus or minus nephrotic and proteinuria if they have renal involvement as well, and they could have macroglossia and periorbital purpura. I think macroglossia is more specific with the light chain amyloidosis. I haven't seen many patients having macroglossia with TTR amyloidosis as well, and orthostatic hypotension, peripheral neuropathy, and they would have the monoclonal gammopathy present as well. So heart is the most common organ involved in the light chain amyloidosis. 57% of the patients have cardiac involvement, 44% have renal involvement, and then 22% of the patients have nervous involvement. Liver involvement is around 17%, GI is around 16%, and then other soft tissue involvement could be seen in 5% of the patients. So this is the IMWG diagnostic criteria for systemic light chain amyloidosis. So patients have to have an amyloid-related systemic syndrome. They should have either renal, liver, heart, or GI tract involvement, or peripheral nervous system involvement, positive amyloid staining by Congo red in any tissue, fat aspirate, bone marrow, or organ biopsy, and evidence that amyloid is light chain related established by direct examination of the amyloid using mass spectrometry based proteomic analysis or immunoelectron microscopy is one of the requirements by International Myeloma Working Group for us to diagnose these patients with light chain amyloidosis. And they have to have an evidence of monoclonal plasma cell proliferative disorder, either serum or urine monoclonal protein, abnormal free light chain ratio, or clonal plasma cells in the bone marrow must be present. So whenever we are suspecting patients to have amyloidosis, we need to order these comprehensive hematological workup, which involves doing a serum protein electrophoresis, serum immunofixation, free light chain assay, 24-hour urine protein electrophoresis, and 24-hour urine immunofixation. I think it's important to do all of these testing because most of the time patients could have just a free light chain disease, or sometimes the SPAP might be negative, but we might be able to pick the disease on the free light chain assay, and sometimes patients could have just the urine and kidney involvement, and they could have free light chains in the urine. So it's important to do a 24-hour urine electrophoresis on these patients to determine whether these patients have nephrotic and proteinuria or not. So a slide on the interpretation of SPAP. So this is the SPAP interpretation. Mainly patients who have monoclonal gammopathy, they would have, I don't know if you can point there. Yeah, so patients would have an M spike, which is presented like this, while the other graphs, they can have more of a monoclonal spike or a polyclonal spike there. So SPAP usually tells us whether there is a monoclonal gammopathy present or not, and then we do the immunofixation to tell us what type of monoclonal gammopathy is present, and then we use the anti-CR to determine whether it's IgG, IgA, or IgM, or kappa or lambda type. So like in this patient has an IgG band here and then a kappa band here. So this is an IgG kappa monoclonal gammopathy present on this serum immunofixation. And then these are the serum-free light chain ratios. So the normal ratio in a patient with a normal kidney function is usually from 0.64 to 1.92. And then if the renal function goes down, the ratio can go up a little bit, up to 2.17. So in patients with eGFR less than 30, the free light chain ratio can be as high from 0.67 to 2.17. So these are the normal values. If the free light chain ratio is either more than 2.1 or less than 0.6 in a patient with low GFR, then that is considered abnormal, and those patients need to have further workup for the light chain amyloidosis. So confirmation of light chain amyloidosis always involves getting a bone marrow biopsy with congruent stain, getting an abdominal fat pad biopsy or aspirate and biopsy of the involved organ if we are not finding the congruent positivity on bone marrow biopsy or biopsy of the abdominal fat pad, and then mass spectrometry to confirm the type of that amyloid fibrils. So this is just one diagram showing the amyloid deposition in the peri-arterial regions here, pericapillary, and then positive for congruent stain, and these are the amyloid fibrils that can be seen here. So this is one of the diagnostic algorithm which was proposed in JAC for cardiac amyloidosis. So if there's a clinical suspicion with typical echo and cardiac findings, so the next step that we should be doing in these patients is getting a serum and urine protein electrophoresis and serum-free light chain assay done in these patients. And if that confirms that the patient has a monoclonal protein present, then we will go down this path of involving your friendly hematologist in that case and getting the fat pad aspirate and a bone marrow biopsy done. If the fat pad aspirate and bone marrow biopsy show the amyloid deposition, then we should get a mass spectrometry to confirm what type of amyloid is this. And then if that is confirmed, then we can treat it accordingly, whether it's a TTR or light chain amyloidosis. If the fat pad and bone marrow are negative in a patient with monoclonal gammopathy, then if patients we have a high suspicion for amyloidosis, then those patients we can go to mass spectrometry in those patients, and or we can also get the cardiac biopsy if there's a cardiac involvement to confirm what type of amyloid is this. If the M protein is negative, then we can go down this path where we can get the PYP scan in these patients, and if PYP has grade 2 to 3 uptake on the PYP scan, that confirms the TTR amyloidosis, and we can get the TTR sequencing done. If it is negative, the PYP scan, then I think if we still have the high suspicion, then we should get the cardiac biopsy in these patients, endomyocardial biopsy, to confirm the diagnosis of cardiac amyloid deposition. A slide on the staging for light chain amyloidosis. It is mainly depending on the cardiac involvement. So patients who have cardiac involvement and they have the NT-proBNP of more than 1800, our troponin T is more than 0.025, and the difference in the free light chain is more than 18 milligram per deciliter. So patient who has none of these, that's stage 0. If one of these is present, that's stage 2. If 2 are present, that's stage 3. And if all 3 are elevated, so that's a stage 4 disease. And the prognosis of these patients depends on the stage, and we can see here from stage 1 to stage 4, the median overall survival goes down from 94 months to less than 6 months in these patients. So it's imperative to get these patients diagnosed early before they develop stage 4 cardiac failure, because those patients, when they're diagnosed at the stage 4 disease, then their prognosis is poor, and most of these patients are not even eligible for therapy at that time because they are so frail and not even able to tolerate the treatment when they have the stage 4 amyloidosis. So this is just one slide discussing on how we can target the amyloid in most of these patients. So most of the treatments that we have available so far are directed against the plasma cells. So the therapy that we are using are mainly the anti-plasma cells are directed. We don't have any good drugs that can target the amyloid fibrils that have already deposited. So again, coming to the point that if we try to diagnose these patients early, we might be able to detect them early and can offer them treatments, because once the amyloid gets deposited, it's very difficult to recover from that damage. There are some newer anti-fiber treatments that are in the clinical trials. There's one, KL101, that is showing some good progress. So hopefully if that shows some good results, we might have some antifibrillar therapy. But so far, the therapy that we have is directed against the underlying plasma cells. So there are different components. So there's a chemotherapy drugs, immunomodulatory drugs, and then there are monoclonal antibodies. So chemotherapy, we use melphalan, cyclophosphamide. Then we have proteasome inhibitors, which is bortezomib is the most important drug there. We have immunomodulatory drugs, IMiDs, lenalidomides, and then we have the newest modality of the monoclonal antibodies. CD38 is one of the target on the plasma cells that we can use to target the plasma cells, and daratumumab is one of the drugs that has shown a very good efficacy in these patients. So this was the Andromeda clinical trial published in NEJM in 2021, which studied dara-VCD or dara-CyBorD combination, and they randomized patients to two arms. One arm got the dara-CyBorD, another arm got just the CyBorD, and but this trial excluded patients with stage 3B cardiac disease, amyloidosis, but we have shown here that the daratumumab addition improves the outcome in these patients significantly as compared to just the CyBorD. So most of the patients, the standard of care for the first line is, if they're able to tolerate, we start them on the combination chemotherapy with dara, Velcade, cyclophosphamide, and dexamethasone-based therapy. And with this treatment, there was significant cardiac and renal responses, and this is response rate at 6 months and 12 months, and we showed that with the addition of dara-CyBorD, there was a 42% cardiac response as compared to 22% just with the CyBorD, and the same with at the 12-month, the response rate even improved to 57% in the dara-CyBorD as compared to 28% of the patients in the CyBorD. So it's important to get those patients started on the combination of the dara-CyBorD treatment once we diagnose them with light chain amyloidosis. So treatment options start with dara-CyBorD. Consider stem cell transplant if they're transplant eligible. If transplant ineligible, then we continue them on the dara-CyBorD until we have able to achieve a very good hematological response or better. If they have a relapsed refractory disease, then there are some other treatment options available like pomalidomide and dexamethasone, lenalidomide, carfilzomib, and patients who have 11-14 translocation, we consider venetoclax, which is another targeted treatment that we can use in these patients that has shown some good results in patients who have 11-14 translocation. So the take-home message here is that consider amyloidosis in patients, light chain amyloidosis, if patients have non-ischemic cardiomyopathy and they have LVH on echo findings, and we start with a workup with the SPAP, immunofixation, and free light chain ratio. If patients have peripheral neuropathy, autoimmune dysfunction, carpal tunnel syndrome, periorbital purpura, macroglossia, that phenotype is more consistent with light chain amyloid. So we check serum, urine electrophoresis, immunofixation, free light chain ratio. And if monoclonal protein is present, or if abnormal free light chain present, then we need to get hematology involved for bone marrow and biopsy and fat pad aspirate before ordering a PYP scan. I think because the PYP scan sometimes can give you false positive rates, and in those patients, I think it's important to rule out the light chain amyloidosis first before we jump on to the next step. With this, I would like to conclude, and thank you everyone for your attention.
Thank you, Dr. Hussain, for being our friendly hematologist and sharing your expertise on AL amyloidosis. Next, we are going to bring up Dr. Brent Goodman, from the Mayo Clinic, who will be talking about neurological presentations of ATTR.
I promise to be a friendly neurologist. It's a privilege to be here, part of the discussion today. My task is to focus on TTR and neurology. I have, if I could break it down to maybe 3 take-home points. Really, I would have 3 take-home points. Number 1 would be, this really does begin with carpal tunnel syndrome, and we need to figure out how to identify patients with carpal tunnel who are going to have or have amyloid. Second, unfortunately, we need to rely on neurophysiologic testing when evaluating and caring for these patients. I'll talk a bit more about that. And third, as has been mentioned earlier, we need to get treatment started as early as possible. Neurological improvement, or at least stabilization, that really relies on early diagnosis. And so those are my 3 main points today. With amyloid, particularly with TTR, this can do about anything to the peripheral nervous system, and we've seen that, including carpal tunnel, radiculopathies, spinal stenosis, neuropathy, autonomic neuropathy. It truly can do about anything to the autonomic nervous system. Important to recognize, it may be the first part of the body to be involved if you consider the median nerve running through the carpal tunnel to be a neurological symptom or sign, I would. Important to recognize that once there is significant neurological impairment, it may be difficult or impossible to reverse, to significantly reverse neurological impairment. So we need to get these folks diagnosed quickly, early, and get them on treatment. And then many of the patients need symptomatic treatment as well. The different forms of neurological impairment may provide clues to the different forms of amyloid, or perhaps even the different genetic subtype. So the different neurological manifestations, the most common that we see would be carpal tunnel, which you could consider orthopedic or neurological, lumbar spinal stenosis, peripheral neuropathy, autonomic neuropathy. These are the most common things that we see. Our tools are the history, of course, our neurological examination. Most of these patients really do require neurophysiologic testing. They need nerve conduction studies and EMG to make these differentiations, and I'll talk a little bit about why here in a second. I would advocate for autonomic testing. We have a busy autonomic lab at Mayo, and I've cared for a number of these patients over the years. It can be very difficult to differentiate autonomic impairment in these patients from cardiac impairment. And sometimes, particularly if they're on antihypertensives, et cetera. So what's medication effect? What's cardiac? What's the result of an autonomic neuropathy? Autonomic testing can really help with that. We do skin punch biopsies in many of these patients, and the role of that is to establish whether a small fiber neuropathy is present. But that skin can also be stained for amyloid, so that can be helpful, particularly in the pre-symptomatic or maybe minimally symptomatic patients in whom you're considering whether to start, let's say, silencer treatment on. Lumbar MRI, of course, is important in diagnosing lumbar spinal stenosis, but remember, after a couple of decades, nobody has a normal lumbar MRI, so that needs to be put together with the clinical story, and then, of course, genetic testing. So as a neurologist, we consider these different forms of amyloid, as has been discussed. I would like to highlight, though, this study out of Mayo Clinic Rochester, some of the differences between what they called at the time, this was a number of years ago, familial amyloid versus AL amyloid. And you can see here in their retrospective study, peripheral neuropathy was much more common at presentation in the familial amyloid patients as opposed to AL amyloid patients. So important to recognize that. And then autonomic neuropathy also much more common during the course of illness, familial amyloid. Of course, this was largely pre-treatment. So these definitely differences clinically between these two forms of amyloid, just generally. So I find wild-type amyloid a challenge. Oftentimes, the patients are older. They may have a number of different medical comorbidities. Most of the patients, or really all of the patients that I see with wild-type amyloid on the neurological side of things, have carpal tunnel and spinal stenosis. I can't think of a single patient over at least the last 4 or 5 years who hasn't had that history. So that's very typical. It can be very difficult to differentiate a neuropathy from spinal stenosis. I'll talk about that in a moment. And while it's not clearly established, I do think that these wild-type amyloid cases can develop a very mild neuropathy, although again, that can be very difficult to distinguish from lumbar spinal stenosis. If they develop an autonomic neuropathy, it's subclinical, meaning they don't have symptoms, but they may have some abnormalities on autonomic testing. Carpal tunnel syndrome, this is hugely important for us to recognize, and I think we spoke a little bit earlier about healthcare systems and how we might do a better job diagnosing earlier in someone's course. The important thing, I think, with carpal tunnel is this precedes the development of other things by sometimes many years, can be 5 or 10 years. So we really have to ask, all right, did you have carpal tunnel in times past? Did you have numbness, tingling in your hands? Did you have surgery for carpal tunnel? It may not be concurrent with their current cardiac evaluation that a person is getting worked up for. So remember with carpal tunnel, it's numbness, tingling in the hands. It may be pain. Not everybody has pain. And it's often weakness. The helpful clue, possibly, is that it's bilateral. But it's also typically fairly symmetric. The problem is that carpal tunnel is so common, and it's often bilateral. If we do an EMG on somebody who comes in with carpal tunnel in their right hand, their chance of having it in the left is upwards of 80%. So that bilaterality is helpful, but in amyloid, it's often symmetric. The symptoms are often the same in both hands. But one of the things that we certainly need to be working on is perhaps what cardiology has done and looking at perhaps some AI techniques for identifying possible clues to carpal tunnel. What are the signatures for amyloid on EMG testing, for example? Lumbar spinal stenosis, also extremely common, often precedes the development of other neurological issues, cardiac issues. Classically, this is back and leg pain that's present when upright, with ambulation. That gets better if somebody leans forward. But not all patients have that complaint. They may just complain of numbness in the legs or feet, which can make this very difficult to distinguish from neuropathy. So to make this diagnosis, we really need lumbar MRI and then an EMG to try to differentiate between neuropathy and spinal stenosis. The other thing that I look for clinically is asymmetry. Typically in the lower limbs, neuropathy related to amyloid is symmetric. So spinal stenosis is going to be any sensory symptoms related to spinal stenosis that are fixed, that are present all of the time, that aren't positional, are going to be asymmetric. They'll be worse on the right foot, worse on the left foot, worse comparing side to side in the legs. So those can be clues to differentiating between lumbar spinal stenosis and amyloid. So, it is important to make that distinction. Okay, is this multiple lumbosacral radiculopathy secondary to amyloid, or is this a peripheral neuropathy? So important to make that distinction. And the amyloid, what it does is it infiltrates the ligamentum flavum, so it results in narrowing of the spinal canal. I should have mentioned earlier with carpal tunnel, the amyloid infiltrates the flexor retinaculum within the carpal tunnel, and that's why people experience these issues. So peripheral neuropathy and amyloid. Now, with amyloid, putting carpal tunnel aside, amyloid involves the small fiber nerves first. So these are the nerves that send in pain and temperature information into the body. That's in distinction to the large fiber nerves, which send in light touch, joint position sense, vibration. These are the nerves that help us out with balance. The small fiber nerves are the nerves that send in pain and temperature information. Small fiber nerves are involved first in amyloid. So if I'm seeing somebody with burning in the feet, they may actually have a normal EMG. They may have a small fiber neuropathy that's early due to amyloid. The only way I would diagnose that is with a skin punch biopsy. So important to recognize that somebody can have a normal EMG very early in the course because they have a small fiber neuropathy. So important to recognize that. Typically then, if the amyloid progresses, it will involve the large fiber nerves. It will affect sensation more generally and then affect the nerves to the muscles and cause weakness in the legs. This is typically, it'll start in the feet and then ascend. The general rule of thumb for a neuropathy is that you expect the hands to be involved once the sensation gets to the knees. In amyloid, it would be common to hear that history of carpal tunnel first, and their hands may stay numb in spite of having carpal tunnel surgery 5 to 10 years ago. But so this is what you're looking for historically with a neuropathy with amyloid. Important to do an EMG again to distinguish electrically with EMG. For us as neurologists, to distinguish that from spinal stenosis can sometimes be difficult. And again, remember the epidermal skin punch biopsy may play a very important role increasingly for us as we decide who to start treatment on. In my opinion, it should be started on patients sooner rather than later. So I've mentioned difficult sometimes to distinguish between these different clinical syndromes. Autonomic neuropathy can be difficult to distinguish from cardiac-related impairments. We're looking for a history of orthostatic intolerance. So basically any symptom that's present when upright that gets better when somebody sits or lays down is a potential autonomic symptom. So typically that's postural lightheadedness. They may have syncope as a result of orthostatic hypotension or near syncope. They may have gastrointestinal dysmotility. They may report heat intolerance. So important to do, if not formal tilt table or autonomic testing, postural vital signs. So I would have somebody supine for 5 minutes, measure their heart rate and blood pressure, then stand them up, take immediate heart rate and blood pressure, and then you test them at 3 minutes. So immediate and then at 3 minutes. 3 minutes, if they have a decrease in blood pressure without any significant change in heart rate, then that's typically compatible with neurogenic orthostatic hypotension. Important to do that. Sometimes it can be difficult to differentiate between those who are on antihypertensive medications. Most of the time, patients with orthostatic hypotension will have a drop in both systolic and diastolic blood pressure with standing, so that can be helpful. But ideally, these patients really, I would encourage formal autonomic testing because sometimes, quite often, we will pick up things that you might not have necessarily expected based upon your history. And I would also say that, you know, these autonomic symptoms, the orthostatic intolerance, they don't correlate super well with what we find on autonomic testing. So I would advocate for autonomic testing, particularly if you're wondering, all right, what systems are involved with this disorder? And then also, of course, think about GI motility testing in those who may have symptoms of abdominal bloating, early satiety, which is feeling like you fill up more quickly than you ought to when you're eating a meal. Many of these patients they may develop a horrible diarrhea, which may be due to amyloid infiltration of the GI system or small intestinal bacterial overgrowth or result from overflow from constipation. So this is a very significant problem. If it develops, it can be very difficult to treat. As a neurologist, if I hear a history of peripheral neuropathy plus orthostatic hypotension and they don't have diabetes, I'm doing genetic screening for TTR amyloid after doing serum immunofixation, working up AL amyloid. So, and then as a neurologist, if I have somebody with an antecedent history of carpal tunnel syndrome and a neuropathy, and I don't find some other cause of neuropathy, I'm doing genetic screening for TTR amyloid. The stakes are high. We have to make this diagnosis, and ideally we have to make this diagnosis early. So this was, I just wanted to show this case. We just had this come through one of our autonomic labs just a few weeks ago, and I think it emphasizes what I'm suggesting, which is the benefits or importance of early treatment. This was is a 44-year-old female. She was diagnosed with TTR amyloid. Her dad had died after a liver transplant done for amyloid. She reported sensory symptoms and also postural lightheadedness, which was present when standing still. She had actually quite an unremarkable neurological examination, normal strength, normal reflexes, just very mild sensory loss on her feet. And her cardiac testing was unremarkable. Her EMG was kind of borderline abnormal. Her autonomic testing, which I'll show in a second, was abnormal. She was started on patisiran infusions due to the abnormal autonomic testing and the early signs of neuropathy. Hopefully this comes across okay. I included EMG in upper left, which was only mildly abnormal. Heart stuff was unremarkable. And here's her autonomic testing. Up top is sweating, and so she had abnormal sweating up top. These are the, I don't know if I have a cursor here. Well, anyhow, up top is abnormal sweating. We put capsules on the skin, iontophoresis, acetylcholine, and make people sweat at 4 sites: forearm, proximal leg, distal leg, and foot. So this is one of the ways we diagnose an autonomic neuropathy. And so she had abnormal sweating on the foot, which would be suggestive of a peripheral neuropathy or an autonomic neuropathy. In the middle is cardiovagal testing. So we ask people to breathe at 6 breaths per minute and then measure how much heart rate variability they have. We have normal values for that, and that was reduced. So these are very typical early signs of an autonomic neuropathy. And then her tilt table is down below, and you can see that she supine was 116/76 with a heart rate of, 51. And then, so she drops her pressure a bit with tilt table testing. So she was diagnosed with an autonomic neuropathy. This in conjunction with her exam and the borderline abnormal EMG prompted the initiation of patisiran. And so we just recently got her redid her autonomic testing. This is about 1.5 to 2 years-ish. And so her heart rate variability has improved, her sweating has improved, and her tilt table study, it ain't perfect, but I would argue that it's better. So I think an important demonstration of the peripheral nervous system can regenerate if you catch disease early enough and you treat it. So I think it's super important, and I think this really shows also the value of doing testing and allowing that to sort of factor into decision making in some of these cases. So thank you very much. Appreciate being here.
So thanks so much for that really fantastic talk. It's my pleasure to introduce Dr. Ellen McPhail from the Mayo Clinic, who's going to talk to us about pathology and biopsy. For those of you who've heard the term mass spectrometry here, The Mayo Clinic remains the national treasure and resource for all of us, because every time we want to know exactly what the precursor protein is, we send tissue to them, and Dr. McPhail is always very helpful in sorting that out. So we're all very grateful.
Thank you, Matt, for that really nice introduction. Can you all hear me okay? Yep, okay. Well, I'm very, very pleased to be here at this really wonderful and comprehensive meeting. And so I come from Rochester, Minnesota. I am a hematopathologist, so I'm not a cardiologist. I'm even a cardiac pathologist. But since about 9 years, I've been part of the mass spec lab, and I've been the mass spec medical lab director since 2017. And so since that time, I've seen a lot of cases, and I've actually learned quite a bit about the whole amyloid world. So I hope this is helpful, and let's get started here. So no disclosures. So just as a background, amyloidosis involves basically any organ in the body, and there are now 42 different types that have been described. If you look at the most recent description now, we used to be at 36, but we're up to 42, and they involve basically every organ you can imagine. But fortunately, heart is relatively simple, because although we have described, we wrote a paper about 2 years ago. We went and looked at our whole mass spec experience at that point, which was about 16,000 cases, and then we looked at each type separately. So this description here, that you can see, is the heart. And you can see that although we had 9 different types at that point, in fact, we're up to 10 now, 98% of them were either TTR or AL. So in some ways, heart is really, really easy, because basically that's the question. There are other types. The next most common type is ANF, which is a localized disease, and that only involves atrium. So you really don't have to worry about that either. So basically 99% of cases will be TTR or AL. And it's also important to remember that aside from ANF, these are all systemic diseases. So though the patient may not have symptoms in certain organs, those organs may be involved. So for instance, TTR patients may have prostate involvement, may have gallbladder involvement, may have involvement of basically any other organ. It just may not be symptomatic. But that's a place where you could possibly go and look to make the diagnosis. And then I think, as has already been mentioned, cardiac involvement is the single most important prognostic marker across all amyloid types. So although other organs may be involved and may have some symptoms, the heart is really where the money is for prognosis and outcome. Okay, so a couple points I'm going to make today. This may be controversial. We'll see if this brings up questions. But from my analysis, most patients should not need a heart biopsy. So we'll start out with using the numbers from the paper that we wrote in 2020. Now, I think TTR patients are actually a lot more common than this, but because they come to diagnosis later, because they're older, because the disease is more progressive and indolent, there tends to be subclinical disease. They don't come to attention, are probably underdiagnosed more than AL is underdiagnosed. But we'll use these numbers just for argument's sake. So about 2/3 are TTR, 1/3 are AL. For the TTR patients, about 3/4 of them will not have an M protein. Again, the numbers vary in different studies. It could be higher, it could be lower, but we'll use 75% as an estimate. And for those patients, as we already heard, the scintigraphy scanning should be diagnostic of TTR, and there should be no need for any tissue biopsy whatsoever. About 1/4 of the TTR patients will have an M protein, and for them, as we heard, scintigraphy is not indicated. And for the ALs, pretty much all of them should have an M protein, and again, scintigraphy is not indicated. So we'll go on. So for those patients who have TTR and have an M protein, those patients will have a TTR present in a surrogate site such as fat pad and bone marrow about 1/4 of the time. And similarly for AL, for those patients, again, who have an M protein, so you can't do PYP scan, about 75% of those will have an amyloid present in either the fat pad or the bone marrow. And again, these surrogate sites are overall quite reliable. Not 100%, but overall quite reliable. So that only leaves the 75% of the TTR patients who have an M protein, plus the 25% of AL patients who absolutely need a heart biopsy. So if you do the math, this winds up being about 20% of all cardiac amyloid patients. Now the numbers are all estimates, so maybe it's 30%, maybe it's 15%, but it's certainly under 50%. So that leaves most patients, again, should be diagnosed without the need for going to the heart. So as I mentioned, patients, surrogate sites are often acceptable as a surrogate for the going to the organ of interest. So again, in AL patients, about 75% of fat aspirates and 70% of bone marrows will be positive for AL amyloid. Similarly, for TTR, about 15% of their fat aspirates and 30% of their bone marrows will be positive for TTR amyloid. And then if those sites don't work, there are other sites that have been used with variable success. So lip biopsy is actually a pretty good site for AL. One paper I was looking at showed that about 50% of patients who had a negative fat, 50% of AL patients who had a negative fat and bone marrow did have lip biopsy positive for AL. Again, 10 synovium is good for TTR patients. However, I would not be convinced that a patient who had TTR in their, say, carpal tunnel couldn't possibly have AL in their heart. So I wouldn't use that as a great site for a surrogate. I think it's an indicator, but it doesn't prove it. And then people do use all sorts of other pre-existing sites, such as prostate, bladder, gallbladder, and GI tract. Whether we should use that or we shouldn't, it's hard to say, but people often will go back to pre-existing specimens and see if they can make the diagnosis without having to, subject the patient to a heart biopsy. So the next point is about pathology. So if you do need a biopsy, which is going to be, at least half the time you'll need a biopsy of some sort, make sure it's reviewed by an experienced pathologist who can confirm the diagnosis. So you'd think this would be easy, but in fact, it's not. So again, the same problem that plagues clinicians, plagues pathologists, is that you have to think of it in the first place. It's not so hard to think of it if someone tells you that's the question. So for instance, if someone tells you this is a heart biopsy, do they have amyloid? That's not so hard. What's hard is when you have a patient who has diarrhea and it's a GI biopsy, because the differential for diarrhea, as you all know, is quite broad. And although amyloids can certainly present with diarrhea, so can a lot of other things. So again, you got to think of it. And so you need a specialist who has encountered this and knows how to deal with it. The next challenge is the Congo red stain. We all talk about that like it's just we do it and that's the end of it. And in fact, it is the gold standard. It's a cheap stain. It's been around forever. It's easy. It's in some ways easy to do, but it's technically challenging. So everything has to be perfect. The pH has to be perfect. Everything has to be made up quick, freshly. The thickness of the tissue has to be correct. Everything has to be correct for this test to work. Otherwise, you wind up with false positives and false negatives. And another problem that we came up aware of recently is that we used to think it was 100% specific for amyloid. In fact, it's not. So there are rare diagnoses like fibrillary glomerulonephritis that are Congo red positive. It's a fibrillary disease, but it's not amyloid. So again, you need to make sure someone who is an expert is looking at this. And then the next challenge, okay, now you know it's amyloid. What type of amyloid is it? And of course, as this audience knows, the treatment for AL and TTR is so dramatically different that you really want to get the answer right. So most pre-mass spec, most methods were antigen and antibody-based methods. So this included immunohistochemistry, immunofluorescence, and what's called immunogold, which is an EM-based technique. And these are all great techniques for a lot of things, but amyloid is not one of them. There are problems with amyloid. Now, it's true. I mean, these are our workhorses. IHC, immunohistochemistry, that's all we do. Basically, that's the workhorse for the backbone of our practice in pathology, but not so much for amyloid. So there's some problems. The first problem is there's a bias toward expected types. So as I mentioned, there are 40 different known types, but nobody out there is doing 40 different antibodies when they come along on an amyloid case. So unless your case is one of the 3 common types, this is going to be a problem. So you either will miss the type it is, or even worse, misdiagnosis as a type, one of the common types. And then the other problem is the chemistry is nonspecific. Again, this isn't a problem for most areas of pathology, but it is for amyloid. So we end up with a very high inconclusive rate and a lot of cross-reactivity. So we think that optimal patient care requires a better method. And so it was actually this problem, this very problem, that prompted our institution to develop the mass spec test for amyloid. So this was the first test. We launched the world's first clinical test to type amyloid by mass spec based shotgun proteomics back in 2008. And it was developed to solve this precise problem. And it's now considered the gold standard for amyloid typing, now performed worldwide. So we obsoleted our IHC for all the amyloid proteins back in 2008 because we realized this works so much better. And why it's a great test, it directly analyzes the proteins of interest, it's unbiased, it unambiguously identifies all amyloid types in a single assay, very, very high sensitivity and specificity. So sensitivity is about 98%. The couple percent we miss is usually because there's not enough amyloid present to do the test. And then specificity is about 100%. It uses a paraffin tissue, so you can go back to specimens that are 30 years old and you can type the amyloid. And it requires very, very little tissue. There are a few cases we can't quite get enough, but they're very, very rare. So even tiny heart biopsies and tiny kidney biopsies, this works fine. So just to give you a little background, or maybe my sort of simplistic way of thinking about amyloid. So there are components of amyloid. There are the amyloid signature proteins, which I think of as the straw. So again, that's the stuff that's, they're ubiquitous proteins in the serum that are soluble, and they're just there. And so like straw, they can kind of just move freely. And then there's the unique amyloid precursor protein, that's the mud. So again, that's soluble, and it's on its own is not a problem. But these are not normal proteins, they're abnormal in some way. And when these get combined under the right conditions or the wrong conditions, you wind up with the immovable brick that is amyloid. So here's an example. The amyloid signature proteins that we use are apolipoprotein E, apolipoprotein A4, and serum amyloid protein. So there are actually a couple other proteins that are considered amyloid signature proteins, but those are the three we use in our lab. And when combined with, say, an abnormal lambda light chain, you wind up with AL amyloid lambda type. Here's another example. Same amyloid signature proteins. This time the abnormal protein is an abnormal transthyretin. Put them together and you wind up with TTR amyloid. So here's an example of a case that we ran. I don't want to go through all the specifics of mass spec in the interest of time, but you can see that the image on the left is a blood vessel. This is looking at a Congo red under UV light with a fluorescent microscope, so it looks different, it looks kind of bright red. So that red material is the amyloid. You can see a very, very fine sort of lavender line within that red. That's the line of a laser. So what we do is we take the tissue, put it on an uncovered slip slide, and we use a laser. We do a Congo red on it, and we use a laser to cut out just the amyloid that we can see. And that tissue falls into the cap, and that tissue gets analyzed. So it's a very helpful to enrich for the amyloid and eliminate the other material. That's actually a key component to this test and why it works so well. Then we run the mass spec, and we wind up with a personalized profile, which you can see here, which are the numbers. We run 2 samples, so you get 2 columns, each one's a different sample, just to make sure we're honest. And the numbers are what we call spectral counts, which are a semi-quantitative measure of abundance. So, hope you can read this. The top 3 here, you can see those are our amyloid signature proteins that have high numbers. So this is a way that we proteomically prove to ourselves that this is indeed amyloid. So it is. And the next most abundant protein is TTR. So this is a TTR amyloid case. And yes, there are a few rare gammas and alphas and lambdas and kappas, but that's background serum proteins. We can't get rid of them 100%. So there are always a few around, but the numbers are very, very low. And we know that's just background. And in addition, this test is kind of even better because beyond just doing our usual search to identify, say, the amyloid type, say TTR, we can then use a different database, which is a curated mutation profile, and look at the same information, run the search, and we can identify the mutation. So we do this in every case. So if you send us a case, we do this automatically. And it's not 100%, but it's probably above 95% that we can identify the mutation. And in some ways, this is even better because it's diseased tissue. So you could have an asymptomatic patient, a carrier, who doesn't actually have disease yet, but carry the gene. But here we can show here that it is amyloid, and it also carries the abnormal protein. So here's an example of a case, just to show you the problems that we can face sometimes. So this is a 74-year-old man, had a heart biopsy, had amyloid, no problem, gets typed. I don't know if you can read this. This was done somewhere else, actually a very, very good institution. They used immunofluorescence, which is actually probably better than IHC. And they came with a diagnosis of AL-kappa. And then, 31 months later, the very same heart biopsy, so the very, very same specimen, came to us, and they're the signature protein, so we know it's amyloid, and it was TTR. So, beware. So the last point I want to make is, although I have already told you that surrogate sites are really good, they're not perfect. And so if the clinical picture doesn't fit right, then you're going to have to go to the involved organ, which is the heart. So I'll give you three. The first example are rare amyloid types. So again, these are super rare. APOA4 is probably the most common one that we deal with. That's a problem sometimes because I think even that can give maybe Matt, you know, but it can give a false result using PYP scanning, but I think this is anecdotal at this point. So that's a problem, but it's extremely rare. The second problem is discordance. I'll show an example of that. So here's a case, 73-year-old man, had a long-standing type 1 diabetes history. He had symptoms that sounded good for systemic amyloid. He did have an MGUS, a kappa-free light chains, and a kappa MGUS. He had a fat aspirate, which was positive for amyloid. His bone marrow had 5% monoclonal kappa plasma cells. So at that point, the working diagnosis was systemic AL amyloidosis, quite understandably. So he had his fat aspirate typed, and we see the amyloid signature proteins. So they're present, so we know it's amyloid. But what we found was insulin. So this is not AL, this is not TTR, this is insulin. So, insulin amyloid is actually the 5th most common amyloid type that we see. It's about 1% of cases. This is not a systemic disease. It's a localized disease to where people inject insulin. It causes decreased absorption of insulin. It causes masses usually, but it's a localized process that basically is a red herring. But if you go back to our paper, of all our fat pad biopsies, although 60% were AL and 30% were TTR, a full 10% were insulin. So this is not that rare. So it's not unheard of that you will encounter this. So this happens, and basically, it's a red herring. So our clinicians knew that, and they said, yes, this patient still could have cardiac amyloid. And so a heart biopsy was done, and it turned out to be TTR. So in the end, this patient had 3 things. He had the main thing, which is cardiac amyloid TTR, wild type. He had an incidental localized insulin amyloid, and he had an incidental MGUS. So yes, there can be people can have more than one amyloid type, either in different organs or the very same organ. And we've written about this. Other people have written about this. So is it common? No. Does it happen? Yes. So don't be surprised and just keep going if the story doesn't make sense with the surrogate site. And the last example, okay, I forgot about this. So This is a paper we had written about whether you could use surrogate sites like prostate or bladder or tendon as surrogate for cardiac amyloid. Because if you think about it, who gets cardiac amyloid? Well, it's kind of old guys, right? So the old guys often get prostate biopsies and bladder biopsies. So this was kind of an interesting study. And so we had 16 cases where we had a heart biopsy plus one of these sites. And 14 out of 16 were concordant, which is great, but 2 were not. And so it's important that you know about these. So the last one, which I think is 29, was discordant. This person had a type of amyloid called seminogelin, which is localized to seminal vesicles in his prostate. And this is always localized disease. So this one did not pose a problem because you would know that there's no way that's what was in the heart. And the patient had, I think, AL. I can't even read it from here. AL in the heart. So that's fine. There's no way that could have been the same thing. The other case, case 10, was potentially a problem because he had AL in his bladder and TTR in his heart. So AL can be, in addition to being a systemic disease, can be a localized disease. And localized disease, AL in the bladder, is a relatively common clinical pathologic entity. So again, this is an example where using the surrogate site didn't work, and the clinical picture didn't fit, and the clinicians were astute and went to the heart and diagnosed a separate type there. So this is just to keep in mind that this can happen. Usually it doesn't, but it can. And the last case, this is the one that gave me endless gray hairs. This was a 91-year-old guy who had prominent, I'm going the whole story because we're out of time here, but he had prominent interstitial amyloid. 98% of it were these big blobs of interstitial amyloid, which is a typical pattern for TTR. And so we typed it. It was interstitial aggregates, and again, it was TTR. But the patient didn't behave like TTR. He was treated for TTR, and he basically fell off a cliff clinically. And so we went back, and sure enough, if you really hunt hard enough, you could find rare vessels that had amyloid that looked different. The other interesting thing was this patient had a fat aspirate, which is positive for AL amyloid, which also posed a big problem because we think that fat aspirates is a perfect surrogate. So how could he have a different type in his heart? So we went back to the heart, and we found these rare vessels that had amyloid. And we dissected those out separately. And they were so rare that we could only come up with a single cap. But sure enough, we ran it, and it was lambda. So this patient, I don't know if you probably can't see this very well because the numbers are so small, but there was not a speck of TTR in those vessels. And similarly, there was basically not a speck of AL in the interstitial areas. So they were 2 entirely different amyloid types, 2 different anatomic compartments in the same heart. But even though 95+% of it was TTR, he was behaving like AL. So he did get treated for AL, and he improved. So again, the amount of involvement of the tissue is not necessarily proportional to what the patient's going to do clinically. So this is extraordinarily rare. Like, this is about the only case I've ever seen like this. But if it happened once, it can happen again. So again, I think the surrogate sites are excellent, but if the clinical picture doesn't fit, you have to go back to the heart and again, send it to a very good pathologist because these are hard to diagnose. So these are my take-home messages. For one, most patients with cardiac amyloidosis should not need a heart biopsy, and at least half should not need a biopsy at all. For patients who do need a biopsy, surrogate sites like fat aspirate and bone marrow are often acceptable. If you need a biopsy, send it to a good pathologist, and we recommend typing it by a robust method like mass spec. And finally, surrogate sites, although very good, are not perfect. And if the clinical picture doesn't fit, get a heart biopsy. So that's it. Thanks for your attention.
Thanks so much. That was outstanding. It's my pleasure to introduce Dr. Julie Rosenthal, who's going to be speaking to us about emerging therapies and potential obstacles, including navigating prior authorizations. I just say parenthetically, there are 2 great things about amyloid as a field. One is the patients are lovely, and 2 is get to watch colleagues like Dr. Rosenthal develop really amazing programs all by herself with the help of other colleagues. And she's become one of the national experts in this arena, so pleasure.
Thank you, Matt. And thank you, everyone, for allowing me the privilege to be here with you today. It's truly an honor to be at our inaugural ASU Cardiac Amyloidosis Symposium today. Over the next 20 minutes, I hope to provide you a tour de force of therapies for both TTR and AL amyloid. These are my disclosures. Hopefully what you will appreciate by the end of this morning is that there's truly been an explosion in the development of therapies for individuals living with amyloidosis. We have multiple strategies, and no longer do these include only palliative and pastoral care, but we actually have therapies that will reduce overall morbidity and mortality for our patients living with amyloid. So how did we get here? It was almost 150 years ago that Dr. Virchow first described this starchy protein called amyloid. But only 30 years ago did we actually have our first intervention for our hereditary polyneuropathy amyloidosis patients, specifically with liver transplant. And then it was almost 30 years ago that our colleague Dr. Kelly at Scripps really described the kinetics that led to understanding how amyloid fibrils of TTR background form, which then launched the work into tafamidis, which ultimately led to the approval of our first stabilizer in 2019. But silencer therapies hit the market in 2018. And we now have 3 silencer therapies available for our hereditary polyneuropathy patients. And most recently, approximately a year ago, or 2 years this month, we had the FDA approval for our very first AL amyloid drug, daratumumab. Everything else prior to that had been used off-label for AL amyloid. So this is an overview of this morning. We're going to start with highlighting some therapies for TTR amyloidosis. Knowing this is a cardiac symposium, I really just focus our attention today on tafamidis, but I want to highlight there are several other therapies available. Then we'll talk about some plasma cell therapy and some other therapies for our advanced patients. So to set the stage, I'd like to begin with a case. We begin with a patient I share with Dr. Goodman. He's a 65-year-old gentleman with hereditary TTR amyloid, 380 ALA. And he, like most 380 ALAs, had a mixed phenotype, including both cardiac and neuropathic phenomenon. He was quite advanced when I met him several years ago, and his advanced stage was defined by his cardiac involvement, as this is the driver of morbidity and mortality in patients living with amyloid. You can see that by his elevated cardiac biomarkers. We saw earlier from our colleague Dr. Burke some classic features of individuals with amyloid on echo. So this is a Mayo apical 4. Hopefully you can all appreciate the biventricular thickening here in both the LV and the RV, as well as some biatrial enlargement and interatrial septal thickening. And on the right you see the classic apical sparing strain pattern, otherwise known as the cherry on top. Here is his technetium pyrophosphate scan. You can see here that the tracer lights up greater than or equal to the bone, so he was a SPECT grade 3, consistent with his diagnosis of TTR amyloid. So in this setting, what would you do? How many of you would start him on a silencer, stabilizer, maybe enroll in a clinical trial, start combo therapy, revert to advanced therapies? How many of you have no idea what I'm talking about? Well, hopefully by the end of the morning, you'll feel a little more comfortable. Again, I want to set the stage really on stabilizers. You've already seen this diagram already this morning in different iterations, but I just want to highlight the formation of TTR amyloid. Again, it all begins in the liver. The liver makes this tetrameric protein called TTR or transthyretin. It's this critical unfolding step of that tetramer that leads to the development of amyloid fibrils, which then ultimately deposit anywhere from head to toe, leading to a multi-system dysfunction. So we have 3 main pathways to prevent and delay the progression of individuals living with TTR amyloidosis. We can start at the liver with silencer therapies. Again, these include patisiran, inotersen, vutrisiran. We can actually target this circulating TTR tetramer itself with stabilizer therapy. We'll focus today on tafamidis, and perhaps the holy grail will come with actually extraction or removal of fibrils. This is otherwise known as degrader. There's a lot of work going on right now in the monoclonal antibody arena, both for TTR and AL amyloid. But again, I want to highlight tafamidis today, as this is our only approved therapy for individuals living with cardiomyopathy and TTR amyloidosis. Again, a stabilizer there is to prevent that critical unfolding step. So we lead to an increased concentration of serum TTR and subsequently a decrease in deposition. For those of you not familiar with tafamidis, it really made this stage a couple years ago, thanks to our champions of amyloid, Dr. Maurer, who's here today, and Dr. Rapizzi, who our community recently lost. do their work and colleagues for the ATTR ACT study. This was a randomized controlled trial looking at different doses of tafamidis, a high dose, low dose, and comparing to placebo. And overall, we saw a significant reduction in mortality. You can see separation of curves here at about 1.5 years in individuals taking tafamidis compared to those not. We saw overall 30% reduction in all-cause mortality. The number needed to treat to prevent one death at 2.5 years is about 7.5 patients, and 4 patients to prevent hospitalization at 1 year. Not only does this stabilizer demonstrate a reduction in mortality, but we saw a reduction in overall morbidity. You can see there's a significant separation of curves at 6 months in terms of the decline of a 6-minute walk. So individuals on tafamidis seem to walk longer and stronger at around 6 months and over time compared to those not on stabilizer. Not only do you see improved morbidity from a functional standpoint, but also quality of life. Most of the people in the room are familiar with KCCQ. You can see that the decline in KCCQ scores is less steep than the decline in individuals not receiving drug. We once again saw a significant improvement at about 6 months. This was recently presented at ISA by my colleague, Dr. Martha Grogan, looking at the long-term extension data from the ATTR trial. On the top, you can see individuals who are initiated on tafamidis from the very beginning. This is the yellow line. And as you can see, the gray is the placebo. But at 30 months, individuals in the trial were allowed to cross over and ultimately allowed to receive stabilizer therapy. And hopefully what you can see on the gray curve is that the rate of decline in the individuals who were once on placebo and converted drug has slowed down. And then the decline in the individuals on tafamidis doesn't really seem to be declining anymore. It's almost like they've reached a steady state now over a 5-year follow-up. Once again, highlighting that their quality of life continues to be better. In addition to reduction in morbidity and mortality, we've heard already from my colleagues this morning that timing does matter. We know that trying to pick up people earlier in disease tend to have better outcomes in terms of morbidity as well as mortality with hospitalizations and survival. So individuals who are started on treatment later in their stage of amyloid tend to do less well compared to individuals who start earlier in their journey. Also, we know that regardless of dose, individuals receiving some form of tafamidis do better than those not receiving tafamidis at all. But does dose matter? More recently, our colleagues published that, yes, dose does matter. You can see here on the forest plot that dose mattered not only in the initial trial, but also in the long-term extension trial. Those receiving higher dose tafamidis, 80 milligrams compared to low dose tafamidis at 20, did better. So, knowing that we do have multiple therapies, how do we choose a specific therapy for an individual living with TTR amyloid? Is it based on the organ, based on how the drug is administered, the cost of the drug, or is it a combination of factors? Obviously, this morning I did not go through all the drugs, but as I highlighted hopefully for you in that timeline, we now have 4 approved drugs by the FDA for amyloid. But this table that was adopted from Dr. Kittleson and colleagues highlights that we have 3 FDA-approved silencers specifically for hereditary polyneuropathy patients. We have 1 stabilizer approved for our cardiomyopathy patients, both hereditary and wild type, that is tafamidis. And then we have diflunisal, which I think some of us in the community continue to use off-label really because of cost. As you can see on the far right-hand side here, the cost of these drugs is extraordinary, as Dr. Post alluded to. And while there are financial assistance programs available for our patients, I think we as a community need to do better and need to do more. So getting back to our case of this gentleman I met, we initially met in 2017. And remember, in 2017, aside from liver transplant for hereditary polyneuropathy patients, there really wasn't any therapies around. In 2018, he was initiated on the first drug available, which was a silencer, patisiran. And over the course of those 4 years, he actually did much better. He got off of walking with a walker. His heart failure improved. Clinically, he was doing much better. Interestingly, in 2021, he developed some intermittent hematuria. For this, he underwent a renal biopsy that raised question of malignancy. And ultimately, he underwent a nephrectomy, and all the nephrectomy showed was oodles and oodles of amyloid. So I think that we still have a lot to learn about how TTR proteins can affect the kidney. This gentleman did not have any proteinuria. And currently, he continues to be with us, but is living with some progressive heart failure. The importance of this case I want to highlight, I believe it was Dr. Vijay who talked to us this morning. Median survival for an individual with hereditary TTR amyloid used to be about 2.5 years, 3.5 for wild type. But currently, with the advent of all of these therapies, we're changing the natural course for these patients and their families. So this is a nice summary adopted from Dr. Ruberg and colleague, really just to highlight that we do have options for our patients. This doesn't even highlight what's to come. Apollo B was recently presented at ISA and HFSA, and I believe is in progress with the FDA. So potentially patisiran might be available for our wild-type cardiomyopathy patients, but for now it's tafamidis, as well as off-label difluzinol. Again, for hereditary patients, specifically those with mixed phenotype, I think we should consider silencer versus stabilizer. The data has yet to really be presented. Should we do combination therapy? Is silencer superior to stabilizer or vice versa? I think more to come on that front. So switching gears to AL amyloidosis and antiplasma cell therapy. I would like to just start with another case, and I think this case highlights a few stereotypes. One, amyloid is not just a disease for men. This is a young woman of Jamaican descent who presented for her third opinion re-heart failure and was actually found to have light chain amyloidosis. She presented in quite an advanced case. She was stage 4 with clearly symptoms of failure to thrive. She had actually undergone a pericardial window due to recurrent pericardial effusions more than a year prior to meeting me. She was having recurrent pleural effusions, necessitating multiple thoracentesis. You heard earlier from my colleague a little bit about Mayo staging, and whether you use Mayo staging for TTR amyloid or AL amyloid, once again, it's the cardiovascular pathology that really highlights the morbidity of these patients. So here is that AL staging curve again, and I think one of the things that I would just highlight in addition is these curves remain quite steep. Overall mortality for an individual with stage 4 amyloid untreated is less than 50%, and that's highlighted by the sort of brown curve there. Thank you. But these curves, like I tried to show you with the TTR case, are really changing. Most of this data stems from old treatments, old chemotherapy-based treatments for individuals with AL amyloid, such as the melphalan, prednisone therapies that most of us, when we were in training, were most exposed to. CyBorD really didn't hit the scene until 2012. But now we have a lot of things in our arsenal, and I apologize. This is supposed to be not there. But basically, we have a lot of different agents, whether it's melphalan or prednisone, but CyBorD has really been the standard of care up until more recently with the Andromeda trial leading to CyBorD daratumumab. This has truly been a game changer, and I think more things to come with novel therapies and perhaps targeting cytogenetics to tailor therapy for our patients. But Andromeda, I just want to highlight, this was published just over 2 years ago and now, that led to a game changer for our patients living with AL amyloidosis. Daratumumab is a monoclonal antibody targeting the plasma cells. And what this trial looked at was a randomized controlled trial comparing our control group, which was standard of care, CyBorD, cyclophosphamide, bortezomib, dexamethasone, versus the CyBorD plus daratumumab. What hopefully you can see is that there was a significant risk reduction in individuals with the CyBorD dara compared to the control group. More than 50% of these patients were able to achieve complete remission compared to just under 20 receiving our prior standard of care, CyBorD. So getting back to our young lady, she actually started CyBorD dara prior to the FDA approval. We were using off-label dara back in this time period in August of 2020. It took her 2 months to normalize her free light chain ratio, and at that time she was actually in complete remission. This was actually shown in Andromeda, which she would have been excluded from because she was a Mayo stage 4. So they excluded the sickest of the sick patients. This demonstrates that you can use this regimen in quite sick patients. And I recently saw this young woman last month, and thankfully she remains in complete remission. She is now on surveillance monitoring. And just to highlight how much remodeling can change, I think you saw a nice example from Dr. Goodman. When you're thinking about remodeling from an autonomic reflex study and so forth, we definitely can see some cardiac remodeling. This young lady was requiring 200 milligrams of torsemide daily with intermittent boosters to control her volume status. She was initially getting multiple thoracenteses. Now she has not had a recurrent pleural effusion in almost 2 years. And when I saw her in clinic a few weeks ago, I decreased her torsemide to as needed only. She is back to living life. But what about patients who are really this advanced patient who I think have missed the boat when it comes to potential turnaround with chemotherapy or stabilizer or silencers? We can think about transplant. Autologous stem cell transplant is still used for certain individuals living with AL amyloidosis, but I think our program is steering more and more away because we are finding that therapies are working for our patients. Knowing that I'm a cardiologist and this is a cardiac amyloid symposium, I just want to highlight the role of heart transplantation, and I'll save stem cell transplant for another time. But people back in the day used to think that we could not transplant our individuals living with amyloid. And this comes from old data out of Mayo Clinic, actually showing that individuals with amyloid tended to do worse. A more modern cohort, looking at our United Network of Organ Sharing data from 2008 to 2013, demonstrated, in fact, that individuals with amyloid can have just as good outcomes as individuals not with amyloid. The difficulty with UNOS data reporting system is it doesn't differentiate between those with AL amyloid, which you have seen perhaps have a greater morbidity and mortality compared to those with TTR amyloid in some respect. And so it's kind of among us as amyloid centers of excellence to kind of look at the data a little bit more granularly. Our colleagues at Columbia, as well as other centers like Stanford and Cedars, have demonstrated, while numbers are small, that these patients, whether they have AL amyloid or TTR amyloid, can have just as good outcomes as those not living with amyloid. And I think this stems from us understanding as a community who these patients are, what their comorbidities are, and making sure patient selection prior to transplant is good. And I think what's really interesting now, these cohorts that I'm highlighting here, this is prior to the era of actual stabilizer therapy or silencer therapy. So I think there's going to be a lot more to come in the future in terms of how we're managing them. And just to show you that, since we've all been in the room kind of looking at data points and graphs, these are the people we're talking about. These are the people who hopefully were impacting their lives as well as their families' lives. I actually just saw this gentleman for his 4-year annual follow-up. He just finished a 5K back in North Dakota. This was actually a patient sent to me from Dr. Grogan. So this was his 1-year heart transplant anniversary. But now he's still out there living life. And next to him is Kathy. Kathy we met after basically 1 cycle of chemotherapy with Cybor-Didera on a balloon pump, and ultimately we transplanted her, and she is going to have her 2-year anniversary this March. She is actually only on surveillance. She has not required a stem cell transplant or recurrent chemotherapy. And I think that's a question that myself and colleagues are charging our hematology colleagues, how long do we need to continue these people on therapy versus just maintenance? So with that, what's to come? You've already heard from my colleagues, Dr. Post, Sonia Sabrowski, and others. There are so many clinical trials available. I would encourage you to go to clinicaltrials.gov today. Last night I typed in 2 keywords, treatment and amyloid, and more than 500 hits came up alone. CardioTransform, for any of you in the community who are still enrolling, who are still caring for patients, this clinical trial is still enrolling. Helios B, hopefully will have data come out in a couple more years. This is looking at vutrisiran, silencer therapy. It's a depot injection. Acoramidis, waiting for the results, hopefully in the next year or 2, maybe sooner, 2 years.
No. June.
June, okay, excellent. What about gene suppression therapy? This is really going to potentially be a game changer. You perhaps have seen a couple years ago in New England Journal published a case in our hereditary polyneuropathy patients, 7 patients showing 1-dose wonder that can really change your entire genetic makeup. Phase 2 clinical trials are ongoing, and phase 3 are in the works. But this really could be a game changer for not only our patients living with TTR amyloid, but perhaps other diseases. And then a lot of monoclonal antibody trials are going on right now. These are 2 active trials for individuals with AL amyloid. And what's nice about these trials is they're including our really sick cardiac patients. AFFIRM-AL is looking at these Mayo stage 4 patients who otherwise would have been excluded from clinical trial. KL101 is looking at a different staging system, but again, sicker heart patients with Mayo stage 3A and 3B. So I think lots to come and encourage you. And with that, I will just close with this image by Monet. This was the actual painting that launched the movement of Impressionism for any Impressionist lovers in the audience. This is called Le Soleil Levant, or the sunrise. Really, I just think amyloid-targeted therapeutics, they're finally here, but there's a lot more to come. And I think tailored therapy is certainly on the horizon with gene suppression, maybe looking at cytogenetics and thinking about those who might respond to venetoclax if they're not responding to the Cybor-Didera and other things. So with that, I could not be here without my amazing team, so I want to thank them, as well as all of you for being here. Thank you.
That was fantastic. Please don't go away. If the speakers could all come up, we'll begin a little, at least panel discussion. Certainly if there are questions from the audience, please raise your hand and we'll get you a microphone. So it looks like there's some in the background there. Okay. Actually, I'll just start. Maybe one question for Sonia. So you mentioned this 23andMe genetic testing. So you have a 25-year-old who is looking for God knows what, but they have a Val122 ILE variant, and they show up in your office, no symptoms. So what are you telling them?
Yeah, that's a great question, and I've actually run into this somewhat recently. So, you know, essentially the first thing is I ask them what research they've done on their own, because it's really helpful to have an understanding of where they're coming from and, you know, what their impressions of are, what they've read online, or maybe what they've even read from their own genetic test report. But the first thing I tell them is that variant in particular, this is probably a true positive. So I kind of treat the session as if, you know, we've already got a positive result, but that there is some chance that maybe it's not. So we do proceed with clinical confirmatory testing, as I had mentioned before. But we are talking about, you know, that increased risk for the cardiac amyloidosis. In particular, we talk a little bit about amyloidosis in general, implications for family members. You know, like I said, really kind of treating it like a positive test report at that point. But that we'll have further discussion once the clinical results come back. And usually at that point, it's a phone call to confirm that the results did come back positive. And at that point, I also talk about our awesome multidisciplinary clinic and the providers that we have here. I know we just heard from Dr. Rosenthal and Dr. Goodman, and they are really great. And so I talk about the support that we have on our team, and that there is support from other clinical standpoints, and the genetic implications of that as well, just in terms of what are we thinking about for family planning and other family members, because this oftentimes is a surprise. You know, they many times don't even know that this is something in the family or had never heard of this before. So there's a lot that we cover in one of those genetic counseling sessions, but it is something that comes up. And, you know, whenever patients ask me about 23andMe testing or direct-to-consumer testing in general, should they do it, should they not? Really, it's a personal decision and it's up to them. But I tell them, you know, there are things that we might find out about that you're not expecting to find out about. So certainly worth doing your research ahead of time and considering both what it might mean for yourself as well as your family members when you get those results back.
Great. And maybe I just ask Julie, so what do you say clinically to this person who's now been referred to you in their 20s or 30s with V122I? For them, I mean.
And they're asymptomatic. Yeah, this is definitely a struggle, and I think something myself and colleagues talk about often, but just try to reassure them and also just encourage them to follow back. You know, typically I've been recommending 5 years. We unfortunately don't have guidelines for this, and so I base this off of some data from HCM patients and their families in terms of screening. But try to provide them some education. We have a great team of nurse coordinators, so try to provide them that education of signs and symptoms to look for. At the same time, as Sonia alluded to, sometimes that stigma, I think, can really mentally affect patients, so then they think they have a neuropathy when they don't have a neuropathy, or they're worried they have chest pain and there is no chest pain. So you do want to be cautious and understand your audience, and I think asking them, you know, what they understand, what they know, and how they feel, but try to provide reassurance and just bring them back to kind of hold their hand in some respect.
Yeah, I would just agree. I mean, this is a disease, as we heard, it has an age-dependent penetrance, so we don't see V122I penetrating usually before the age of 50. The opportunity may be that loved ones who are older in their family may actually have a clinical phenotype, and maybe those are the individuals. So I always encourage older adults who have the disease to get their, not their kids tested, but rather their siblings tested. Question?
So I work as a hospitalist and I see a ton of heart failure patients, you know, and usually cardiologists are involved when there is low ejection fraction, but then they kind of turf off a lot of diastolic heart failures, and, you know, a lot of echoes are not actually read by experienced cardiologists, if I may, or it's in the substance and not in the conclusion, and a lot of times these are missed. So there are a lot of barriers to diagnosing early. And also our hospitalized patients have that revolving door mechanism where they keep coming, going, and a lot of them are 80 plus or 75 plus. And now the cost versus benefit, as well as what is the, you know, when you say the biomarkers and you're saying 2 out of 3 makes it stage 3 or stage 4 and your life expectancy is 40 months to 6 months. Here you're dealing with our patients who already have multiple medical problems, chronic kidney disease, their tropes are elevated, BNP is high to start with. So when you say 40% improvement with treatment, I want to know in years, am I prolonging life or delaying death, or am I actually benefiting this patient? What is the number of life in years that you can give with treatment and without treatment, so I can approach my patient in a positive way?
I think that's an outstanding question and something that each of us are faced with quite routinely. And I think you highlighted that question about the multiple morbidities, right? I think it's, if you look at the patient and they can't get out of bed on their own, is this really the patient I want to offer an endomyocardial biopsy to and start thinking about chemotherapy, or is the right thing to do to offer palliative care? So I think you have to treat each patient as individual. I don't think we're in necessarily the exact place to judge, what is their life worth to them, but looking at the whole picture, are my therapies and the treatments going to ultimately cause harm, or as you said, are they going to cause benefit? But I think that the important thing to know is that this decision does not have to be made on your shoulder. You heard today from a number of colleagues in different subspecialties. Amyloidosis can affect many things, so this can be a team decision and approach to how to help you counsel your patient, or also just help counsel the patient and their family. But sometimes in my patients who are quite advanced in age, 90 plus, 85 plus, with multiple comorbidities, even if they have TTR amyloidosis, if I feel they have class 4 heart failure, stage D, and I don't think they're going to be living more than a year, I'm not going to be offering these patients a stabilizer therapy that's $250,000 a year, because I'm not sure it's going to provide that benefit. We saw even from the ATTR Act trial, while there is some initial benefit early on from symptoms, it doesn't happen overnight. This takes several months, and you're not seeing mortality benefit for more than a year and a half. So while things might change, for now, I think you just need to continue to approach each patient on an individual basis and reach out to your colleagues who can help provide you some guidance.
If I can add a little bit to that. So I think that's a great question. And I, as a hematologist, I see a lot of those patients who have like stage 3 or stage 4 NYHA heart failure, and they are diagnosed with light chain amyloidosis. And then are they eligible for treatment, and will the treatment improve their quality of life, and will they prolong their life expectancy? So just to give you an example, I saw a patient, like she was in her 60s, late 60s, and she was diagnosed with stage 4 heart failure at another hospital. And then the hospitalist saw the patient, cardiologist saw the patient, they diagnosed her, and then she was sent to hospice. So she was in hospice for at least like 2-3 months, and then she came to see one of our cardiologists who specializes in amyloidosis, and they started the workup and finally diagnosed her with light chain amyloidosis. So then she came to discuss her options with me, and I had the discussion with her. Yes, the outcomes, the prognosis is not good because you already have stage 4 heart failure, but we can at least give a trial of the treatment and see if that improves your quality of life. And we started on a single agent daratumumab initially to begin with, because she was wheelchair bound and she was not even able to walk on her own. And after first couple of months of treatment, her symptoms started to improve. And now she is able to do her activity. She is able to walk at least. She's now 6 months into the treatment, and she's out of the hospice, and she's doing really well. So some of these patients can be very sick when we start the treatment, and experienced physicians, when we start the treatment, we start gently and see how they tolerate. And if they tolerate it okay, that can help improve their quality of life and also can improve the longevity. I don't know whether it's going to be 1 year, 2 years, 3 years that she's going to live, but at least she will have some quality of life. And most of the treatments that we offer these days, especially in the hematology world, are not cytotoxic chemotherapies, and most of these treatments are very well tolerated, but we have to start gently and build it up slowly, and we can improve the quality of life in these patients.
I would just add that I think you're in a unique position as a hospitalist. There's data from National Health System in the UK in which patients with TTR amyloid are hospitalized in the last 3 years of their life 17 times. So you talk about the revolving door. If you can make this diagnosis, you can institute therapy, we may be able to, as Dr. Rosendahl was mentioning, prevent some readmissions. So, that's what we're hoping for. Other questions in the back?
Yeah, how different is amyloidosis and amyloid plaque formation in patients with Alzheimer's?
So the amyloid type in the brain, for the Alzheimer's patients is a different amyloid type called A beta. So that's a specific amyloid type. There are about maybe 16 different amyloid types seen in the brain, but some of those are very, very rare. So the most common one is A beta, and that's the Alzheimer's amyloid. Is that the question? Answer the question?
Yeah, no. Sometimes there can be some confusion, particularly with family members who may read about, they may have amyloid diagnosed by us, say TTR or wild type or variant, and then they may read about amyloid associated with Alzheimer's, but there really isn't any association, and usually it's just a matter of reassurance. But it does get to the point that we've been discussing, which is these older patients do have multiple comorbidities, and so we do struggle with this. And some of the patients who, they may, for example, in neurology, they may come in with a little bit of neuropathy, but they may have a lot of dementia, for example, that's unrelated. So, a number of the patients may have other comorbidities which need to be factored into treatment decisions.
There. Is this still on? So there is the idea that there may be amyloidopaths. So people who have amyloid of different types in different parts of their bodies. There is some evidence maybe that there's a link between Alzheimer's and amyloid elsewhere, but it's kind of tenuous, and I think there needs to be a lot more research. But that idea is at least floating around out there.
I would just add that my clinical experience with the overlap is pretty minimal. I'm surprised. Like the average age of these patients is 75 or 80, and most of them are quite erudite. And the coexistence of the two, at least in my clinical practice, having seen literally 1,000 patients with TTR, is much smaller than I would anticipate. The other thing I would also submit is I think the cardiac amyloid world has done a much better job of actually taking care of this disease. You hear what's coming out of FDA approvals for Alzheimer's disease, and it, is associated with pretty high costs and not much, necessarily clinical benefit. But the same argument is being held, which is if we can move upstream and identify people earlier in Alzheimer's disease, these therapies might be more beneficial in some regards. So I think across all amyloid diseases, early diagnosis is really critical.
Yeah, a great conversation, great talks. Oh my God, I'm learning so much already from each of you. It's fantastic. So in my reading, therapy, Julie or Matt or anyone, I think you probably did mention, maybe I forgot, missed it, doxycycline plus tauroursodeoxycholic acid. Where is the data? That's one. Secondly, from a patient perspective, and regular every day, after you've seen your patients with heart disease, heart failure, whatever, their question is, what should I eat? What should I take? How much exercise? Those are the most common questions almost on a daily basis with every patient. And then some. What is that some question? What about green tea, Dr. Rosenthal? What about turmeric? Will it prevent Alzheimer's? Will it prevent amyloidosis? Is there any data, or is there a therapeutic strategy that maybe there is some evidence there? What are your thoughts on that?
One question. I think prior to 2018, most of us in the room who are practicing amyloid physicians, these are the tools that we could reach for in addition to palliative care. We were reaching for these things like TUDCA and doxycycline and green tea. I found doxycycline in the state of Arizona quite challenging due to photosensitivity, seeing lots of sunburns in our patients or GI intolerance. That being said, I think the data is quite minimal, and there's some data in some animal models, but we haven't seen seen on a large scale in human models, overall morbidity and mortality benefit, and due to potential side effects and drug interactions, I'm no longer using these in my practice. The clinical trials did exclude patients from taking specifically the green tea. I do not know about turmeric, but maybe Matt can comment on that in ATTR. But I know doxy and green tea were excluded from some of the clinical trials. So those are not agents I'm using. There was actually some data recently published for our AL amyloid patients. I think people are now steering away from doxycycline, even in AL amyloid, which used to be standard of care in that first year. We're giving doxy with the Cyborg-D. So I think the community is going more away from those more herbal or other types of agents for treatment of amyloid. To answer your second question in terms of what do we educate our patients regarding diet, I think that's a whole 1 hour lecture in terms of the supportive care from a heart failure standpoint, right, for individuals with amyloid. We talked this morning, or I talked this morning about disease-targeted therapy, but what about how we treat our patients just from a neuropathy standpoint or heart failure standpoint? Those are whole lectures in themselves. From a dietary standpoint, most of these patients I find are quite cachectic, malnourished due to malabsorption or just poor cardiac output and difficulty absorbing, so they get that early satiety feeling. So I typically put my patients on a seafood diet. I've coined this term from Eric Steadley. Not that they need to eat seafood, but meaning they see food, they eat food. You know, there's a lot of controversy for those that you attended the ACC Arizona. I was a part of a debate with a colleague from Tucson, you know, salt restriction versus no salt restriction. I do not salt restrict in my practice. I think there is great data out there for salt restriction in the hypertensive heart disease world. I think Dr. Maurer recently had a paper out in JACC with some additional colleagues, you know, on what is the optimal diet. And I think trying to tailor to your patient is probably the most important thing. And for these patients, quality of life should be at the top of our list. They're suffering in so many ways. So for me and for many people, food can bring pleasure. So I let them eat whatever they want to eat. It just might mean some extra torsemide or Lasix or Bumex, not to provide to any one department. So just let them enjoy. Maybe others have comments.
Dr. Maurer, Ellen, I wanted to ask one question before we break for lunch. So if we have a 30% likelihood of detecting the monoclonal protein with fat or bone marrow in TTR, but we have a 70 or higher percent in AL, should we be preferentially considering cardiac biopsy in patients with suspected ATTR? And the reason I'm asking this question is it takes time in some institutions to organize a bone marrow biopsy and a fat PET biopsy. And by the time you get all that back and it's negative, you have a 70% chance. Now you're going into potentially a cardiac biopsy, or you could just preemptively treat them for ATTR. So I'm just sort of wondering, I feel confused as a practitioner, what type of biopsies we should be ordering when.
That's a great question. And in fact, I had put this conversation with one of our cardiac amyloid guys at Mayo Rochester a couple days ago. But I think when there's an M protein, you don't know which one it's going to be at that point. It could be either one. So that's why we next go to the fat and the bone marrow at that point. I suppose if you're really strongly pushing for treat as fast as possible, the ideal site is the heart. So I don't think it's ever wrong to go to the heart first. But because at the point with the M protein, you really don't know which way it's going to go. If it's AL, then you have an 80% chance of making the diagnosis with something a lot simpler like a fat or a bone marrow. So it's an excellent question. I don't think it's ever wrong to go to the site of interest first.
Is it okay to treat without having the protein? Because if you have a negative biopsy, then you're empirically treating for ATTR. Is it okay to stop, there and say, well, we didn't find it in the bone or fat?
I'm not sure of the clinical circumstance you're describing, but I would be very cautious about trying to institute treatment without being sure what the precursor protein is. I mean, look, these are two very different diseases. If you see enough patients, AL is a medical emergency. So if you get light chains back and they're abnormal, these patients usually look very sick, and this is something in which you need to move quickly. I mean, in the days when we started to try to do transplants on patients with AL amyloid, the median time to death was 56 days. Now, these are really advanced AL patients, as we saw in the curves. So, you measure light chains and it's abnormal. You need to have a clock in your head, as Martha Grogan would say, and you need to get that person in and move as quickly as you can, whether it's a fat pad first, and if it's negative, then heart biopsy. TTR is a very indolent disease. The other thing, just epidemiologically, is that TTR is the tail that's going to wag the dog, right? It is going to be, as we heard, I bet 95% of all cardiac amyloid we see in the future, just given the epidemiology of who's getting, amyloid and aging. So if you do this enough, you get a real good flavor for what people have. But I would just say, if you think they have AL, call all your friends, call them quickly, your hematologist, get consults, and do not dawdle, right?
I would just echo the following. I think if we walk away from anything Dr. Hussain highlighted in this morning's talk is AL amyloid is a heme emergency. So from a cardiologist perspective, I hope that each of you think of this as a STEMI. Time is light chain, just like time is myocardium. And I would never want to treat these patients blindly. You heard from Dr. McPhail this morning, 25 to 40% of individuals with TTR amyloid are going to have some kind of MGUS. And just because they have an MGUS, they might have AL amyloid, they can have Waldenstrom's, they can have TTR. So I had a patient who I for sure thought had AL amyloid. Fat pad was negative. He went for a bone marrow and turns out he had Waldenstrom's, but didn't fit his cardiac picture. So ultimately he got a cardiac biopsy and turns out he has TTR amyloid. So his Waldenstrom's is now remission and he's on tafamidis. Interestingly, his ejection fraction remodeled, went from 20% to 65. So I'm thinking this was some light chain circulating toxicity. I don't know, but I think that we have potential to cause more harm than good if we're treating an MGUS blindly. I think many of us on this stage in this audience have seen individuals being treated with chemotherapy for TTR amyloid because they had that background of MGUS. So really, thanks to our colleague, Dr. Dahlgren and colleagues at Mayo in 2009, we developed this technology you heard about this morning with mass spec. So I think tissue is the issue. And to stress to each of you in the room, where do I go? You go wherever you can get the fastest result. Like who can help you the quickest? As Dr. Maurer said, you call all your friends. Fat pad yield is somewhat low for TTR amyloid, but it doesn't mean they don't have TTR. And the biopsy of the bone marrow too might not show TTR or AL amyloid. So you ultimately do have to go to the organ that is problematic. And I think in this day and age, cardiac biopsy is relatively safe. There is about a 1 to 5% risk of perforation, but in experienced hands, this can be done and should be done.
All right, that's wonderful. I think we should break for lunch. We'll be back at 12:45 for our keynote address.
Good afternoon, everybody. Thank you again for coming out to this inaugural ASU cardiac amyloidosis update. I think it's really a testament to all of you, as well as the individuals who organized this event, Dr. Chris Vijay, Dr. Sandesh Dev, and Janice Guzman for putting on such a spectacular event. I have the distinct honor and privilege of presenting our keynote speaker, who I believe really does not need any introduction, but here is Dr. Matt Maurer. For those of you who have paid attention this morning, you would see that there's not an amyloid project that Dr. Maurer hasn't touched over the last several decades, and it's really a pleasure and honor to share this stage with him today. He's someone that I look up to, as I'm sure many of you in the audience do. So with that, Dr. Maurer.
So it's really great to be with everyone and give this address. I would say I'm really excited about everything that's happening in amyloidosis, but we do have a lot more work to get done. I'll try to highlight that. And I have support from lots of places, including your government. So I just wanted to recognize Claudio Rapezzi, who was the co-chair of the ATTR ACT study with me, who unfortunately passed away suddenly. He was a lovely man, very curious, a real master of medicine, credited with a paper in 2005 in JACC using DBD scintigraphy. And if those of you knew him, he had what we call Rapezziisms, these ways of kind of making associations that were kind of unbelievable. So a great loss for the community. There he is presenting the ATTR ACT data at the ESC in 2018. So this is a disease that's undergone a transformation in a very short period of time. We've gone from what we thought was rare to one that's pretty common, one that required an invasive endomyocardial biopsy, to one that you can diagnose with scintigraphy, and one in which we had no treatments, to one in which we'll have a plethora. And so with that background, this is a patient that we saw at Columbia with one of our fellows who became interested in amyloid at the time. It's really a typical, unfortunate case of a 62-year-old African-American gentleman who had acute decompensated heart failure, had bad hypertension and aortic dissection, and then had, multiple admissions. We heard from one of our hospitalists earlier. Later on, he had a phenotype with a pretty low blood pressure, orthostatic. You can see he had an increased wall thickness, no aortic stenosis, even at RVH. And someone had done light chains on him, and they were abnormal. These are in milligrams per deciliter. His lambda is 29. His kappa is normal. He has elevated troponin and BNP, and they order a PYP scan, which literally makes no sense, because once you know that they have light chains that are abnormal, a PYP won't help you. And basically, we met him, you can see the timing here, but, many, many years after all these tests were done. And within about a few days of our evaluating, making a diagnosis, he unfortunately passed away. And here's a patient who one of my first cases, this was a 62-year-old gentleman, had progressive shortness of breath for 2 years. He had what people thought was a silent MI because his EKG showed pseudoinfarcts. He initially had AFib that became persistent after a few paroxysmal bouts. Then he had a cath to evaluate for coronary disease, didn't have much, but he had an elevated LV-EDP. No one seemed to notice that. They gave him ACE inhibitors, beta blockers, and diuretics. He told all the doctors he felt absolutely miserable. No one seemed to care. And basically had an echo with increased wall thickness and a preserved ejection fraction. Actually progressed to develop big right pleural effusion that they tapped, thinking it might be malignant. And 2 years later, now he's in persistent AFib, his EF has declined, and he gets crazily an AV node ablation and a BiV pacemaker. So this was a guy seen by one of my bosses, Milt Packer, and he called me and said, I don't know, everyone I thought who had HFpEF is an elderly woman with hypertension, and I got this guy who's, in my mind, middle age. He's only in his 60s. He's a man, and he's got low blood pressure. And if any of you know Milton, he could really kind of summarize some key clues to things pretty quickly. This is the guy's EKG. For those you can't see, it's got atrial fibrillation, diffuse low voltage, not only in the limb leads, but precordial and pseudo-infarct pattern with poor precordial airway progression. And this was his echocardiogram at the time we were seeing him. So he's got, wall thickness like 25 millimeters. He's got no LV chamber capacitance. His end diastolic volume is like non-existent. His atrium are like twice the size of his ventricle. And this was years ago, so we didn't have PYP. We're talking, 2002 or 3. So we did a right heart cath and a biopsy. These were his filling pressures, which are high. I just point out he has no stroke volume, right? So if he has no stroke volume, even though he's tachycardic, you can see his cardiac index is 0.97, right? And that's why his blood pressure is low, because blood pressure is determined by both flow and resistance. So if you have no flow out of your heart, you're going to have a low blood pressure. And we did an endomyocardial biopsy, as we heard, a relatively safe procedure, especially in amyloid. And you'd see pathology like this with a diffuse hyaline material that stains bipolarized microscopy, Congo red. And if you're really stuck, you can kind of do EM on the bottom right to look at the amyloid fibrils. So this is 2 cases that I wish I could tell you are rare, but they're not. And these are data from Isabel Usada, who runs the Amyloid Research Consortium, and she surveyed patients, and this is what they said. I had to wait a long time. I had to see lots of doctors, and unfortunately, the provider that misses the diagnosis most often is a cardiologist, who basically say these patients often have hypertrophic cardiomyopathy. So we've heard this morning, but just to remind you, amyloid is a disorder when systemic that is characterized by extracellular deposits of a protein. These proteins form fibrils. The proteins get stuck in the organ. They make the organ not work. And there are, as we heard, dozens of proteins that can form amyloid in various organs in vivo. But as I like to jokingly say, but probably not untrue, cardiologists are not the brightest folks don't have the brightest tools in the tool. So we only need to know 2 types of amyloid, really, AL and TTR, as we saw. And TTR comes as either variant or wild type, which for some reason we used to call senile cardiac amyloid or age-related. And again, the key here is to make sure you distinguish these 2 disorders, because they differ not only in the biology and the precursor protein, but in their outcomes, the prognosis, the genetics, and most importantly, how we treat them. So just to highlight, AL is a disorder of the plasma cell. It affects people of all ages, but I just has an equal male-female distribution. I was mentioning to someone earlier, if someone calls you with a case on the phone, it's a 40-year-old woman who has amyloid, right? It's AL amyloid until proven otherwise. Epidemiology does matter. Our heart's affected in 2/3 of the time, the kidney 2/3, so there's a lot of multisystemic involvement. And this is the disorder we saw the survival curves, where mortality is very, very bad, especially with advanced disease. All the way to the right is wild-type TTR, a disorder to date of older adult men, probably underdiagnosed in women, all of these orthopedic manifestations. And we have, as we heard, stabilizer therapy, though probably silencer therapy will work here too. And then we have hereditary or variant disease. There are 130 different variants in the TTR protein, so the phenotype is very dependent upon which mutation you have. But it seems to like, as we heard, the heart and the nervous system, as well as sometimes ligaments. And here we have advantages of silencers and stabilizers. So these are reasons, and these are 5 ways to avoid missing the diagnosis of a cardiac amyloid. So we'll go through each of these. First is you've got to think about it to diagnose it, and it should be included in your differential. So this is a really famous article by a famous educator named David Eddy. It's really great if you've never read it. In the New England Journal, he analyzed the pathological conferences in the New England Journal. If you read them every week, there's a case. And he analyzed, 50 of them, and he came up in certain conclusions, one of which was he said this was fallacious and didn't have anything to do, but more often the diagnosis was correct from someone from Harvard, but he attributed that just because they knew about the case and they heard it in the hallway. But it's kind of embarrassing to do one of these cases in the New England Journal and actually get it wrong. And when people got it wrong, which happened, the problem was that they didn't follow what he thought were these main 6 steps to, basically making a diagnosis. You listen to the, chief concern or complaint. That gives you a pivot, and you generate a list of causes, and then you kind of hypothesis test. And the key, he said, was when you have a very short differential. So you walk in the room, it's a thick-walled heart, and it's hypertensive heart disease, and you're done. You didn't create a long enough differential. So I urge you to put amyloid on your differential. Second is there's misconceptions. So we think it's rare, and we think we got some good screening tests, and we don't. So this is the impression of most providers. They're looking for a needle in a haystack, and these are the data we heard today, right? 16% of patients undergoing a TAVR have amyloid, 13% of patients with heart failure and a preserved EF and an increased wall thickness, 6% of HFpEF patients in the community, 5% overall of HCM patients. But if you're over 60, 1 in 4. And I like to jokingly say, if you walk out on Broadway and you just scan someone who's 75 or above, we just saw it was 1 or 2% of older adults going to be asymptomatic but have it. So this is not going to turn out to be a rare condition at all, even though tafamidis got approved under the FDA designation of a rare disease. So these are the data. Don't want to rush too quickly. So this is AL amyloid. It's a disease that affects 1 person in 100,000 or 10 per million. So you can do the math. There are about 3,000 to 5,000 new cases in the U.S. Even if they all live 10 years, which they don't, there's not going to be a lot of cases. This is definitely a rare disease by every designation. Variant TTR is not that rare. We heard 3.4 to 4% of African Americans carry a variant, depending upon if they live to be the age of 60. There's estimates that there are 25,000 to 120,000 African Americans who have variant TTR, and that's not including the other mutations we heard about. So I would say not so rare. And wild type disease is just going to explode because the fastest growing segment in the worldwide population are people over the age of 80. So definitely not rare, I think. I always ask people which patient has amyloid. Who says the red EKG? Just raise your hand. No one put their hand up. Well, Dr. Steadley did. And who says the green EKG? And most people, and the answer is both of these people have amyloid biopsy proven. So we taught people that low voltage is something to look for, and it is, but it's a very late phase phenomenon. So if you want to identify amyloid with someone who has 2 feet in a grave, that's when you look for low voltage. But as you can see here, in 210 biopsy-proven amyloid patients, low voltage is prevalent in less than a third. So it's not very sensitive. Much more sensitive is pseudoinfarcts, looking formally at the voltage criteria, or doing what we ask all clinicians to do, which is look at the EKG and integrate it with the wall thickness on the echo. So this is Cristina Quarta, who's a famous amyloidologist, PhD thesis with Claudio in Bologna. They took 1,000 patients, and they quickly, a third of them had HCM, a third had hypertensive heart disease, a third have amyloid. Basically, if you look at all 12 leads of the EKG, usually every lead has 10 millivolts. So it's pretty simple. It's 120 millivolts. And if you divide that by a normal wall thickness, that is a number of 12, right? If you add up all 12 leads and divide it by the wall thickness of 17, and it becomes 7 or 6 or 8, anything below those cut points are basically amyloid. So this is a very simple way. And as you can see, low voltage, not very sensitive, but specific. Increased wall thickness, very sensitive, but not specific, could be anything, but the two together, much, much better. The other thing I would just note is that AL amyloid can be diagnosed by a fat pad, as we heard, but if you have a clinical suspicion for AL and the fat pad's negative, you can't stop there. You need to go on because the sensitivity, while we talk about it being 70 or 80%, is nowhere near good enough for a life-threatening disease. And so fat pad biopsy negative, you think something's going on, got to keep working them up. You should know about the clinical clues. We heard about them all this morning, but once you know these clinical clues, it's really easy to make this diagnosis because there are a lot of them for a prepared clinician. So we talked about this, but this is a disease of HFpEF, usually without, in its later stages, hypertension, typically with in men. You can see pressure volume loops to the upper right. For those of you who don't remember, this is how we study physiology, but we are increasing, the EDPVR and upward shifting it. And what happens then is the end diastolic volume goes down, and so does the stroke volume. So your EF stays the same because the numerator and denominator are both going down, so the EF is preserved. But the cardiac output, as you can see in the black line, goes down. And what happens to their blood pressure? It goes down over time. So you're removing antihypertensives. They're getting on less and less medications. These are patients who always have an elevated JVP and right heart failure. As I said, I'll show you some data. They don't like ACE inhibitors or beta blockers. If you're looking for a big tongue and periorbital purpura shown here, for TTR, you're never going to find it. It doesn't exist. It exists in AL amyloid. But for TTR, as we heard, there are lots of orthopedic clues. So we know about bilateral carpal tunnel syndrome. This is lumbar spinal stenosis. I call it carpal tunnel of the spine. I'll show you data, about a third of patients with TTR have it. This is the famous Popeye sign. So you can look like Dr. House with the resonance. If someone has a biceps tendon rupture and their biceps muscle looks like that, and they have a thick-walled heart, you don't even need to do a PYP scan. Literally, it's diagnostic. I mean, you should do it, you will do it, but you could look pretty erudite on rounds. And these are the data I was mentioning before that we recently published with Maz Hanna, in which the big new news here is 83% of wild-type patients have an orthopedic manifestation, and in addition to hip and knee replacement, shoulder surgery and shoulder issues are very common in these individuals. And you can see the hazard ratios, there are odds ratios compared to population-based samples, much, much higher for knee, hip, and shoulder arthroplasty. Most of us, unfortunately, don't diagnose things by history anymore or physical exam. Unfortunately, we wait to the image. And so if you're waiting for that, which is fine, there are also lots of clues, which we'll run through. These are the still frame echo images that we are all looking for. So there's increased wall thickness, always, usually in amyloid. It's not symmetric, by the way. By MRI, it's symmetric in 17% of the patients. So just because it's asymmetric doesn't mean it's not amyloid. They have, as we heard, a thickened intraatrial septum. They have valvular thickening. Their atrium get big. Early on, they have diastolic dysfunction. But if you miss the boat, like in our patient, they'll end up with a low ejection fraction. So that's clearly a late phase phenomenon. And we heard about pericardial effusions. MRIs are very useful. This is what I used to call the peak and the squeak test. A colleague in New Jersey followed someone with a myopathy for years. They didn't know what it was. They got an MRI. It showed relatively preserved LV systolic function and diffuse enhancement. At the bottom, it said, think amyloid, and they went, ah! And they referred them off to the amyloid center, in part because they were, unsure what to do and also a little embarrassed that they didn't kind of sort it out sooner. So this has become a source of referrals. This is the apical sparing we heard about, highly sensitive and not so specific. You can see this in chronic kidney disease and hypertension, but quite useful, which leads to the apical sparing. So lots of clinical clues, right? And you should really understand the non-biopsy diagnostic approach because that's critical. But there are a few pitfalls, and we're seeing this more and more often as awareness goes up. So again, endomyocardial biopsy is not a bad test. It's really hard to do the worst thing in an endomyocardial biopsy, which is perforate someone when they have amyloid, right? It's a thick-walled heart. So if you're ever in doubt, I'm sure my colleagues who are nodding their head who do this all the time agree this is a pretty low-risk procedure. These are our data that people highlighted previously looking at PYP scintigraphy. Remember, Claudio published this paper in 2005 using DBD. We wanted to use DBD. It's not available in the US. It's actually not true that the only isotope is PYP. We learned during the sourcing pandemic issues that HMDP is available in the United States and can be used. And those of us who knew that kept doing scans, and those who didn't were like, oh my God, what are we going to do? So both are fine. MDP is not fine and doesn't work, so don't use MDP. And this is how these scans are graded, right? 0 is no uptake. We heard 1 is uptake less than the heart. 2s and 3s are positive. But the bottom line is you can't use planar imaging anymore. You must do SPECT imaging, right? You have to know that the uptake that you see on the X-ray, the planar imaging, is actually inside the myocardium because it could not be. It could be, as we heard, blood pool. And so these are the current, diagnostic criteria, and I highlight the important things here. You can make this diagnosis non-invasively with a PYP or HMDP scan if they have a phenotype that's consistent with amyloid, right? Don't scan someone whose EF is 10 with an 8-centimeter ventricle and a thin-walled heart. That's not amyloid. That's not what it looks like. It doesn't have amyloid that way, right? So they should have a phenotype that you're suggestive, or they should be a variant carrier, right? You must obtain monoclonal proteins. You can't order a scan without ordering the monoclonal proteins. If you do, and you do it without monoclonal proteins, you're committing malpractice. And I jokingly say to people, I will now testify against you, right? Because it is malpractice, right? You can't interpret the test. If the monoclonal proteins are positive, you can't use the PYP. You need to go on, as we heard, to biopsy. And you have to have grade 2 uptake, but you need a SPECT scan. So we tried to highlight some of these errors in a paper in JACC. Maz Hanna led the charge here with Martha Grogan and others. But you can see in the upper right is a patient's got a floridly positive PYP scan, right? It's in the myocardium. But this person has AL amyloid. Turns out 25% of patients with AL amyloid are going to have a positive PYP scan. That's why you need to get monoclonal proteins. Then there's, and this Venn diagram is the embarrassing one from Columbia that we published. These are people who came for our Center for Clinical Testing, and you can see how many got all 3 of the appropriate tests in the middle, only 40%, right? So doctors are ordering PYP and not ordering the monoclonal proteins. Second one is, I just highlighted here, here's a grade 2 scan, but when you do SPECT imaging, what do you see?
the isotope is inside the chamber. This is not in the myocardium. This is a false positive PYP scan. And then if you do this long enough, you will run into some unusual mutations or variants that don't uptake PYP. So this is, a paper we published about PYP use at our center. Now we're up to like 300, 400 scans a year. As Dr. McPhail was saying, we don't need to do a lot of biopsies. You can see the blue is the biopsies. It's under 10% of the time that we need to do a biopsy for a patient. And it's a pretty good test, I would just point out, because about a third of patients, you can see in the line, are positive. So what test do you do in medicine where 30% of the time are you making a clinical diagnosis? It's not perfect, though. So people who had grade 2 scans, when we used SPECT as the quote-unquote gold standard, 64% of them were blood pooled, not positive scans, right? Not positive. So in the community, we're seeing a lot more of this planar imaging, people getting on tafamidis, and they don't need tafamidis. It turns out the overall false positive rate's almost 10%. So screening is great, but, you'll see, screening could be associated with some problems. So this is what I call the amyloid cascade. For decades, we were kind of all the way up here looking at symptoms in the EKG and low voltage. We use the echo once in a while, but now we have, techniques that are a lot more sensitive. In fact, you can have a normal wall thickness in a positive PYP scan, and you would really identify someone who's asymptomatic and early in the course of the illness. So these are very busy, I apologize, but this just shows you how much PYP enables an earlier diagnosis. Everything about the patient tested in our lab with PYP versus biopsy is better. New York Heart Class, biomarkers are lower, all of their staging systems are better, blood pressure is higher, stroke volume. And the key then is that translates into better survival, not because PYP scanning is doing anything interventionally. It's just you're finding people in an earlier stage of disease, which is where we need to find them to leverage therapies. And for those of you who don't know, there's a fantastic paper by the London group in 20 years, like 2,000 patients, and they showed this unequivocally. Why? Because tafamidis is not available in the UK because it's too much money. They didn't pay for it. And in our data here, just to show you, the older you are, like all things, the greater your mortality per year, right? If you have variant disease, you tend to do a little bit worse. But you can see if you're diagnosed by, PYP, you have a lower mortality, right? And stabilizer therapy is, in this multivariate model, still highly effective. So all of these things are leading to much better outcomes. So the algorithms, I'm never a big fan of algorithms. I quote Joe Alpert from Arizona, the editor of the Green Journal, between every algorithm and a patient needs to be a provider with a brain. Make sure that you know what you're doing, because every algorithm, if you follow it blindly, could lead to problems. But this is pretty simple, right? You basically check for monoclonal proteins, do a PYP scan, and do genetic testing. And that doesn't mean you have to do one on each day. You can just bring them in and do all three on the same day, and you're basically make a diagnosis pretty quickly, assuming, again, they don't have monoclonal proteins. If they do, you have to go down the other pathway. And then, I think we really want to, as we've been talking about today, figure out ways. I give you credit at this meeting because it's one of the first to think about what I call active ascertainment. I'm not so sure this is screening because people have this disease per se, but maybe it is. And all these therapies work better when they're started earlier. So, sorry, this is the landmark tafamidis paper, and we heard from Dr. Rosenthal about how it works. It binds in the dimer-dimer interface you can see here, and it prevents the protein from dissociating. Really an unbelievably effective, well-tolerated drug. Unfortunately, it costs too much, but this is probably the most important unpublished data from the trial. So in the trial, there were 37. There were 441 people in the trial, 37 with NYHA class 1, less than 10%, right? And they had the confidence intervals in this example are wide, but just look at the point estimates. They had a 64% reduction in mortality, whereas those with class 2 had a 39% reduction in mortality, and those with class 3 only had a 16%. So very clear evidence that if you start this drug earlier, I mean, where else do you see more than a 50% reduction in mortality, right? I mean, like, kind of amazing. And so this success of the ATTR ACT trial has led to, as you can see over the timeline here, just a plethora, as we heard about, of new therapies that are coming down the pipeline. So what can we do for screening? This is one of the first papers we got interested in with Adam Castano. This is what we call the UNVEIL study, in which we took consecutive patients undergoing a TAVR, and we found out that 16% overall had amyloid and 22% of men had amyloid. So you could start screening all the patients who are getting a TAVR. Becky Hahn, a famous echocardiographer, taught me that you can just look at the echo, and if the S wave on the echo is less than 6, everyone who has amyloid has an S wave less than 6 in this trial, because she helped us read the echoes. And you got rid of 50% of the patients who didn't need to get screened. So this now brings the yield to 44% in men. So that would be an approach. Everyone getting a TAVR gets an echo. This is a study we did more recently, screening with our colleagues Finn Gustafsson and others in Finland. And you can see here they have a national healthcare system. We basically found 1,179 people who had bilateral carpal tunnel syndrome. We called them up and we said, hey, you had this surgery 10 years ago. Do you want to come in for screening? And we heard that in men who are over 70 with a low BMI, by the way, clinical clue, no one with amyloid, almost nobody is fat. Almost nobody. We published the data. A BMI over 30 has a 98.5% negative predictive value. HFpEF is a disorder of older obese individuals, but not amyloid in our experience. But you can get 1 in 5 men who has this particular phenomenon. So definitely a very high yield, I think. And they summarize the data here. You can see this, 1 in 4, 1 in 5 prevalence in older adult males. So we have a screening study that was funded by your government called SCAN-NP, in which we're focusing on minority populations in particular because they have the variant that we talked about that's common. It's called SCAN-NP with Rick Ruberg, and we're trying to, again, advance early diagnosis by screening. This is an 800-person prospective cohort study. We have 3 sites: Columbia, affiliate with Harlem Hospital, Boston Medical Center, and now Yale University. And we're doing phenotyping on patients with increased wall thickness who are over 60 who have a clinical heart failure syndrome. Can't tell you all the details yet, sorry. Still actively ongoing. We're at about 480 of the 800 subjects. This is a study we did with NIA funding that led to a grant that we're thrilled to be working with Mayo Clinic and Ellen McPhail on. So in 47 patients at our center who are undergoing back surgery, we basically said to the surgeon, please don't throw it in the garbage, just give it to us. We stain the tissue, and as you can see, 35% of patients had amyloid in their spine. When we sent the tissue to the Mayo Clinic to figure out was it TTR, we found out that 2/3 of it was TTR, much more commonly TTR as they got older, but not everything in the spine was TTR. Many of the times, 1/3, it was undefinable amyloid, and who knows what that means and whether those patients are going to develop TTR. If they're not, we're going to start screening lots of people who have amyloid on biopsies in Congo Red, and it would imply a critical role for mass spectrometry to figure it out, or maybe they will develop amyloid and then mass spectrometry won't be a critical. So we have hopefully going to start soon a prevalence study in these individuals at 5 centers, and then amongst the patients who we find amyloid in, they've had back surgery on average 10 years earlier. We're going to call them up and say, hey, we found some amyloid in your spine. Why don't you come on in and get tested to see if you have it in the heart? And if the data in Finland are correct, we're going to find lots of patients who are relatively asymptomatic but have a disease. So we're excited. Rick Ruberg and I wrote this, though, and I think it's really important if you're thinking about screening, and that is the following. This is the validation studies that have been done. So the Gilmore paper that we all cite from Julian and me and colleagues, half the people in that study of 1,300 had amyloid. It's really easy to use a test when 1 in 2 people walking into your office has amyloid, right? So PYP scanning, we saw 90% sensitive, 100% specific when you exclude monoclonal proteins, but 1 in 2 people in this study had amyloid. So the pretest probability is hugely high, so your positive and negative predictive value are very high, no matter what test you have. If you start screening people and they have a 5 or 10%, you will have, a very high negative predictive value, but your positive predictive value is going to go through the roof. You're going to start finding people who you think have amyloid and they don't. And so it's going to be really important to use clinical features to increase your pretest probability and to make sure you're doing the scanning test really, really, really appropriately. You need to scan with SPECT. You need to probably scan at 3 hours to avoid the blood pool at 1 hour in low pretest probability populations. So the second thing I was asked to talk about, which I'm going to try to run through quickly, is this very important question. Now that we have all these patients and we're taking care of them, how do we follow them? And the short answer is nobody knows, right? I mean, if someone tells you dogmatically that they know exactly how we should be following these patients, we don't know that. And we really do. But this is the most common question, right, we all get, which is, hey doc, how am I doing? Is this tafamidis thing working? Is the other drugs? So there's a good rationale for screening, right? For following patients, right? Hopefully you're going to alter, intensify. Maybe you're going to get rid of certain therapies. Lots of these patients develop conduction disease and need pacemakers. We're actually trying to apply right now for a multi-center grant for BIV pacing that the government's interested in around the country for patients who have amyloid. We have reasons to think of a BIV pacemaker. People who develop atrial fibrillation may need to go in sinus rhythm. And then the thing is, if we have 3 or 4 therapies approved, how are we going to switch? Which one are we going to use? If you think insurance companies are going to let you give 2 drugs that cost $750,000 a year for an 80-year-old, you're dreaming, right? I mean, the pre-certification process will be cuckoo. So let's just talk about some of these and the data that we have. So this is the patient I showed you before, who you can imagine has a blood pressure of 80/40. He has progressive, as we saw, diastolic dysfunction, reduced what I call LV capacitance. His ventricular chamber is small, his EDV, and his blood pressure is falling. And so there's an essential role in this patient to stop medicines, right? Be a geriatrician, shut off the heart failure therapies because they're not tolerating them. And we investigated this in our database with Richard Cheng. It's actually been published in JAHA, and these are the data on outcomes in 150 TTR patients for beta blockers and ACE inhibitors. For mortality, the answer is no benefit. But Richard, because he's astute, found this. I see patients, they weren't feeling well, I shut off their beta blocker. So in blue are the people I shut off the beta blocker, and in red are the people I didn't. By the way, I would usually shut off a beta blocker in sicker patients, right? You could imagine. And the hazard ratio for deprescribing the beta blocker is more than 50%. I saved more than 50, I reduced the chance of dying by more than 50% by simply stopping the beta blocker. So you want to kill your amyloid patients, give them a high dose of beta blocker. That would be a sure way to do them in. They have a low stroke volume, and they need a faster heart rate. Don't assume you're smarter than the physiology of the body. I think there's a big role for SGLT2 antagonists. Personally, we don't have a lot of data. One of our fellows is conducting a study right now. We now give this to everybody with amyloid, and the reason is, as Richard showed, one of the things that predicts mortality in these patients is the dose of their diuretic. And you can see survival is much worse. The more loop diuretic you're on normalized for your body size, then obviously one way to keep them euvolemic might be and protect their kidneys might be an SGLT2. So food for thought, and people are interested. These are the data from a patient in my colleague, Dr. Nabobian's open label study. This is a 90-year-old lady who has an NT-proBNP of 10,000. Over 12 weeks, her NT-proBNP went down to about 8,000. She basically, the red is what would have caused us to stop. So if her creatinine, which was already high, would have went up by 30%, or EGFR, that would have been the stopping rule. And you can see in this study, her creatinine remained stable, and she required actually less diuretics. And that's what we've observed in this 15-person open label study so far, that we usually get rid of the metallazone if they're on high dose or cut their torsemide quite a bit. These are data from Brett Sperry, in which he took the TopCat trial. No one knew in this trial, a HFpEF trial, who had amyloid, but he looked for features that were suggestive of amyloid, low tissue Doppler signals, and he then analyzed the outcomes of patients who got aldactone, who he thought had amyloid and didn't, and aldosterone antagonists had a mortality benefit in patients who had a phenotype that looks like amyloid. So we often give them MRAs. Second is pacemakers and bradycardia. So this is a new focus of our attention. These are data from Claudio's group again, poor Claudio. But these are 3 risk factors for developing a pacemaker or need a pacemaker in amyloid. A, atrial fibrillation. B, first degree heart block. Can't have the 2 at the same time, but you could look back at their historical EKG and see, do they have a wide QRS? And just to highlight, if you have all 3 of those things, you have a 40% chance of needing a pacemaker within 12 months. So those are people who, you should start maybe doing long-term monitoring on and check. This would be, I think, a really good place to think about a BIV pacemaker. Why? Because these patients become pacemaker dependent like the minute you put the pacemaker in, right? And the electrical conduction system is frayed with amyloid. They have a stroke volume of, 45 mLs, index is 25 mLs, and now you start to RV pace them. So their cardiac index, which was 1.8, now goes to 0.8. They don't feel well. And there's data shown here to say that physiologically it makes a lot of sense. And there's even a case control study, not the greatest evidence, in patients from the Cleveland Clinic showing there's a survival benefit. So we think this is the right thing to do, and that's why we're advocating to the government to fund a BIV pacemaker trial in which everyone will get a BIV up front, but for 6 months we turn it on and turn it off to get the information. So this is the bane of everyone's existence in general cardiology. I call AFib the most overtreated heart rhythm in the world. But should we restore normal sinus rhythm? I have no idea. This is my approach to AFib for all patients, amyloid or not, and that is the 2x2 table of, are you really symptomatic or not due to your AFib, yes or no? And are you likely to stay in normal rhythm if I jump through 15 hoops, right, and start, And so, it's very easy for someone who's really symptomatic, right, and highly likely to stay in sinus rhythm. But no one with amyloid is highly likely to stay in sinus rhythm. It's really easy for someone who's got amyloid who didn't notice that they were into AFib and nothing's different about them. I don't do anything by the X. But there's a lot in the other groups. And the question really here is you just got to get down to shared decision-making with the patient and chat with them. These are the data over 40 months about who's going to stay in sinus rhythm. And the bottom line is early amyloid patients might stay in sinus rhythm after cardioversion or AFib ablations, but patients with advanced amyloid almost never do. So I don't rush to do things. And then this whole question of, well, what if we had 2 or 3 treatments on the market, which we may soon have? How are you going to decide what to switch or what you're going to do? And so, again, these are the current across the spectrum of disease. We use tafamidis, but certainly for those who have neuropathy with a cardiomyopathy, and I think all my colleagues in amyloid use silencer-based therapy. We think it's potentially going to be better. So this was a paper that was written by very famous and important folks in the world of amyloid. I wasn't a co-author. I don't want to pick on it, but they made this up. It's a reasonable starting point, but there are a lot of holes in this. So I just want to, but these are the things they suggest about monitoring patients. You should look at them clinically. You could look at lab, and you could look at the EKG. So let's touch upon each of these, the clinical ones. So New York Heart Class, a recent hospitalization, are they taking more diuretics or performance-based measures? So New York Heart Class, fantastically prognostic, you can see there, right? Like the dose of diuretics, fantastically prognostic. So we use those to modify the Mayo and the NAC staging system. And it turns out they really improve the AUC. And so this is what we call the Chang or Columbia score after Richard or our data. But it's much, much better than the others if you wanted to refine risk. And the 2 things we're adding are New York Heart Class and how much diuretic they're on. So it's really not terribly complicated. It's a score 1 to 9, and you could put people into early, middle, and late. 6-minute hall walk. Well, that would be great if we could get the staff and everyone to agree to do it at a set period of time, because their 6-minute hall walks definitely go down quite a bit over time. And as we saw, while tafamidis doesn't make the 6-minute hall walk better, it prevents the decline. So I endorse that. And we know that this disease is not linear in its progression. And so probably when we're doing testing, we may need to do testing more frequently, at a certain point in time. So you can see here, people are pretty stable on this curve functionally, where here, people are falling off the curve. And so probably as people progress, we may need to change the frequency by which we monitor patients. Frailty, very, very common in these individuals. This is what we call the clinical frailty score. After the Dalhousie University, 1 to 9, and you can pick. And this was evaluated by the group in Canada in circ heart failure, and you can see there were people here who were not frail in a CFS 1 to 3, pre-frail 4 to 6, and frail, and everything about them was much different. But interestingly, tertiles of frailty score were independent predictors of outcomes in these patients, independent of their amyloid stage in New York Heart Class and treatment with tafamidis. We've actually become really interested in this, which is called the short physical performance battery in my lab. So this is a marker of physical function, involves 3 items. It's your balance. Can you put your feet together and hold it for 10 seconds? Can you put one foot slightly in front of the older hand 10 seconds? Can you do a tandem for 10 seconds? You got 4 points if you can do all of that. Second is we do gait speed, right, in meters per second. And then the final thing we do is chair stands. So the reason we like this is we don't have to get a hallway, we don't have to block off things and so forth. It takes about 5 or 10 minutes to do. And it's very, very predictive of what happens to patients. For those of you who read the Rehab HF trial in the New England Journal, Delane Kitzman used this as the primary endpoint. So these are data just from our center that we're collecting, you can see. And here in ATTR patients, one of the biggest problems they have is the chair stands. They have a lot of, someone was mentioning muscle loss before, but they seem to do much worse. And we're measuring it in scan NP as well. laboratory tests. We have lots of biomarkers, and we can easily not only risk stratify patients, but we can follow them. So these are the two staging systems, one developed by Martha Grogan using NT-proBNP above or below 3,000 and troponin T above 0.05. And the other staging system is the Gilmore staging system, which uses the same NT-proBNP cutoff, but an EGFR, renal dysfunction, above or below 45. So you can tell someone, you know, are you early, middle, or late? I would make sure patients want to know their prognosis before you tell them, right? Many people don't want to know. Often the wife wants to know, but not the husband. You know, you got to be a little sensitive to all this. It turns out these, no surprise, biomarkers are highly prognostic over time. And so you can see here, these are changes in the NAC stage at 6 months, 1 year, and 2 years. The stage changes, people do worse. And you can see the hazard ratios here for changes in NT-proBNP. So a 10-point change in their NT-proBNP and the weekend call on Saturday was, what does it mean? It went from 1,000 to 1,010. It means nothing, right? You know, but a 500, 1,000, or 2,000 point change, those really have meaning for patients. If you really want to get into the weeds, it turns out uric acid's really high in these patients and is prognostic, independent of their diuretics. Maybe SGLT2s will modify that risk because they lower your uric acid. And if you want to prove to a patient that tafamidis is working, they always want to know, is it working? You just measure their prealbumin before they take tafamidis and after, and it goes through the roof. Obviously, if we start silencer-based therapy, the prealbumins are going to go down. It's going to be confusing. But these are the changes that we see in patients that we published on. And then, not finally, but we can always use, you know, all these sophisticated cardiac testing. So EKGs, well, there's lots of AFib, there's lots of conduction disease, and then there's lowering voltage over time. And these are some of the findings that you could look at and see. This is the data I showed you about Claudio Rapezzi's, about who needs a pacemaker. So pretty common. I think that's going to be the new horizon. These drugs work seemingly well for heart failure, but they're not really affecting, in my experience, patients' risk of AFib and their risk of needing a pacemaker. So it's just that they're just plodding along in that regard. This is what my nurse practitioner won the Heart Failure Society Nursing Award for. We stuck Zio patches on 50 patients, expecting to see lots of heart block. We saw a new onset AFib in about 8%. New heart block that was bad enough that we're like, hey, buddy, you should come in. You had an 8-second pause. You need a pacemaker like soon in 8%. So a yield of about 15%. And ugly, hair-raising, oh, my God, what's happening, VT in like 70%. And that has no prognostic significance. So you can order this test, but you better be prepared not to start sticking a defibrillator because you're going to put a defibrillator in 7 out of 10 amyloid patients because they have a lot of VT. I think this is a useful thing to do, and the frequencies probably should be modulated based on how severe the phenotype is. What can we do to measure amyloid load? So patients always want to know, how much amyloid do I have, and where is it, and what's happening? And the answer is, this is not yet, I think, ready for prime time outside of research, but these are the things we could do. And as you can see, as we do more and more, it'll get more and more costly and it'll be less widely available. But if we're going to spend $250,000 a year or $500,000 a year, we may end up needing to get some tests to figure out, are things really better or worse in this regard. So these are the data from the ATTR ACT trial, just to share with you. This is the wall thickness change between tafamidis and placebo. We're talking about less than a millimeter change in both. So you could stare at the wall thickness, and if the patient is asking you what their wall thickness is, you can tell them. But I usually say, if your wall thickness changed a lot on the echo, it's because a different reader read your echo, not because your wall thickness changed. Because this is over 30 months. It's less than a millimeter, right, in hundreds of patients. So you can't use that. EF didn't change. Stroke volume is where the money is, as I said. But you could look at that. But these are pretty small changes of, over a long period of time. And GLS, everyone talks about, didn't change. It turns out that the things that did change are circumferential and radial mid-strain. So we're not even measuring those usually clinically. But we could look. Maybe quantitative bone scintigraphy is a good idea. There are ways using CT to quantitate, and these are provocative data from a center showing that the PYP scan with CT quantification and so forth tended to change over time. Maybe that'll be a marker, but we're just starting to. I don't have a lot of confidence per se in that. There's also these reports that are coming out with silencers, particularly, that PYP scans can become negative, right? They go from grade 3 to grade, a half. So I'll touch upon that in a minute. These are data from the NAC to the left with patisiran. Patisiran didn't change the ECV, whereas patients who got placebo, they got worse. So things weren't getting better, but you could use ECV. And these are data from a center also looking at tafamidis versus historical controls, where they also measured MRI and there were some changes. But these changes are pretty small on group averages. Maybe as you're following an individual patient, it could hold some promise. These PET imaging agents, I think, are really where the money's going to be. So this is florbetapir, and then to the right is what we're using at Columbia, a compound made by Jonathan Wall. It's a small peptide that he's labeled with I-124, and it images amyloid all throughout the body in every organ, and you can get really fantastic images, and then you can quantify. How often will we do this? Once every few years is my sense, right? I don't think it's going to be like sarcoid, that it's going to melt away in 3 months, you know, with just steroids. But this is an interesting patient, I just point out, who we had in the Helios A trial. And the argument here is we're going to need multimodal imaging. So if you can see in the upper, here's his baseline. You can see he's got a PYP that's positive, right? He's got, a clear grade 3 scan, and you can see on SPECT, there's, the circles there. And then we gave him silencer treatment, and we were kind of intrigued. So we did another PYP scan. All my colleagues called me and said, why'd you order another? I was like, I was just curious. I wanted to see what happened. His PYP's gone. I mean, there's no uptake anymore, right? So this is cool, right? And it's about, 30% of patients with silencers this is happening to. We then brought him in for the PET scan, right? This is his PET scan with the Jonathan Wall compound. His heart's full of amyloid still, right? I mean, so we never knew what PYP was even binding to. We heard earlier it's microcalcifications. It's not measuring the amyloid load. And so the changes that we're going to see with CT scans and those, I have a lot of suspicions about and worry that we're going to make some misconclusions. So these are the things that we could do, but I just point out, I think there's a big thing that was missing, and that is, remember, we're all doctors, just talk to the patient, right? Just ask them how they're feeling, and these are the most engaged and erudite patients I've ever encountered in my career in cardiology. They know what's going on, they can monitor their biomarkers, and so just provocatively, these are not amyloid data, these are serial KCCQs that were given to patients remotely in an ARNI trial paradigm in which they just measured it. And guess what? The patients, when they were feeling worse on their KCCQ, that predicted their hospitalizations. And they got better after them. And so I think there are ways that we can really engage patients in a much better way. Certainly, all of this testing and everything is going to require, as you have at your centers, a bunch of experts, right? And it's amazing to see all the individuals whose expertise is essential, right? I mean, you can't do this without a hematologist and a fantastic neurologist and pathologist. It's not a cardiac disease. So it's going to require multidisciplinary care. So I'll just stop by saying early identification of patients is feasible. We don't know what the best strategy is, right? So you want to create a screening program, great, but don't tell everyone you've got the best one. We have 5 or 6 that are ongoing. I'm convinced that there'll be a screening strategy, in a guideline, but I have no idea. Is it lumbar spinal stenosis? Is it carpal tunnel? What we need to do. That's an area of science that should be checked out, determined to be cost effective. Even more in its infancy are how we monitor these patients. So I encourage everyone who's taking care of patients to just get a database together and record what you're recording and see, because you may teach us all that there'll be, a better way. And certainly we're going to need that in order to optimally take care of people, because if we got to choose between therapies, we're going to have convincing, or add a second therapy, we're going to have convincing data. I think we got a lot to learn from implementation scientists. I'm not those folks, but they know how to engage patients a lot better. Really in our shared mission of optimally monitoring disease. And we really got to, bring the patients into all of this, and they are really fantastic partners. So again, thanks for allowing me to come out west. I really appreciate it.
Well, we can have some time for questions.
Thanks for the fantastic talk. One of the things that at least I've struggled with on the neurological side is the asymptomatic or perhaps pre-symptomatic family members of affected patients, and just wanted to get your thoughts on that.
Yeah, I mean, I think it's really, look, I mean, we have enough to do, but remember, as you're pointing out, there are lots of allele carriers out there. So, I jokingly say to the companies in this space, they're like, who can we find and screen? I'm like, just screen the family members. You want 50-50 yield? If they have a brother or sister, there's a 50-50 chance. I think they probably have a phenotype more than certainly cardiologists know. So, I wish we had more bandwidth. I mean, my sense is that neuropathic findings are occurring much earlier than the cardiac findings. There are very subtle things. We try to do COMPAS questionnaires in patients, and they often report a lot of, as you were highlighting, autonomic symptoms that may be subtle. I'm professing we don't know. We just got a grant with, I didn't get it, Justin Grodin, for those who don't know, is at UT Southwestern. Fantastic amyloid individual. Julie knows him well. He got an R01 for V122I patients, in which at the Cleveland Clinic, Columbia, and UT Southwestern, we're going to be doing MRIs in allele carriers, because he has some evidence that they actually have a phenotype in their hearts beforehand, before all of these things change. And so if the goal is really early diagnosis, that may be useful. The other intriguing thing that my former colleague, Alan Castano, when he went to industry, he was working with Eidos, who makes acoramidis. So tafamidis is the stabilizer, acoramidis is the next generation stabilizer. They had planned, they bailed because of certain issues, but they had planned to do a prevention trial. So actually to give allele carriers, these drugs. What do I do for patients? When I find someone who's got, a variant disease and is asymptomatic, but is close to when I think the disease could penetrate, I talk to them about diflunisal. Every single one of them. And I usually give them, if they're willing to take it, diflunisal. Do I know that that's the right thing? I don't. But I mean, I watch their parent, God forbid, die of a miserable disease. They watch their parent and they're pretty motivated. Now, if I wouldn't give diflunisal to a 30-year-old who's got, 30 years before they're going to develop the disease, but you could argue that there's probably a right time to do that. It's an individualized decision. Obviously, the risk to nonsteroidals that you take every day, and people have to be aware of that, but we're giving a dose that's below the nonsteroidal dose. So those are some free-flowing thoughts. I don't know if that addresses what you're talking about, but I think early is the name of the game, and with allele carriers, we need to be a lot more vigilant at really getting them into the multidisciplinary team and scrutinizing them, because cardiologists miss it, I think, often.
Could you comment on anticoagulation of
Yeah.
this patient, please?
Yeah. So they get anticoagulated if they have atrial fibrillation, irrespective of their CHADS VAS score, right? So you see AFib, they should get anticoagulated. Doesn't really matter whether you give DOAC or warfarin. In our experience, emerging data suggests that is true. Often all these patients go on a novel anticoagulant. Some interesting things that we've observed. So the London group has published this phenomenon of atrial electrical mechanical dissociation, which basically is they're not in AFib, but their strain on their atrium is non-existent, like they are in AFib. That is 22% of patients with TTR amyloid. 22%, right? So you wonder, amyloid, as we know from data from the Mayo Clinic, is very thrombogenic, AL more than TTR, but the worst thing that can happen to a patient is having a stroke. We probably need to anticoagulate them maybe even sooner than we're doing. So here's my quick observation. V122I is a much worse outcome than wild-type disease. V122I almost exclusively affects blacks. Who has more AFib with amyloid, blacks or whites? Whites, by far, statistically significant. In the general population, who has more AFib, blacks or whites? Whites. There's actually a risk score for AFib, and it includes race, nationally published from many studies. But when you develop AFib in the general population and you're black, or with amyloid, your risk of having an embolism is even worse, much higher. I think that African Americans probably have an atrial cardiomyopathy. They may be resistant to developing AFib, and when they develop AFib, they're worse off. If all this holds out, I bet in 10 years, amyloid may lead the way to a change in general clinical practice. I'm not sure we should be anticoagulating people just because of AFib. We should be anticoagulating people probably because of the atrial cardiomyopathy. We may get to a point where we really just look at the atrium and go, this is the person who needs it. Right now, we're doing something downstream. That's all, hypothesis generation. But what happens in amyloid seems to mimic what happens in the general population. So.
Thank you again.
Yeah.
As a non-cardiologist, I learned a lot, but my question to you is, I think there should be a standard of care for screening, considering the high percentage of occurrence or prevalence of, amyloid. So are we going to develop those criteria that you had listed, echo criteria and the biomarkers, as a means of putting something into a screening plan? Just like, we have smokers and we screen them for AAAs. I think now time has come, but with our aging population, we may need to develop new screening, guidelines.
Yeah, I completely agree with you. I'm just trying to profess to you that I think it should be scientifically based. And so, there are lots of benefits to the screening, right? We all have all these clinical clues. It's somewhat of an unusual disease, but we can find it early. It all seems to make a lot of sense, but there are lots of things in medicine that made a lot of sense that didn't work out so well. And look, from a screening perspective, everything's been met except cost effectiveness. If you look at the WHO criteria, but that's important, right? Are we going to have too many false positives, right? Part of the impediment to all this, I don't mean to, is I've been saying it for a long time, is these drugs are way too expensive. There's no way that this could ultimately be that cost effective per se. So don't misunderstand. I'm 100% enthusiastic about a screening approach. But when you say to me, well, which one should you use? The answer, I think, honestly, should be no one knows yet, right? Try one in your center, see what you're going to do, collect data, and so forth. We're planning to pool the Finnish data, our own ScanNP data, Omar Aberdessi's data, and try to put it all together. We have different things, but no one's, and I'm not sure, like anything, it's going to be 100%, exactly what you want to do for everybody, set. There may be different approaches. As we heard, when you're 95, my dad's 101. Unfortunately, he's not doing well. He probably has amyloid. We didn't screen him, right? We just were kind of like, he's got too many other things going on. My colleague's like, I love you, Matt, but I'm not going to look for if he has amyloid. I think she's doing the right thing, so.
I had a question too. What are your thoughts and experience in using cardiac MRI to diagnose?
Yeah, I was a big naysayer, I have to say. Years ago, I made that joke about the squeak and the peak because I was kind of annoyed. No one was really looking. I think it probably does have a pretty big role. Especially, what I was trying to make a point, I don't know if I made it well, is that when the pretest probability is very low, when you start screening, right, you're going to look for one patient out of 20 or 1 out of 10, that's really low prevalence, right? We're not what we've done. Then we're going to need some better techniques. And I don't know what the right ones are, but MRI seems to be, one that can really suggest the phenotype in a lot more specific manner. So the biggest concern I have about screening, like I said, is given the current data that we have, PYP scanning is going to be wrong 50% of the time if we don't do it really well, if you're really looking at 1 in 10 people. And it's not me making that up. We've known that. Here's an example, right? Stress testing for coronary artery disease. It looks fantastic when you stress people in 1970, all who had left main and 3 vessel disease, and, it was always positive. But we've all taken care of women who have like an isolated circ lesion and the stress test is negative or it doesn't reveal things. So when your pretest probability declines, it's an old, well-proven epidemiological phenomenon, screening tests don't look as good. So I think you as clinicians have to be a little cautious about, who you're looking for. I can't, every month now, I'm sure at every major center, we see someone who comes in someone suspected amyloid, they don't have amyloid, right? Or worse than that, someone who's been on tafamidis for 6 months, spent the $3 or $4 grand for the first month, $1,000, and now they spent 10 grand or 5 grand, whatever, out of pocket, and you tell them, sorry, you don't have amyloid. They're like, well, why'd I get on this drug? I'm like, I don't know. Be enthusiastic, but be, I think, sensible is my point.
I'm sure we have more questions.
Can you explain again why the patients with cardiac amyloid don't do well with beta blocker?
Yeah, so I wouldn't say at all beta blocker, but I would say high dose beta blocker for sure. And the answer here is, these are individuals who, how do they maintain their cardiac output, right? Remember, your stroke volume normally is 70, your end diastolic volume is 100, right? So, right, 70 divided by 100 is 70% ejection fraction, right? 70 milliliters, right, times 70 heart rate gives you 4,900 milliliters a minute. That's 5 liters a minute. That's normal. In amyloid, let's make up the numbers. Give them an end diastolic volume of 50, half as small, right? Small chamber. Their stroke volume is now 35 mLs. Their EF is 35 divided by 50 is still 70%. They got a normal ejection fraction, right? But their cardiac output, even if they went at 100 times a minute, right, is 100 times 35. They're delivering 3.5 liters of blood as output. How are they maintaining their output? Because they got a heart rate of 100 or 80. You start slowing them down, their blood pressure falls, they don't like that. That's how they physiologically maintain the state. They're in a state of, I would call it, subclinical cardiogenic shock. The one good news about TTR amyloid, no doubt good news, right, is it's a very slow and indolent disease. These people have had this disease at the time you've diagnosed them, even if early, for 5 years. It's been percolating in their body. In the ATTR ACT trial, we had patients whose average age was 75. Their average NT-proBNP was 3,000. Their troponins were elevated. Their stroke volumes were 45 mLs, so their stroke volume indexes were 25 mLs, right? And their wall thicknesses were 17 millimeters. What was their New York Heart class? 2. Why was it 2? Because this disease develops so slowly that these people can acclimate in a big way. So a lot of messages there, but they need a faster heart rate usually to maintain their outputs, and they don't usually like beta blockers very much. The most important thing I do to a patient that I see when I first see them medically is if they're on carvedilol, I wean it off or shut it off. It's a vasodilatory beta blocker, and I put them on a bioavailable loop diuretic. They lose 10 pounds, their heart rate goes up, and they feel like normal again. And then they realize, I'm not the greatest doctor in the world because I don't have any more tricks up my sleeve, a few weeks later. But they're like, they do feel a lot better. So that makes sense? Yeah, totally. They behave very differently than HFpEF patients. Once you start seeing enough of them, it's very obvious. I mean, the BMI thing I told you is not unimportant. They're almost never fat. I mean, I see a patient who comes in my office who's referred in with a grade 2 PYP scan that's been planar imaging, and their BMI is 35. My antennas are up that this is not amyloid, right? And it's just not. Like I can look at them and go, I'm pretty sure when we do our PYP here at 3 hours and we do SPECT, you're going to not have amyloid. And I start talking to them about, you may not need that tafamidis or what you were taking, kind of thing. So screening's great, but you don't want to misassign people to a disease that they don't have, because this has emotional consequences, financial consequences. Eric, last but not least. Okay.
So thanks, Matt. You mentioned the orthopedic data,
Yeah.
but the other interesting thing anecdotally that Dr. Rosenthal and I have been talking about, and actually Dr. Grogan up at Rochester, is that a lot of these TTR folks seem to be in their premorbid lives very athletic. All-American football players, black diamond skiers, 60-year-old mountain bikers. So 2 questions. One, do you think that orthopedic issues is somewhat is a relationship to the fact they've led athletic lives? If you believe that observation is sort of genetically true, then I have a separate, different question.
So, Dan Judge also described data similarly. So I give you the thoughts. One would be it's a little bit of a fluke. Those are the most active people in the world, and as soon as they can't run as far, they're on top of it and running to see you, and so they're just more vigilant. That would be, therefore, it's not an association. I do believe it, though, and the reason I believe it is a guy in London, Bellotti, who basically has shown, well, how does TTR misfold, and dissociate? And certainly if you have a variation in TTR, it basically falls apart a lot easier. But the kinetic stability assays that Jeff Kelly, who invented tafamidis, has developed don't show that TTR is much less stable in wild-type patients than normal controls. We've published it. No one seems to pay attention to it. There's no doubt that if you use tafamidis, you'll prevent the disease. So one other way you can, break up TTR is by shear forces, proteolytic enzymes, and so forth. So one hypothesis is that the organs that it goes into are ones that there's a lot of shear forces and motion. Your heart's beating all the time, so maybe you're shearing TTR. Aortic stenosis, the blood's running through there, maybe you're shearing it. And the other part of your body that you move a lot is your joints and your ligaments. I personally think there's probably an epitope, something in those tissues, like in the ligaments and also in the heart, that attracts TTR. So if someone was interested, smarter than me in biology, they could take out those tissues and try to find, I bet there's something that kind of brings TTR there. Because TTR is made in the liver, right? And almost none of these patients, no one gets liver involvement. So why is the liver able to handle it and other tissues not? But it's a great question. A lot of athletes, though, I do see that, yeah.
So as the number of TTR patients grow, as we make these diagnoses, how do you imagine we're going to sort of triage out these patients to those that are going to sort of the tertiary referral amyloid centers versus the amyloid programs that hopefully will become more widespread as we're showing, here in Arizona, there's interest, a lot. I mean, I'm shocked that in a great way that so many folks from around the valley are here, and then, back to the role of the primary care doctor. So after the diagnosis of TTR is made and we start treating it, where do you see all the roles of those different groups of folks?
Yeah, it's a great question. I mean, look, if we're right, there's going to be, hundreds of thousands of wild-type TTR patient, right? I mean, like I said, on autopsy, it's 20-25% of 80-year-olds. If you started, 80-year-olds are the fastest growing segment in the worldwide population I mentioned. I mean, so it could become overwhelming. I think I don't have a good answer. It depends upon your local resources. It depends upon what their needs are. Clearly, they need a heart transplant. They're not going to go, except to the center of excellence. I mean, I think some of these therapies that are coming soon are, patisiran would be great, but it's pretty complicated. IV infusions every 3 weeks. Could you imagine? I have 840 people as of last week on tafamidis. I mean, can you imagine if 400 of them wanted to get IV infusions of patisiran every 3 weeks? I need like 40 nurses to put the orders in. I put orders in for 10 patients in the Apollo B trial. I spend, so it could quickly overwhelm the healthcare system. And I think that's part of what people, I think appropriately in your state are discussing, which is this is only going to become a bigger and bigger part of healthcare. How do we organize ourselves to best take care of people? It's not rocket science. I'm not a very brilliant guy. So it's pretty, certainly the TTR patients, I think, are the ones who could be cared for by community providers most of the time with some advice and counsel if need be, a visit once or twice a year with a amyloid center, but they don't need day to day, especially in the course of the illness. They basically, take tafamidis, take a little bit of a diuretic, and they live pretty functional and healthy lives. Someone asked before, like, how much does it prolong life? It doubles their lifespan at this point. People used to be dead in 2 years, 2.5 years. People are now living more than 5 years. So while I'm ticked at the pharmaceutical companies for cost charging too much, and they know that, they certainly, they could argue, and they do, that this is much more effective than, chemotherapy that we give people to prolong their life by a few months. That doesn't mean two wrongs make a right, where every drug costs too much, but I get that argument. This is pretty amazing treatment therapy for these folks.
I think that wraps up our Q&A. Dr. Maurer, thank you so much. So Dr. Vijay has assured me that he'll have the last word today, so I'll be brief. First of all, this event couldn't have been possible without all the help we've had here at ASU and from our partners, our speakers, and all of you as attendees. I do want to single out April Johnson. She's been my right-hand person in organizing this. In addition, Stephanie Calderon, Nicole Hernandez, Craig Woods, my colleague at IFH, as well as the staff here at ASU Health Futures and our Livestream team. And Matt, I really want to thank you. I think I can't imagine a better person to come out to really kick off this effort in Arizona. And I have to say, I think we were really lucky to get you, and it's really a pleasure to have you here. And in fact, I have to say, I thought your slide deck was a little long until I heard you start speaking, and I've never seen someone go through so much so quickly, so effectively. So that was amazing. I wanted to say that, but I'm glad you said it. I do disagree with your statement that cardiologists are not the sharpest tool in the shed, but otherwise I agreed 100% with what you said. And, a couple observations struck me that, we talk about community, and I think this is really a good example of our community coming together. We have Arizona Heart Foundation sonography students here, and that was really kind of a bonus, so thank you. We have, practitioners from primary care, from geriatrics, we have advanced practice providers, we have pharmacists. We really have so many people that I think, haven't seen in one place. And furthermore, we also have great specialists. I think I probably learned the most from our pathologists, our neurologists, our hematologists. I think for me as a cardiologist, it was really extremely instructive, and I think I've never had that, as well as our primary care representatives. And so, in this world of Zoom and post-COVID, it's so refreshing to be, in the room with people. And, just a couple of housekeeping. We will have everything available online on YouTube. CME credit will be available if you fill out the survey. So here I'll turn it over to Dr. Vijay.
Yeah, great. Yeah. Hey, thank you again. Thank you. Sandesh already summarized and really appreciated everybody's input. Of course, the input from all the faculty members has really been phenomenal, and all the principles are now hopefully getting embedded into our DNA, right? I mean, it's phenomenal. So give all the faculty members a big applause. And of course, applause for the audience here and also the people who are online that Sandesh already met. So give them another round of applause, because without you, it wouldn't be possible. We could declare a war if nobody came. It won't mean anything, right? So and then thirdly, of course, I want to thank and appreciate what Sandesh has done. He's done really aligned all the dots and crossed all the T's and really delivered something phenomenal and brought this program to fruition. So give Sandesh a big hand. And finally, I always believed that, being lighthearted, prevents you from heart attacks and strokes. So that's been my philosophy and principle all my life. So be lighthearted, joke around, and have fun, and do this and do that. And I thought that I was doing pretty good in my practice and engaging patients, like Matt said, that the patient's voice. I wrote a book, about my own patients and through my life, calling Invoking Your Inner Therapist. That's the title of my book. I wrote it recently in heart failure, and for the lay community and for everybody. And I thought I was doing a pretty good job. And I had this patient who had diagnosed with amyloid and had, severe aortic stenosis, 84 years old. And his wife had died 10 years ago, and he had severe aortic stenosis. He has a loud murmur. He's waiting for TAVR, and he's hard of hearing. And so he'd come to see me, and he's waiting. And so I see him in the mall. I never go to the mall. I said, no, I want you with me. You've got to go something. I said, okay, I'm going to the mall. Suddenly I see this 84-year-old guy with a beautiful young blonde, and he's on the other side of the mall, and he's like waving to me. And the doctor, then a week later he comes back to see me, and he says, I look at him and I say, you're doing pretty good for yourself, aren't you? And he said, yeah, doc, I'm following your advice. I said, following my advice? And I'm like, suddenly, I said, what did I say? He said, well, you said, get a hot mama and be cheerful. And suddenly it occurred to me that between my accent and his hearing, it got lost in translation. I said, get a hot mama and be cheerful. No. I said, you got a hot murmur, be careful. Again, thank you all for coming. Be lighthearted, have fun, have a fantastic day.